Yeah.
Start.
Happy morning. So, greeting from Micro Eras. I'm truly delighted to welcome each and every one of you for the sixth ENTrain workshop. Today marks the sixth ENTrain workshop and is an exceptional occasion for medical professionals from various disciplines, coverage to share the knowledge from expertise and innovative practice in the field of ENT surgery. This workshop serves as a collaborative learning where we can aim to foster a vibrant exchange of ideas. We at Micro have gathered some of the finest minds in the ENT community. Our sincere thanks to our mentor, Dr. Deepak Haldipu, for putting it together. Legends like Dr. Satish Jain, Dr. Janaki Ram, and Dr. Vishwas and Dr. Tushar, who will be in action for live surgery. And our moderators, Dr. Bharti, Dr. Sharnu Mali Patil, and Dr. Manoj, will be in action and ably assisted by a team of chairpersons and panelists. So this 2 days workshop is going to be academic feast, and I request all participants to enjoy this feast across the country. We have 1,500 odd registrations, and it is going globe, not only in India and many parts of Nepal, and even in Malaysia. We have faculty members and postgraduates across the country are sitting and watching live these legends in action. So I'm sure this is going to be a 2-day academic feast, and it's none other than Dr. Deepak himself is going to start the program. And so wishing you all good luck and have a happy learning. And I'm handing over to Dr. Manjula.
Good morning, everyone. Once again, welcome to all of you for this academic feast. This is the sixth ENTrain workshop we're having, and thanks very much for making the all the five successful. Is it full now? Yeah. So before, this has been done in collaboration with Trustwell Hospital and Micro Knowledge Academy. Before we just start, I thought very briefly about Microlabs. Microlabs established in 1973. It is a multifaceted healthcare organization present across the entire pharmaceutical value chain, from research and development to active pharmaceutical ingredient, finished formulation to marketing and distribution, India as well as overseas. We are ranked among the top 20 pharma companies in India. Microlab has more than 22 specialty divisions with a wide product range, having over 6,000 dedicated field force promoting our products. We have 14 world-class manufacturing facilities which are approved by all the regulatory bodies of the world, which includes US FDA, UK MHRA, Health Canada, WHO, TGA Australia, MedSafe New Zealand, with more than 2,000 qualified technical personnel working here. And Microlab has its vibrant presence in over 50 countries, which includes US, many Europe, Germany, Southeast Asia, many countries across the world, and exporting formulation and APIs in all major therapeutic segments. We have 3 R&D centers with more than 400 experienced scientists working with us. And we have an educational foundation called GDA Foundation, which runs Surana Co-Group of Institution and Surana PG Center in Bangalore. Srimati Paribai Chunilaji Surana Charitable Trust runs 2 magnificent temples, one is Sushil Dham and Mata Dham in Hyderabad. And I'm happy to share that Microlab is celebrating 50th years this year. And I thank each one of you for making this happen, and we request your continued support so that we'll be celebrating the next milestone of 75 years. Thank you so much for all your support. And quickly to all the activities on Microlabs involved in some of the activities on the scientific front. We have a e-library which is available for all doctors. It is a one-stop digital access to all doctors on scientific presentation, specialty-specific newsletter, latest guidelines on all therapy areas, infographic on patient education. So it is just a free, so please log in to use this facility. And we have Fever Foundation, which is a very noble initiative, which is done only exclusively to manage the fever, all the challenges in making the fever, how to manage them, and how to kind of analyze and diagnose and manage all aspects of the fever management, and a very unique platform where pediatrician, internal medicine, infectious disease, critical care specialists, oncologists, epidemiologists, pharmacologists, microbiologists, so all specialty who manage fever under one platform in Fever Foundation. So ENTrain workshop, which you have been seeing, which has completed 5 successful events. Now we are with the 6th, and it is a live surgery from renowned surgeon. We have to thank Dr. Deepak Haldipu sir for having made this possible, and Dr. Vishwas sir, and Dr. Jain sir, and Dr. Janaki Raman, and all the legends who have been helping us in conducting these surgeries. And we have Hypertension Foundation of India, dedicated for supporting educational, like academic activities in the therapy areas of hypertension. We have 2 exclusive studies undergoing: in-home BP monitoring study. This is done using 1,500 doctors. We are expecting 10 lakh BP readings across 18,000 patients and 54,000 family members. Then hypertension registry, we manage hypertension registry on the epidemiological data of hypertension. Coming on to book, Microlabs brings out lots of books, and some of them we brought about book in cardiology and type 2 diabetes book. It is our flagship book. We have been doing it for the past 20 years. Then Fever Foundation brings up a lot of books. Every year 2 books comes out, one for pediatrician, one for physician, basically one for pediatric children, management of fever in children, management of fever in adults. So we have bought about 13 books at the Fever Foundation. And diabetic front, we have bought also therapy books like glycoside. And in the ENT also, with the support of all our well-wishers, we have brought about current concept in otorhinology. So coming to today's session, the 6th workshop. So lots of newness in this, and you have to learn from the legends. We have legends with us, with Professor Dr. Deepak Haldipur sir from Bangalore, Dr. Satish Jain sir from Jaipur, Professor Dr. Janki Raman sir from Trichy and Dubai, Dr. Tushar Kanti Ghosh from Calcutta, and Dr. Vishwas sir from Bangalore. So they will be doing the surgery. Basically, this activity is for education and done under the aegis of Microknowledge Academy and the Trustwell Hospital. And this is the agenda available to you on the platform. And if you have the agenda, you can see them very briefly. We have 4 surgeries, live surgery planned today. First by Dr. Deepak Haldipur sir, then adenoidectomy and tonsillectomy with ablation by Dr. Tushar Kanti Ghosh. Then we have extensive angiofibroma with intracranial extension from Dr. Satish Jain sir. Then pediatric septoplasty from Vishwas today. And tomorrow we have rhinology and skull-based surgery from Professor Dr. Janki Raman sir. And we have 3 panel discussion in this ENTrain. Today we have one which is on CSF rhinorrhea. Dr. Sharnamali Patil will be moderating it. Tomorrow we have 2 papillary and follicular thyroid tumor moderated by Dr. Bharti ma'am, and one more panel discussion planned today, which is sudden NSHL and auditory spectrum disorder by Dr. Manoj Manipur. Apart from that, there is a certificate course which is available, so you can go on to our platform, do this certificate course. So we have International Centers of Excellence doing this course. One is that Suturing Basic Skull by Professor Dr. Rakesh Kumar from All India Institute of Medical Sciences, New Delhi. Then olfaction analysis by Dr. Andrew Swift from UK, and diagnostic silendoscopy from Dr. Srinivas Murthy from Bangalore. So this you need to get onto the platform, get onto the certificate course, and complete the course to get the certificate. So with this, I thank you, all of you, for patient listening. And now, before I hand over, I would like to introduce our chairperson for the first surgery, which will be done by legend Dr. Deepak Haldipur sir. To chair this session, we have Dr. Sanjay Agarwal sir. Sir is the national president of AOI in 2016 and scientific chairperson Asia Oceania ORL HSN, then IOCON 2019 Hyderabad, and then a national scientific chairman for IOCON 2020 Nagpur, and he's delivered talks and demonstrated live ENT surgeries and sinus surgery at national and international. Dr. Sanjay Agarwal sir, welcome to you. Thank you very much for accepting to chair the session. We have the second chairperson, Dr. Shalaluddin. Dr. Sharafuddin sir is a senior consultant ENT and head and neck surgeon from Ascent ENT Group of Hospital in Kerala. He is empowered committee member of Intergovernment Kerala Government Deafness Prevention Program, and he is also involved in a lot of government programs. Another one to name is he is an employed cochlear implant surgeon for Kerala State as well as Central Government of India. He is an executive committee member of prestigious Association of Indian Society of Oral. So, Dr. Sharafuddin sir, once again welcome to you, and thank you very much for accepting me as chairperson. Then we have Dr. Chauhan sir. Sir is MSc ENT from MGM Medical College, Indore. He's a senior ENT surgeon, president of AOI Indore branch 1998. He's presently also holding the post for second time. Sir has been the organizing chairman of All India Institute of, All India Conference, that is IACON 2018, which was held in Indore. So, sir, thank you very much for coming in and accepting and being the chairperson. Thank you so much. Now, I hand over the session to our chairperson, Dr. Sanjay Agarwal. So, over to you to continue the session. Thank you very much. Yes. Over to you, sir.
Hello.
Yes, sir. You're
Good
on.
morning, everyone. Yeah. Good morning, everyone.
Yes, sir.
Hello. Mic on
Dr.
camera.
Deepak, good morning.
Yeah, mic. Hello.
Dr. Chauhan sir is here.
Am I audible?
Hello.
Yes.
Yeah, very much, very
Ah.
much.
Morning, Sanjay bhai. I think shall we start? Sharaf, hi. Sharafuddin.
Yeah,
Yes,
good
please
morning.
start,
Good morning, sir.
Hi,
Yeah,
hi,
good morning,
hi.
sir. How are you?
So, Sharaf,
Good morning, Dr. Aldipur. Good morning,
Arey.
and everyone.
good morning, President Saab. Good morning.
Yes, sir.
Sir. Thank you, sir.
I think I can start.
Yes,
Yes, sir.
At the outset, I welcome all the delegates to Micro Knowledge Academy. And we have been doing this course every year. My first thanks to Mr. Dilip Surana, because he has been a big inspiration. Every time I meet him, we talk. Truly, this is a knowledge academy. Number two, the Heroes Division, with whom I have very close contacts. Late Pradeep was very close to me. He has been replaced by Durga Prasad, who has become even little more closer. Dr. Manjula and all, I feel like I'm working at home. The second important thing is, again, after some time, we've got the two big stars together, Satish Jain and Janki Ram. No amount of praise is less for these two people. They have taken the ENT scene to a different orbit, internationally and nationally. And I'm very happy that both are a part of that. Number three, the Indore division of AOI, which is going through a resurrection and blitz of activities headed by Sanjay Agarwal, Chauhan and Navneet Jain, they are here. Sharafuddin is one man whom I've always admired in Kerala because of the excellent ear work he does, the nasal work he does, very good surgeon. And I like that he's extremely polite, always smiling like me. He keeps smiling without any reason. That's a very good quality.
Thank you, sir.
Pal is here, my team, Vishwas, Akshay, Naveen, everybody is here. Every program we should have an invocation. And I love to do the invocation. And that is this case of FES. Thousands of people have demonstrated before in thousands of ways. Still, there is always something new out of the ordinary. So let me start with this case. It's a 50-plus man who has been having nasal polyposis for the last 8 to 10 years. I am not one of those who believes that the moment you see a bilateral ethmoidal polyp in your OPD, you should operate. I manage them with oral steroids. If they are doing well with pulse steroids twice a year, then I don't operate many for 10, 15, 20 years. The day they stop responding to medical treatment, I think of doing the surgery. So this man, I think, has been with me for 12 years. But last 1 year, the mistake he did was he kept on swallowing deflazacort whenever he had a symptom. So now he is no longer responsive to deflazacort. So I have posted him for surgery. It's a case of bilateral ethmoidal polyposis with AFRS. Without wasting much time, because 9 o'clock, Satish Jain is starting a huge angiofibroma with intracranial extension. My time was 8 to 10. But if I give 1 hour of my time without any regrets to one man on the planet, it is Satish Jain. Because he is my teacher and he lifted my game in my life to a different orbit. So let me straight away go into the I stand always for an average ENT surgeon. My target in every teaching program is to talk about the ENT surgeon who is in a taluka place, medium setup, access to a simple CT scan. Cut number 1, you can see the nasal bones. Cut number 2, nasal bones. My first concentration will be on the septum at the upper part, which side is roomy and which side is narrow. So, which side is roomy and which side is narrow, that is very important. So here I can see that the left side is roomy, which means I'll have more space to go towards the frontal sinus, unless do a septoplasty in between. What is more important is look at the frontal sinuses first. In India and many countries, you can have patients who don't have a developed frontal sinus at all. If there's a total agenesis or a hypoplasia of frontal sinus, trying to open that up, you can always create a CSF leak. So in this patient, I can clearly see that the frontal sinus are fairly well pneumatized. The nasal bone in its, the septum in the upper part is deviated to the right. The moment I go here, I can see that there is an interfrontal septal cell. The moment there is an interfrontal septal cell, one of the frontal sinuses, sometimes both, would be difficult to enter. And this is not a small interfrontal septal cell, it's a fairly large one. Definitely it is compromising on the right frontal sinus, which I may find it difficult to enter. The left one probably would be a little more easier. Comparing it with the axial cut, in the axial cut, I look at the frontal beak. And you can see in this patient, the frontal beak is fairly thick, which means I need to go a little posterior as well. The septum is deviated to the right side. Now, once I go behind from the interfrontal septal cell, the moment maxillary sinus starts appearing in your CT scan, you can take it for sure that frontal sinus has started disappearing. So you can see the Kennedy's nipple at this cut. But before that itself, you see this cell. This is not frontal sinus. The moment the maxillary sinus appears, the sinus which appears in the frontal area is the supraorbital cell. And this looks like a well-pneumatized bilateral supraorbital cells. The moment there is a well-pneumatized supraorbital cell, it also means that your anterior ethmoid artery by default will be hanging on a small mesentery. The moment you have a well-pneumatized frontal sinus and sphenoid sinus and a well-pneumatized supraorbital cell, this basically is a roomy, spacious, well-pneumatized ethmoid. Like how we say cellular mastoid and sclerotic mastoids, some set of sinuses can be small and narrow, which is difficult for the surgeon, and some where the cellularity of the ethmoid is much more. So this is a cellular ethmoid and frontal, basically set of sinuses. As I go behind, you can locate the Kennedy's nipple, and the other way of identifying this is look at the orbital muscles. You can see the superior rectus, the medial rectus, and then you see a small muscle, the superior oblique. The superior oblique always points towards the anterior ethmoid artery. It is hanging on a mesentery, but luckily far more closer to the skull base. On the left side, it is hanging more on the mesentery. As I go more posteriorly, I am going towards the posterior ethmoid because the skull base W is becoming a gentle U. And here I can see the posterior ethmoid is also roomy. The lamina papricia apparently looks reasonably intact. And as I go behind further, I come towards the sphenoid. The 5 important signs to say that you're reading a scan of the posterior ethmoid: the skull base is a gentle U. The orbit, which is big, becomes small. You can see the middle turbinate turning and coming here. The bone of the superior turbinate you can see. And the maxillary sinus, which looks hexagonal or quadrigonal, suddenly start looking oval. These 5 important features tell you on the CT scan that what you're looking at is the posterior ethmoid. As you go behind, As you go behind, you look at the septum bifurcating and forming the lower border of choana. The moment this happens, once you start seeing the choana clearly from this cut onwards, you know that you have transited from the posterior ethmoid to the sphenoid. So you have two well-pneumatized sphenoid sinuses. Posteriorly, the left sphenoid is smaller, right is bigger. There's a very small onodi cell on the right side, which you can see here. Fortunately, the carotid or the optic don't appear dehiscent or bulging into the sphenoid. There's a well-defined lateral recess on both sides, which again indicates this is basically a cellular set of sinuses. I have not spoken about the disease, basically because disease is incidental, especially in polyposis. Only when you talk of neoplasms, where you require an MRI, you talk about the contents of the cavity. As an average surgeon and a beginner, your endeavor is you should learn to open all the four sinuses safely. And you should know the anatomical variations. All your life, give respect to the lateral wall because there are three important structures there: the medial rectus, the optic nerve, and the carotid artery. Once the surgeon damages one of these three structures, you can never bring it back to normal. You can salvage, but never normal. And remember, when a patient walks to you with a harmless ethmoidal polyposis, you should try not to give these three complications: the injury to medial rectus, so injury to the optic nerve, injury to the carotid. In Kannada, we say when you're focused, akade ikade nodbeda, which means never look lateral. So I don't encourage lateral thinking when you're operating on the sinuses. Keep straight. Right? Thank you very much. And I'm so happy that Sanjay Agarwal is here, who is my, what I can say, I think in a movie called Sharabi, Om Prakash, Amitabh Bachchan. I think in a movie called Sharabi, Om Prakash, Amitabh Bachchan. I think a movie called Sharabi, Om Prakash, Amitabh Bachchan. I think a movie called Sharabi. Lights are on, madam.
अरे सुनो, वहीं से हो रहा है ना ये? हेलो
Hello.
वहीं से हो रहा है ना ये?
Somebody is speaking, I think some disturbance, somebody. Sanjay Agarwal and Sharaf.
Yeah. Good morning.
I'm
Dr.
requesting
Yeah.
our,
So when the CT was taken, Dr. Deepak?
TT was taken about 1 week back.
1 week back.
Yeah.
Right. Yeah. And you had given any steroids specifically in the last 2 weeks? Just
He has,
to
he has
make
himself
you.
taken. He has himself taken quite a
you
bit of
told.
steroids.
Yeah.
But I have given him steroids last 1 week. And
Okay,
an antibiotic also.
Okay. Which antibiotic?
Linezolid. Linezolid is what we give.
Linezolid. Okay.
Yeah. Only thing is with linezolid, you have to bother about the bone marrow. I request our Dr. Jaidev to speak for 5 minutes about what he plans for anesthesia. He is our senior anesthetist, Dr. Jaidev. Yeah. Lights are Jaidev Dadmel off, madam.
Good morning, everyone.
Good morning.
Welcome to this
Debrider section, sarigide nodu.
along with my dear classmate Manjula. Hi, Manjula. Are you there?
Hi, Jaidev. Hi. Yeah.
Section sound ಏನು ಬರ್ತಾ ಇಲ್ವಲ್ಲ?
ENT surgeon for anesthesia is always high.
ಎಲ್ಲ
So he wants a blood-less field while he is operating. All we can do, all I can do is just get less blood, not a blood-less field.
Correct.
So that's the victim of anesthesia. So it's all depends on what kind of a patient you are anesthetizing, and whether the patient is an hypertensive, a young patient, or with comorbidities. So optimization preoperatively is the key to handle the case intraoperatively. Perioperative less blood field, we need to prepare the patient in preoperatively. So that happens with a well-maintained, well-controlled blood pressures, diabetes, if there is any other comorbidities. So preparation is very, very important. So the induction, all the routine induction happens as planned by the anesthesiologist. So taking care of pre-induction drugs to optimize. The most important question here is how you allow the surgeon to infiltrate the local anesthesia along with the adrenaline into the field of surgery. So there are various things the different surgeon follows here. Some do dilute the adrenaline mixing with the normal saline and they directly injects. And there are some using with local anesthesia and a prepared local anesthetic with adrenaline. I believe the local anesthetic with adrenaline is the best because the local anesthetic which is there is going to have a protective against the cardiovascular complications caused by the adrenaline. So it's the allowable dose for adrenaline in any patient is 5 to 10 micrograms per kg. And it's also important what concentration you are going to infiltrate the local anesthetic before the surgical procedure starts. Normally, our local anesthetic is available 1 in 2 lakh concentration. So my advice, and over the past more than 25 years of anesthesia practice, I always advise my surgeon to dilute it into one. Infiltration anesthesia doesn't require 2% of the lignocaine. It's enough to have a 0.5% or 1% is enough to give a good infiltrative anesthesia. So when you take up according to the body weight, suppose for a roughly, I will give you an example. So you want to infiltrate, you have to take some 2% xylocaine with adrenaline, that is 1 in 2 lakh concentration, and you mix with equal amount of saline. So that makes you 1 in 4 lakh solution, which is the safest as a concentration. So it will give you a very good field of bloodless field for the surgeon to operate, and it's also safe for the patient, not allowing it to go to hypertension or cardiac arrhythmias. We always use as a inhalation anesthetics which have an interaction with adrenaline, and it can lead to dreaded cardiac arrhythmias intraoperatively. So the safe is to use xylocaine with adrenaline 1%. So that makes you 1 in 4 lakh concentration of the adrenaline, which is very, very, very safe. And also it gives a good field, bloodless field. Rest of the things, we will manage the patient in the intraoperatively having a triad of anesthesia, that is amnesia, analgesia, and relaxation. If you follow these 3 basic principles of good depth of anesthesia, and the patient will never buck intraoperatively and cause increase in the blood pressure or tachycardia, and the field of maybe not conducive to the surgeon, operating surgeon. So if we manage these 3 things, the field will be good. As you, by example, now you can see my patient with this 70-year-old man having a heart rate of 80 and a MAP of 65 blood pressure. And I think surgeon is going to enjoy this today's surgery with this kind of
situation that I have a 70-year-old hypertensive and diabetic. Over to Dr. Deepak.
Yeah, Sanjay Agarwal. Sharaf is there.
Yeah,
Yes,
yeah,
Deepak
yeah,
bhai.
yeah, yeah.
Sanjay is there.
Yes, sir.
One dialogue mera chale gaya, you know. Sanjay Agarwal for me.
Yes, sir.
I'm not able to hear somebody
Some,
there.
some echo is going on.
Paul
Some-
teams, Dinesh, Paul team, can you check where the echo is happening? Can you fix
Some
it up?
echo is going on.
I think there's a double echo there. There's a double.
Yeah.
Iska echo yaar dodo. Hello.
Sanjay sir, I think you should move from the venue where you have to sit in a separate room because you're coordinating from there. You have to sit in a separate room because others are also watching live from there. Echo will have.
Let me start.
The surgical field is, the endoscopic picture is beautiful, Dr. Deepak.
Yeah.
Yeah, it is very
Yeah, yeah, yeah.
beautiful. Yeah.
Always my debrider first will always look up to the God. I look up. You know. First is to try and take a, see, because I have been a private practitioner all along. So I always look at patient relief. Patient has come to me with nasal obstruction. So I would like to first give him a little airway. So even if I leave a little polyp, he should still be breathing better than pre-op. Then, you know, he's likely to settle my bill.
So you infiltrated already, sir?
Yeah, I do infiltrate a little bit into the polyp because the
Okay.
polyps are avascular structures. So you are getting a clear picture, Sharaf?
Very, very clear, very clear, very clear.
Okay. So basically better to go below upwards and initially anterior to posterior. Once you clear the first half, maybe you can go posterior.
So you will take the biopsy from little
The upper
posterior.
part
not-
I'll come
yeah.
a little later. I will take a biopsy, but not anteriorly.
Yeah, correct.
I will look at something which looks vascular. And then you can take a biopsy. One for safety, patient safety. Second for medical legal reasons.
And regarding the anesthesia, no, you also give the 1% silocaine, that is 1 in 4 lakhs, right, sir? Or you a pre-prepared one?
I make a fresh solution which was taught by Dr. Madhavaya. So we take basically about 10 ml of 2% xylocaine and we add 8 to 10 drops of adrenaline on a 20, 4-gauge needle. I make it freshly prepared. I don't use ready mix. Somehow Madhavaya sir told me freshly added adrenaline always works far
Better than the pre. Yeah. But
My
we have tried all.
Satish,
Yeah.
My mentor Satish and the superstar Janki both have stopped giving injections.
They have
frank adrenaline. Yeah. I still continue to give injections in select areas.
And the topical pack, you prefer only plain adrenaline, not with dilution.
In the
topical.
No. Again, I use 5 ampules of adrenaline in 30 ml of saline or 4% xylocaine.
Okay.
I don't use undiluted adrenaline, no.
Okay.
Somehow, I don't know, I'm still a little scared of using...
but we use unless the patient has not very comorbid, especially the coronary artery disease, very old patients. Otherwise, young patients, we directly pack the nose with 10%. The adrenaline.
So, I don't think it's anything wrong.
Yeah, even children we use.
I have been a little lucky so far that I have not had much of oozing. In my cases with 5 ampules, the work is going on. So I am just using the same thing. But I think, as you correctly said, unless there are risks, you can use now frank adrenaline. See, Sharaf, now we can see the koina.
Yeah.
See, for me, this is important because when you breathe, Second, the moment I see the upper border of Koina, I
Yeah.
can always locate the sphenoidal ostium.
Yeah, yeah,
And it also tells me, once I open the sphenoid, the
Yes.
skull base of the sphenoid tells me what is the safest high point I can meet.
okay,
So
okay.
that's why I always like to see Koina. So I've got one landmark.
You
I've got
redefined
the-
the anatomy, yeah.
And I've got inferior turbinate, which is the second landmark.
Okay, okay.
Okay, so now we'll move from landmark to landmark. Probably this could be the middle turbinate.
Yeah. It's all
Sponge.
polypoidal, yeah.
Yeah.
And regarding the anesthesia.
What I want to tell the
yeah.
what I want to tell the beginners,
Mm.
don't remove the upper part of the polyp first.
Okay,
The bleeding will keep on trickling, it will cloud your path.
correct, correct.
See, this way, if you remove the lower part first, all the way posterior, you see, you got already two landmarks, probably three. The septum, the inferior turbinate, and the most important landmark even in the revision surgeries, which is always there, is the upper border of the Koina.
Yeah.
Many times, with just a middle meatal antrostomy and upper border of the Koina, you can figure out all the other structures in the nose.
Okay.
If you follow the basic principles. Sponge. Sanjay Bhai.
And regarding the anesthesia, the side, no, you prefer the good MAP or you prefer a good heart rate? I mean the lower heart rate for the bleeding part.
Any day. Somebody's voice is echoing.
Yeah, some echoing, yeah.
Yeah.
Maybe someone near to the OT, sir. Speaking.
ಅದೇನು ಯಾವ್ದದು ಇಕೋ ಬರ್ತಾ ಇರೋದು ಯಾರು ಮಾತಾಡೋದು ಹಾ ಅಲ್ಲಿ ಇಲ್ಲೇನಾ ಬಟ್ ದೇ ಆರ್ ಮಸ್ಟ್ ಬಿ ಸ್ಪೀಕಿಂಗ್ ಟು ದ ಮೈಕ್
Sir, indoor center. Sanjay sir is sitting with the team, I think.
Sanjay,
Yeah, I am here, Deepak.
अरे वो
I have come out of the hall.
Yes, yes, I want to tell the national delegates my friendship with Sanjay Agarwal. In Sharabi movie, Amitabh Bachchan tells Om Prakash कि
Yes.
आप तो सुनने की चीज हो, देखने की चीज हो और गोद पे सर रखकर सोने की चीज हो.
Daddu,
I know
Daddu,
you know that, yes. Kaddu,
Daddu.
yes. So I think that echo has stopped now. Probably it was coming from our audio visual here only. This is the
Yes.
other side, which I won't be demonstrating right now. So Sharaf,
Yeah.
I think the picture is reasonably clear.
Yeah, it's very clear, very good.
And as Dr. Jaidev had promised, like our Congress government in Karnataka, that the field will be good. The field is good. Like the 5 guarantees.
Yeah.
Hmm?
It's not good, it is excellent.
No.
Thank you.
If the field is good, the credit goes to Jaidev. If the field is bad, the credit goes to my clumsy dissection. Yeah.
So what would you prefer, a lower heart rate or a reasonable
heart rate.
MAP?
Any day lower heart rate. Lower heart
Okay.
rate. First important thing, lower heart rate. And I don't do under local, I'm opposite of Aila Swami. I do even my myringotomy grommet under GA.
Okay.
Okay. Yeah. Now I'll remove this polyp between the, very close to the.
And snake and the middle term. Yeah. Yeah.
The bottom line is try not to touch the normal mucosa.
Correct.
Try to remove the polyp only. Try to stick within the polyp.
You have prepared the patient very well. The bleeding is very, very less. Of course,
Yes.
anesthesia part is there.
Yes. Yes. In Kannada now there is a statement, ನುಡಿದಂತೆ ನಡೆದಿದ್ದೇವೆ. And Jaidev has done that. See, now I am removing the polyp bit by bit. So in extensive polyps, as you keep on removing the polyp, Dr. Sanjay, the landmarks will appear by themselves.
Yeah. Many times the ostia will be widened by the disease, so it will be easier for us to
Yes.
see the ostia.
Yes. The disease itself will lead you to the ostia.
Yeah,
Absolutely
to the ostia,
correct, Sharaf.
Yeah.
I think, Papa, they have put Sanjay outdoors, so he is not hearing us fully properly. I can see the intent with which he is seeing. I am working now in the area
Yes.
medial to the middle turbinate. The whole idea is if I do that, then the middle turbinate will get a little lateralized, and see, it will give me more space.
Yeah.
It is already flappy because of the polyps.
Yeah, it is unstable. Yeah.
I may take it out in the end. Now, my first endoscopic guru, Dr. Tulsi Das, and my friend Vikas Agarwal, they believe in this concept of ethmoturbinals. And they remove the middle turbinate in the beginning itself in these extensive polyposis. Because one, they feel the recurrence rates are low if you remove the middle turbinate. And number two, if you remove it in the beginning itself, leaving a top stump, you are still keeping the landmark, and your further dissection becomes easy. Sponge. So far, so good. Now don't put it in the gauze. Then solution will all go to the gauze. So squeeze it well and just give. So Sharaf, I have been using the same 5 ampule adrenaline stuff.
Okay.
Undiluted.
Yeah.
So if the field is this much, I'll keep it that way.
Yeah,
but I'm definitely sure in an occasional case where I find a lot of oozing, I will not hesitate to use undiluted adrenaline.
Yeah.
Right?
I don't know what is opinion of Dr. Jayadev, the anesthesia doctor, about the keeping topical adrenaline straight away without dilution.
Straight undiluted.
So we use right and left and right, but I don't know. Yeah.
Yeah. Morning. There is always a controversy between the usage of adrenaline by the surgeon and the anesthesiologist. All is well that ends well. Okay. If there is a complication, then how to manage? What are the remedies? It's the rapid. Always this adrenaline is a debatable question with anesthesia and the surgeons. I would stick to my rule. He would stick to his rule. So let us something which controversial still going on. They say that you use so much nothing has happened. But when it happens, I should be able to manage the case. I should be able to bring the patient to the normal. It can happen. It is always, let us remember like this. It's not only the drug, where you inject, the amount of injection, and the rapidity of injection. All come to the concentration of the drug. So we manage this balance, nothing goes wrong. See, the same amount of safe drug, when it is injected rapidly, it can have a different effect.
This is not regarding the injection, Dr. Jayadev. We are asking just the topical, whether we used to keep lot of topical adrenaline directly in the nasal mucosa. So not the injection. 1 in 1,000. The ampule itself we just keep without dilution. Topically.
Submucosal absorption.
Yeah, that's what.
Whatever they see the amount of whatever he says that 4 ampules, 6 ampules, it has come in the dose of in a saline, and it is soap gauze piece put in on the mucous membrane. So the amount of drug which is absorbed to the body is always very, 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 very less. So that is how it is a safe game. It's going on. So I cannot, because they have experienced it. And
Yeah.
I'm only when they infiltrate. The
Yeah, that's what. Infiltration is the.
You will have a immediate effect on the patient, and I will have to manage the case. So whereas the adrenaline soaked gauze is going to take a lot of time, and it has not an immediate effect on the patient. Whether you can see now he says he has used the same concentration of the adrenaline for the packing, whereas I am talking about the when he
infiltration. Yeah, correct.
Infiltration is the one which is going to bring an immediate effect on the patient. And
yeah, correct.
There where I have to be careful, and he has to be careful. Okay. So it works well actually. There is as long as he maintains the infiltration anesthesia with the local with adrenaline, that the amount, that rapidity, or the place where you always withdraw before injection, the simple rules of infiltration anesthesia, it will always go well.
Now we have reduced our infiltration to the nose very, very less. We rarely infiltrate now, as Dr. Deepak sir was telling. Now we mainly depend on the topical application of the
application of the adrenal.
We have reduced our injection because of the fear and because of the things we were discussing.
That should do well.
So
yeah.
Thank you.
So Sharaf.
Yes, sir.
So now this could be probably the portion of the uncinate or whatever.
Uncinate, the junction of the horizontal and the vertical angle almost.
And as Satish Jain says, the only mobile part in the lateral.
The lateral wall is the
uncinate.
Yeah, correct.
So probably keeping myself a little low at the upper border of the uncinate.
Yeah.
I'm trying to probe because the extensive polyposis case.
Yeah.
Like to use the
curved ball probe. Yeah.
Yeah. So I would like to just go like this.
Yeah.
Keep pushing. This looks like the maxillary opening. So maybe I'll use the debrider rather than going into the turbinate further down.
Correct.
Debrider. Again, I'm not facing the lateral wall.
Yeah.
I'm just keeping the face of the debrider.
Yeah.
See, you can get a look now.
Yeah.
At the maxillary sinus. Yeah. So this makes me a little comfortable now.
Correct. When we saw this, when we saw the CT scan, it's an extensive polyposis. We were afraid of lot of bleeding and all, but you have prepared the patients very well, and the anesthesia field is excellent, anesthesia side is excellent, and also the dissection, the surgeon part, that is the most important.
Yes.
You're doing a wonderful job.
Very meticulous. So again, initially I try to do most of it with a 0 degree. For beginners, it's a lot easier to use the 0.
Correct.
Then they get used to 40 degrees. So we have one more landmark now, Sharaf.
Yes.
Yeah. And see, this clearly shows it is such a medical disease. 1 week of steroids, look at the mucosa and the polyps within the nose.
Yeah.
Isn't it, Sanjay Bhai?
Yes, sir.
Yes. So this probably is the portion of maybe the lower part of the bulla, because I'm really not able to make out. Probably, 45-degree forceps.
Could very much medialized uncinate, polypoidal medialized upper part of the uncinate.
Yes. So when I use this, I always use the twisting movement.
Yeah.
Okay.
You prefer Blakesley or the true cut to take the remaining part of the uncinate?
True cut would be the ideal.
Yeah.
But even true cut after 7-10 cases becomes Blakesley.
Correct.
especially if you use it on patients with neoosteogenesis.
The only thing is that you have to turn the Blakeslee like that. You never pull
Yes.
it. Yeah,
Yes.
exactly what you are doing.
No,
That is the one
the
thing.
twist.
Yeah,
The twist is
Yeah,
so
correct,
important.
correct. Very important.
You know, because in college I never could learn the twist dancing, which was very popular at that time.
Yeah,
So
even at that time. Yeah.
yes. Okay. So we are kind of, see, if you notice, the bulla seems to be involved by the disease.
Yeah, correct.
What I saw here and what I removed was actually the destroyed anterior wall of the bulla.
Yeah, looks like, yeah.
Yeah. Debrider. Saline ready, it comma. Sanjay always gives me, some critical advice in my demonstrations. So I irrigated once already. I will irrigate it. He tells me, बीच में आप दीपक भाई irrigate नहीं करते हो. So that is one of my, probably limitations. This is the posterior part of the middle turbinate. Sharaf, you agree that we have defined the middle turbinate reasonably well?
Yeah, yeah.
Even the posterior, and see, now I have defined it.
Yeah.
Okay. I have removed the polyps there. And
But that was really a big teaching for all the juniors. So redefining your anatomy, especially extensive polyposis, like you could have noticed what Dr. Deepak sir delineated the choana. So that is very important. You know where is the length of the depth of your nose, and also the middle turbinate. Then of course the lateral wall. So you have to go one by one like this. Then you start removing the polyps in bulk.
And see, these polyps have gone through and through here.
Yeah, perforating the middle turbinate here.
Yes. Yeah. Do you use hot saline or warm saline when you're washing, Sharaf?
I use saline washing. Initially I used to
give me the
use
irrigation,
hot saline, but many times that is not happening now. So saline irrigation, plenty of saline irrigation. That is the main trick. Yeah, so that you need not take the scope again and again, and also your field is always clear. And I don't know, even the washing itself reduces the bleeding.
Yes. Needle. No. I'll wash. So I have 3 more sinuses to look. I'll widen the maxillary ostium much more later.
Yeah.
Right now it is good enough for my landmark business.
Yeah.
So later on I'll widen it much more later.
Usually we take a polyp from each side for the biopsy.
Okay. So I look at the suspicious areas or whatever.
Yeah.
I think, in Kerala you have to really play it safe.
Yes, sir.
Probably a time will come when you'll have to remove all the polyps and like how we do it in papilloma.
Yeah.
Karnataka is still not that dangerous.
But you have a lot of Kerala patients too, no?
They are nice here.
Yeah.
All the people, when you take them out of their natural habitat, they're more diplomatic and hardworking. Our Kannadigas also. It is true with everybody.
Yeah.
Isn't it?
Yeah, it's correct.
If you go to Dubai, for example,
the
most hardworking people are the Kerala people. You agree?
Sure. That is why I know the
Bengalis, even Karnataka people. When you migrate somewhere, I feel you are far more. It's a natural human tendency.
In general, all Indians are hardworking. In general.
Yeah.
When you migrate,
Yes.
They are more hardworking, more sincere, more committed than in our country.
Yes. Probably that home effect, home ground effect.
Yeah.
No?
Because I operate in Medcare hospital in Dubai for the last 4-5 years. I know the most of the staffs inside the OT, They are all Indians and Keralites. There are
No,
one or
Sharaf,
two Filipinos. Yeah.
Sharaf, one thing I can tell you, Sharaf.
Yeah.
India or outside India, the Kerala nurses are the most hardworking, man. Most of us owe our success to the nurses who are they are like, they never get the publicity or the attention they deserve. Without them, I can't imagine. And it is Kerala.
Yeah.
Whatever you say.
But sir, that is the story now. Now the younger generation, they are all want to take the degree and they want to fly to Canada, UK, USA. They don't want to stick on with us. That is the main issue what we are facing. The older generation were with us, but the new generation are not with us. They just want to get the degree only and some 2 years experience.
Yeah, see, because our time this 5G, 4G was not there, no, Sharaf.
Yeah, yes, sir.
We were used to trunk calls. Now the speed has improved. So obviously in everything people would, expect a trunk call. Long ball probe. Now I look for the frontal sinus.
Okay.
I don't have the typical, see, first of all, the anterior wall of the bulla itself is missing.
Yeah, correct.
What I will do in such cases, I will just show you.
Yeah.
Straight grasper.
So could you please tell me the tricks to visualize the frontal sinus in your case, what you follow?
Absolutely. See, for example, usually in a case where the bulla is there, I strongly follow intact bulla technique.
Intact bulla, correct. We all
was
follow
taught to
that.
me by Satish Jain.
Yeah.
But in this case, the anterior wall of the bulla was absent.
Yeah.
Even the middle turbinate, you can see the polyps have eaten away a portion. Can you see this?
Yeah, we can see very well. Yeah.
In this case, ball probe, the first step that a beginner should do is palpate the ascending process of maxilla. See, it is the posterior end of the ascending process of maxilla.
Yeah.
This could be remnant uncinate, little bit of polyps and all that.
Polyps, yeah.
Right now, I don't want to touch it because I don't want to damage the lamina. I'm just palpating this and go up. That becomes the frontal beak.
Yeah.
And we have seen that in this case, the frontal beak is thick. So probably if I can put my ball probe here.
Just posterior to that.
Here, this could be my frontal sinus.
Yeah.
Worst case, it could be the recessus terminalis.
Yeah.
In which case, I'll come a little medial. Straight away, I don't want to go medial because I can damage the cribriform plate. Can you see the probe?
Correct. Yeah, correct.
I don't want to go like that. I'll go a little lateral. Gently lateral, hugging the posterior border of the ascending process of the maxilla. We are already seeing some mucus coming.
Yeah.
Maybe it is Sharafuddin's luck. I may get the frontal recess here. 40-degree blade. One more irrigation, Sanjay Agarwal ke naam pe.
Yes, sir.
I will irrigate, yes. Wash. So this is what is to be done. If you are practicing intact bulla technique and you find that the bulla is missing, or if you are one of those surgeons who doesn't follow bulla technique, but you remove the bulla and the posterior ethmoid and then go for the frontal, then the most consistent landmark, even in the most revision cases, is the ascending process of maxilla.
The anterior beak of which forms the floor and the anterior wall. Yeah, correct.
This I learnt in Kerala. You remember Draft had come?
Yeah, to Kochi.
Our George Varghese had gone.
Yeah, correct.
Yeah, that is where Wolfgang Draft made me unlock the frontal sinus. In that area, I'm using the debrider now.
So Draft was a great teacher.
Yes, and a good friend of Sanjay.
Yeah, we enjoyed.
Sanjay at times I felt was a little anti-national because he was more close to the Germans than the Indians. Yeah, Sanjay bhai.
Yeah.
Mrs. Carl Stars called Sanjay by his first name.
Sybil. Her name is Sybil.
Yes.
Oh.
It is true. I am not exaggerating. It is true. This could be the recessus terminalis where I am putting this thing. Could be the frontal. Okay, Sharaf?
Yeah, correct. That's it. So your scope is still 0 degree, no?
Yes. I do majority of the work with 0
Yeah.
and then move to the 70.
Yeah.
Basically because an average surgeon, again, the anatomical distortions will not be there.
Yeah, correct.
You won't lose the orientation. Isn't it?
Yeah, correct.
Probably we are kind of reasonably unlocking the frontal recess with the 0 itself. Isn't it?
Yeah.
See how far you can see with the 0. Huh?
True.
Yes. Now we give some
And
irrigation.
as I always say, Deepak is a very delegate friendly surgeon.
I am a very
Delegate friendly. Delegate friendly.
surgeon. हाँ. अरे जब टैलेंट नहीं है तो फ्रेंडली तो रहना पड़ता है भाई.
नहीं वो तो हम देखते हैं talent.
No. Because 80 to 90% of the ENT surgeons have to learn with 0 degree, because many times it is very difficult to use 70 degree.
Yes.
Like Dr. Sadish and Dr. Janagi does know, it is very difficult to handle 70 degree. And many of the good talented surgeons across the world is also using only 0 degree.
Yes.
So you can do the things with 0 degree, but you may need a 70 degree. Yeah.
Up to here I recommend you do with 0 degree.
Yeah.
I can see the recessus terminalis.
Correct.
I can see my frontal pathway. I can see the pathway towards the cribriform. Once I know this, I'll feel reasonably sure in the skull base. Saline? I think now we'll look up with a 70 degree, Sharaf.
Correct. For inspection and to
You
do
agree,
the further work.
I think Sanjay will also agree that for a medium level, a beginner, a postgraduate, someone who is a novice, I feel this would be safer.
Yes,
and
definitely.
more easier to do.
Yeah, very correct.
Yeah. Sponge. Give dressing forceps. I don't want this. Yeah. So just for a minute, I'll keep the sponge here. Suction. Punch. One more sponge. But really, the instrumentations have made the surgery that much more comfortable and easier. Isn't it?
Yeah, correct.
Only thing is you must know how to use the debrider and when not to use it. That is the catch. Sharaf, how about the handpiece things? Which handpiece you are using? And Sanjay, which handpiece you are using? Because now we are no longer getting M2.
I use the old one.
Huh?
M2.
M2 is almost now.
Yeah.
Medtronic company has stopped producing that.
I use M5 and M4 both.
Okay. M5 is working well. M4 also.
Yeah, but M4 is I prefer M4 than M5. I don't know.
M5
but
is
I
a little more fragile.
Yeah.
Keeps more frequently for repairs.
Correct. And even you send for the repair, the charge is nearly 1.52 lakhs for repair after your warranty period of 1 year. and it
Yes.
takes
Yeah, it
maybe
is.
three months. It takes 3 months. The service is very poor. I don't know
Okay.
what about in Karnataka, but it takes hell lot of time to get the repaired one
No, that
back.
is true. That is true. That's why we are now keeping our Indian companies into the,
Yes.
like the companies having good service,
Yes.
So,
and also the cost is less.
yeah.
Yes. Which one?
Yeah, Serval,
45-degree forceps. Which company?
Serval.
Surveil. Okay. संजय
Yeah,
तेरा वॉइस थोड़ा एको हो रहा है. I don't know why.
okay.
शराफ का क्लियर आ रहा है. तेरा कुछ जुगाड़ करना उधर. Just see whether.
Okay.
Yeah, Sharaf, the view with the
Yes.
70 degrees.
Yeah.
Yeah. Ball probe. Long ball probe.
So you used to use the Kunz curate to dissect and find out the.
Yeah. I call it the long ball probe.
Okay. Yeah.
One end of that. Can you see this?
Yes.
It is going directly into the frontal sinus, and see there is no movement here medial near the cribriform plate.
So yeah.
So this is our frontal sinus. Debrider.
So you don't follow the cell by cell as per the CT and go to the frontal like that?
No.
Yeah.
And
especially extensive.
And in this city, what cell by cell you can go, Sharaf? No, I don't think. Maybe that is okay where the polyp has understood that, okay, Deepak Altipur wants to go.
Even I was feeling the same, sir. Especially extensive polyposis like this, no?
Yes. I think we have no doubt that this is the frontal sinus.
That's beautiful.
Absolutely, yeah. And see, following the ascending process of maxilla, thanks to Draff and George Verghese. See this?
And thank you to Kerala.
Absolutely. God's own country.
Thank you, sir.
No, honestly. You remember that course?
Yeah, I remember,
so,
sir. It was just after my post-graduation.
Frustrated about the... I think Sanjay also sent me a photograph of that course recently.
Which one?
That draft course, Kerala ka.
Yeah. Because George is now sharing. The old George recently shared the old videos and the photographs. Yeah.
Yes. So I think 2 more sinuses to go. And then finally I'll show the anterethmoid artery and I'll wind up. Sponge.
So what's your plan, sir? So you won't demonstrate the other side on a live because
No.
Dr. Satish has to start the
Because see, my original time was 8 o'clock to 10 o'clock.
Okay, now you have given
But Satish Jain requested that he's got a real big good angiofibroma.
Okay.
So probably between 9:20 to 9:30 I will wind up. So one side showing is good enough.
Yeah, one side,
The other side, the difficult frontal I could have probably demonstrated, but that doesn't matter. See, look at this, Sharaf. When I'm moving this sponge, you see the movement near the cribriform plate.
Yeah, correct.
See, the bony partition is so thin.
Yeah,
so the beginners have to be careful about this area.
Yeah, that is a very important message because the middle turbine attached to the junction of the lateral and the medial lamella of the cribriform plate. So it's very thin, very delicate, and because of the pierced by the
just the sponge movement, you see this. Yeah,
correct.
Yeah, and second, I don't want to touch this area because olfaction can get affected.
Correct.
If you can leave it as it is and give the spray, now that you opened up the area, this will recover. There's no need for a beginner to put a debrider here and try to debride these tiny polyps. You are more likely to create complication and more importantly, anosmia. So better to leave these bits here only. Okay?
Yeah.
Sponge. I think now I'll go to the posterior ethmoid. And
that's
then
right.
the
Yeah.
sphenoid.
Yeah.
And then finally, probably, the anterior-ethmoid artery.
Yeah. And as you correctly told in the beginning, it's not a surgical disease. It's a,
yes. 45. Yeah. See, trying to remove each and everything, if you give one complication,
correct.
it is not a great idea, isn't it? So whenever you use the forceps, you always better give a twist.
Because its extensive polyposis make the middle turbinate very much fragile,
this
unstable.
turbinate is going to go.
Yeah.
Sharaf, this turbinate is going to go.
Yeah.
Because it's already destroyed by the polyp posteriorly.
Yeah.
I'm just keeping it as an exercise to show the delegates how to operate even with the turbinate in place. Straight blade Hakama. I will
being an important landmark of the nose, no? So you have to retain the anterior part of the middle turbinate. That's what.
Yes.
Is where we go when they need a revision, no? Without middle turbinate, it's very easy to find out the anatomy and redefine the anatomy.
Yes. Acha, Satu is alive, is it?
Yeah, he is there.
Nawab Saab always comes a little late, na, Sanjay bhai?
Yeah.
हमेशा मंत्री संतरी पहले आते हैं
कर्मचारी
नवाब साहब का एंट्री बाद में होती है इसीलिए तो वो नवाब है ना राजा भोज एयरपोर्ट सक्शन कर्व्ड सक्शन सत्तू
वो ऑडियो इज ऑफ
अरे कॉकलियर इम्प्लांट सर्जन का ही ऑडियो ऑफ है क्या Yeah, that is the frontal Sharaf.
Yes, sir. Satish sir, you need to. Dubey sir, you need to unmute, sir. Sir, you're talking, but we're not able to hear you.
Okay. No. Good morning to Dr. Deepak sir.
अरे गुड मॉर्निंग साइलेंट मूवी बना रहा है क्या पुष्पक विमान की तरह
नहीं वो कई बार
तो ऑन करना
आपकी तरह टेक्नो सेवी नहीं हूं ना तो थोड़ा मुझे उसको भूलने बंद करने में ही टाइम लग गया अच्छा
गंगाजल और मृत्युदंड का एक्टर अभी साइलेंट सीन करने लगा ड्रेसिंग फोर्सेप्स So now I'll go towards the straight blade Hakama. Eventually, probably this will go anyway. It's just coming in the way. Sponge. Now again, as we approach the posterior ethmoid, there are two things. Number one, better to use a 0-degree blade to go towards the posterior ethmoid. Saline. And always keep the maxillary line in your view. So you keep your middle meatal antrostomy, which you should be seeing. I will show you that point now. Straight blade. Give me the one. See, this is my maxillary sinus, Sharaf.
Yes.
So this is the junction of the medial wall
and the
roof, which also happens to be the floor of the orbit. So this point, concentrate on this point, draw a horizontal line from that point, stay at this line or slightly below it. Don't go far above than this. Probably this is corresponding with the remnant inferior wall of the bulla. You can see this line here.
Yeah.
Okay. You can see this whole thing. And now, you can, straight suction, straight grasper. Satish Jainಗೆ 9:30 start ಮಾಡ್ಬೋದು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು 9:30 start. Let him get ready and suction. Huh? Sharaf, Satish wants to start at 9:30, which means we have another half an hour. So we'll continue.
Yeah, that's good.
Yeah.
That's good.
Yeah.
So, yeah.
Straight blade.
So now you will go to the posterior.
See, this is the maxillary line.
Yeah.
And I'm just going here near the inferior border of the bulla.
Yeah.
And I do the intermediate technique. So keep moving like this. Okay? Stay in this area only. Don't go higher up. Probably you are seeing the superior turbinate there.
Yeah.
Yes.
See, this is your posterior ethmoid.
Yes.
And just stay medial to that. This is the polypoidal superior turbinate. Just stick to that.
Yeah.
Okay, see?
Yes.
You are in the sphenoid.
Yeah, I've seen.
Right?
Yes. Yeah. So all filled with polyps. Yeah.
Posterior ethmoid, inferior wall of bulla. Once you get these landmarks, rest of the job becomes easy now.
Yeah.
There was a onody cell on the other side.
Okay.
No onody cell on this side.
So once you identify the sphenoid, you can come anteriorly safely.
Yes. And I always tell beginners, assume the worst. When I'm going near the sphenoid, even though I've read the CT scan well, I would like to assume that the optic is decent,
Correct.
carotid is decent. That way I will stick closer to the nasal septum and the inferior wall.
Yeah.
I won't go superiorly.
Yeah. And also laterally. Yeah.
Yes, absolutely. So see, this way, even in the ethmoid, this corner is the dangerous corner. Isn't it?
Yes.
In Hindi they say, no, बड़ों के सामने झुकना. So when you always stay inferior and medial in life, you are humble, you are comfortable, and the world treats you well.
Good.
Yeah. Sponge. All my 4 landmarks are there.
So in between, if you are in doubt about the sphenoid, you can retract the middle turbinate laterally and you can again recheck.
Sharaf, the first point.
Yeah.
Any cell whose bottom or the floor you cannot see is likely to be the sphenoid.
Sphenoid, yeah.
And if you have the view of the upper border of the choana throughout your surgery, then as long as you stay anterior to that, you are extremely unlikely to damage the carotid or the optic nerve.
So you are not inside the sphenoid.
Even if there's a onody cell.
Yeah.
A onody cell also pneumatizes posterior to the anterior wall of sphenoid. So as long as you're anterior to the superior border of the choana, all your dissection with debrider, you are extremely safe.
That's
If
why
you're
it's
going-
very important to redefine the choana first in
Yes.
extensive
Which is
polyposis.
why I told you in the
As you did
beginning of the
first.
dissection itself
Yeah, correct.
that I removed the polyps here
Yeah,
and focused on the border. Because I said even in 7th revision, 8th revision, two structures you will always find. Ascending process of maxilla, upper border of choana, and many cases a wide middle meatal antrostomy.
correct.
If you have these three landmarks, you can identify every other structure in the sinus.
Yeah.
Yeah.
Yes.
Yeah. Now, give me the straight grasper. Now I think I'll widen the middle meatal antrostomy posteriorly. Let me see if there's a bone here. There seems to be a bone here. Let me give it a twist. Debrider. Because now I am able to give me the 40-degree blade. Ma? Anyway, in 0 also we can do a little, but can you see how easy it is now?
Yeah.
To do, make the antrostomy wider. Oh, this is a polypoid mucosa.
Yeah.
Maybe I can leave it as it is. Let me just take away the polyps in between, suction. Yeah, I won't advocate even this amount of stripping. This is not good technique. I initially thought it was a prolapsing polyp. Ideally, you should not expose this bone. Sometimes it happens, doesn't matter.
But the one in the anterior part of the maxillary, I think the anterior most, that has to
this
be.
I'll take out. This I'll take out.
Correct.
That's why I asked for a 40-degree blade.
Yeah, correct.
Yeah.
Yeah, Dr.
And if you
Deepak,
take a 70-degree, if you take a 70-degree
Yeah, I'll do that as
to
well.
view the interior of the maxillary sinus.
Yes, I will do that. Straight
Dr.
grasper.
Deepak,
Yes.
Dr. Prakash Munka here.
Are, hi.
Hi, good morning, boss.
ये देश में हो या विदेश में हो?
नहीं, very much in the देश, अपने बोकारो में ही है.
अच्छा.
So,
Welcome.
thank you, sir. You made such a nice program that
Yes.
one cannot afford to miss. I am watching you since beginning. Just one clarification for me, for all the audience. What
Yes.
about the polypoid mucosa? Because whenever you are operating, people
Yes.
end those mucosa,
Debrider?
polypoid mucosa, denuding it, thinking it to be a polyp. And
Yes.
at the end, they find that we have denuded the mucosa. So what are the tips and tricks as per you?
The first thing is we must try to follow the mucosal preservation technique.
Right.
And there is one important word with the mucosa.
Mhm.
Reversible, irreversible.
Yeah.
Wherever you feel after your dissection with medical treatment, the mucosal status cannot be reversed to the healthy status, that mucosa has to go.
Right.
Wherever you feel it is going to revert back to its normalcy with a good steroid spray.
Yep.
Because the purpose of doing surgery in AFRS is to widely open the sinuses so that your medication reaches every nook and corner of the sinus.
Exactly.
So in this case, I feel this was reversible. So this
And
part
how do we
is
decide
removed a
that?
little bit.
How do
It's
we
not a
decide
big
that on
disaster,
the
but
table?
it's still not perfect technique.
Yeah.
Yeah.
Because most of our patients, pre-operatively, we have given a course of steroid. They are well prepared. And on table, if we find polypoid mucosa, which is sometimes embedded with the polyps, how do we decide which part is reversible, which is irreversible?
Any patient in whom you feel the field has become excellent after 1 week of steroids, it is a medically reversible disease. You have to practice mucosal preservation technique. Any patient with fibrotic polyps where you feel not much has shrunken, all that has to go.
So that's the way.
Sharaf said in the beginning, this is a well-prepared case.
Yes.
My endeavor should be to go for mucosal preservation technique.
Right.
It may not be always possible.
Yeah.
But you must try. See, in this case, for example, about 5% of this mucosa is gone. Rest of the maxillary sinus is okay. As Sanjay said, now I'm going to take a look with a 70-degree and see. But even this, if you are a perfectionist, this is not acceptable.
Okay.
Okay. So in
Dr.
this
Deepak.
case, yes.
Deepak.
Yes. Sponge.
Yeah, can you, at this point, can you also demonstrate the landmark for the lacrimal?
Yeah,
how much we can remove?
Yes, why not?
Yeah.
You mean the nasolacrimal duct, is it?
Yeah, duct.
Okay.
And
yeah, how much is safe to remove?
How many?
How much is safe to remove?
No, see.
While vaulting.
Up to here, you can see this Hashner's valve, no, here.
Yeah.
If you leave the turbinate here, one thing is the upper border is here. If you do anything in this area, you won't be damaging the nasolacrimal duct. Anteriorly, you in the middle meatal antrostomy, anteriorly, wherever you reach the hard bone, you have to stop. But sometimes in extensive polyposis, even that bone could be thin. Then better to just palpate the lacrimal area here and check for the movement, like this. See, can you see the movement here?
Yeah, that's fine.
Can you appreciate the movement?
Yes. Yeah, we can appreciate.
This moving portion, don't touch that.
Yeah.
Can you see this? See, because of it is covered with blood, but you can still appreciate the movement?
Yeah, it is moving, yes.
Yes. Yeah. So that area you should not touch.
Correct.
Right? And if you go a little posterior and palpate, it becomes the Stankiewicz sign.
Yes.
True.
Yeah. Straight grasper. So one thing is inferiorly, try to stay away from the upper border of the middle turbinate. That way you won't be, inferior turbinate, sorry. You won't be damaging the Hashner's valve. And number two, don't do here also. So that palpation is very important, Sanjay. And that is why we say in FES, no, don't cover the eyes when you are
operating.
Operating surgery. The most safest instrument is your thumb or your finger, which palpates the area outside the nose. It can save you a lot of trouble all your life.
True.
See, that's my sphenoid. You can appreciate that. I think I'll keep a sponge here. We'll take a good look at the maxillary sinus. And then finally, we go for the anterioethmoidal artery. Let's see. And then come back and widen the posterior ethmoid and sphenoid.
Okay.
Straight grasper. Oh, the bleed is from the sphenoid. Okay, right. Okay, give me the sponge.
Usually in FES, in bilateral FES, no. The one advantage is that if there is a more bleeding on one side, you can
you can go on the other side. Yes,
but
absolutely.
here you want, here you want to demonstrate this side completely
Yeah, because we are almost seeing
that's why. I know.
anterior artery and bit of widening. Now taking a look in the maxillary sinus.
Correct.
You know,
otherwise we could have gone to the other side.
Yeah. Absolutely. You said it. You know, when you're working in your hospital and maybe no demonstration and all these constraints, you just pack here and go the other side.
Yeah, go to the other
But
side.
according to me, packing is a much more important technique, and mopping also is a more important technique than keep on doing the suctioning. Sanjay bhai? Except
Yeah,
that
Janki also advocates that. Janki Ram also advocates that.
Yes. 40-degree blade. Let me see if I can just take out that polyp a little bit. Yeah.
Deepak,
yes.
In these 2 days, you have sorted out such a nice academic program that almost multiple types of surgery will be covered, and it will be very good not only for the budding surgeons but even for seniors who can revise their technique. Only constant what I feel is, like I can see in the PIP, Dr. Satish is almost ready, and there can be overlap. So because it is very difficult to time, like you have put your time up to 9, and you cannot finish in the given time depending on the case. How you are planning to do that?
Monka sir.
Yeah, boliye sir.
Deepak timing was till 10, but he has shortened it because we wanted to watch Satish in action also.
Okay, more of Satish. No, I know. So
and also another thing is Satish sent a message that he would like to go on air at 9:30.
Okay,
so
that's fine.
We have another 12-13 minutes up.
Yeah, no problem.
So we thought we can,
Basically, all these cases are so interesting that nobody will miss on. Like at this stage, if we miss you, that will be not a complete teaching, So,
yes, because see, in courses like this, apart from knowing how to do things, you should also know how not to do things. The way I removed that little mucosa there.
Yeah.
It's important for the beginners. Yeah, Sanjay bhai, little bit of polyp there. Ball probe.
Even you remove little mucosa accidentally, it will regrow. Nothing to worry.
No. It's not worrying. I just see when we are doing an instructional course or whatever.
Oh, correct, sir. Yeah.
We have to tell see here. You can go through the inferior meatus. Can you see this opening here?
Yeah.
See here?
Yeah.
So debrider, 40-degree. Sharaf. Practically, I and this doesn't matter much.
Yeah.
But that is different. But when I'm teaching,
correct, sir.
I cannot have a chalta hai approach.
Yes.
See here, I am going in that.
This is a very good technique Deepak is demonstrating.
Yes.
Please see.
Yes.
Without injuring the nasolacrimal passage, you can go to the anterior most part of the maxillary sinus like this. It's very good technique. Yeah.
It opens up that area. See, that polyp was blocking that area. Yeah. So now the steroid can reach there.
Correct.
Very much.
Debulk the polyp.
Yes.
Debulk the polypoidal mucosa.
Yes.
By retaining the lining.
See, I think...
this is a right 40 blade.
It's a 40 blade. You can
have
60 also. You can use 120 also.
Yeah.
The suction was not working. Otherwise, this would have worked even better. Our nurse is getting it right. I'll be doing exactly for another 12 minutes, Sanjay.
Yeah, that is fine.
Yeah. Because again, like you, Satish has played a very big role in all our lives. You agree?
Yeah, that is true.
Curved suction. Isn't it?
He has taught us so much.
Ready, huh? Yeah. He has been a fantastic teacher, and I keep taking.
He's a powerhouse of the knowledge and the anatomy.
Yes.
Actually, thanks to social media, all these videos by
Yes, absolutely, absolutely. See, a lot of people will
helped
be
many
watching
guys.
on the mobile.
Yeah.
60-degree idiyamma blade. Ready? Haya? Hare. Hi, Satish. Uska mic, huh?
Hello.
Correct 9. Are, good morning, Guru.
Good morning, sir. I'm watching you operate. Pleasure.
Are, no, don't tell me that.
Each and every step I'm following.
माँ कसम मैं अभी नर्वस हो जाऊंगा.
No, you're doing amazing. What a great exposure, the surgical field. Everything is up to the mark. Amazing.
So good morning, Satish bhai.
Good morning, sir. Good
अच्छा
morning.
क्या केस दिखा रहे हो जरा बता दो कैसे भी अभी लास्ट 8 मिनट है.
It's a JNA.
But I think it's going intracranial, huh?
Yes. It's a good case to discuss.
Okay.
Sadish ji, good morning.
Good morning, sir. Shrafuddin, sir. I can see Prakash Mukha, sir. Good morning.
Good morning, Satish.
I saw your video demonstration in Kashmir.
Pardon,
in
sir?
Jammu.
Yeah.
Dinesh sent your videos from Jammu.
Yes.
Which you have done, non-stop 8 hours. Did you drink water at least? Huh?
Dr. Sadish, I was
think
just watching
fairly
your
wide
SARC video
antrostomy.
yesterday. Yeah, it was amazing. The SARC one.
SARC
the
one,
cadaver demonstration. Yeah. Superb.
Dr. Satish and Saifuddin, I was just telling before Dr. Satish joined that with social media, now we can access to most of the things on the YouTube. And before, I tell you personally, when I started in the technique, I saw his videos 3-4 times, then had some doubt. I rang him up. How should I take this? And it's a great learning opportunity, which probably during our early days was not there.
Sure. And not only in India, the whole world is now following Dr. Sadish's video. You're all proud of that. Because each surgeon now just see whether any particular video of the same surgery by Dr. Sadish, then they just see that, as you rightly told, 2-3 times, then they go ahead for the surgery. So it is more than the book, more than any ENT surgeons contributed to the country or to the world. We have to salute Dr. Sadish ji for that. No.
Naveen,
from the heart.
About our country.
Sorry. Wash Marco.
I remember our academic sessions. Yeah. He's been part of that. Contributed a lot. Prakash Mukha sir has contributed a lot. Deepak sir is like, torch bearer. He has been very, very important. He has been in my life, encouraging and giving opportunities and learning a lot of things from him. Sanjay Agarwal sir, Dubey sir, all have been,
Okay. Ball probe.
I've been so lucky to have such people in my life.
But Satish, one thing I will like to comment. I have many other centers in abroad also, but the way our Indian colleagues teach us, frankly speaking, each and every step, what to do, what not to do, what should be the approach, like you, Deepak, Janki, everybody. I mean, if I name somebody, I will be missing out more than what I name. People are so humble, and if any problem, you ring them up, they help you out. And that is, I think, for most of the guys, they do entertain, or you send a text that I'm going to do this case, I have missed out. This, privilege, probably we Indians have got because of, good teachers like Satish and others.
Satish?
Yes, sir.
Another 5 minutes and you're going on air.
Yes, sir. No need to rush, sir.
Exactly
I've been
5 minutes.
watching and
No, no, I'm
really
working on the supraorbital
so
cell.
nice to watch you operate. I'm enjoying, sir. Take your
No,
own time.
no.
No need to
Another
rush.
5 minutes, whatever it is, master is the master. I think my anti-ethmoid is coming here. You agree that this is a supraorbital cell,
Yeah.
Satish?
Behind the behind this lamella.
ये तूने ही तो सिखाया है ना?
अरे sir.
तूने ही तो सिखाया है.
No. It's not. It's your modesty.
Now
I know you are
I'm staying posted to. No. I'm defining the skull base the way you taught me. Only thing is I don't use the reverse rad blade. उतना guts मेरे में नहीं है. That is the only thing. That is a skull base, Satish, complete up to the sphenoid.
Sir.
And I think this is where my anti-ethmoid artery is.
It has to be there behind. Yes. Running along the skull base.
Yes.
See, looking at the CT scan, you get to know whether it is prominent to be visualized or not. You don't have to go for it. You don't have to chase for it all the time.
Yes.
It's not that always a positive identification is mandatory.
Yes.
So the best part what Deepak sir is doing is, look at his middle turbinate, his corridor, it is so well stabilized. He's using 70 degree to keep an eye all around on a lateral limit, medial limit, and working right in the middle of these either side limits.
And this I feel is the anti-ethmoid, Satish, here. If
Could
I
be.
follow this,
Yes,
I'll
could
be
be.
going there. Yes. Debrider?
We must know the area where it is traversing through so as not to damage, rather than identifying on a positive note always.
Yes.
The beautiful panoramic view you get by the 70 degrees, all the boundaries as you hear.
Look at the skull base behind. Behind is the skull base.
Yeah.
Behind this polypoidal thickening is the skull base. Model skull base.
Yes.
Sadishji, could you please tell us some tricks to handle the 70 degree? So most of the surgeons find very difficult to visualize and work with the 70 degree. As for the inspection, fine, but to work with the 70 degree, very often it's find very difficult. So could you tell us some tricks too?
You are right, because the visualization in 70 degree is not like 0 degree where the endoscope points and the structure there is.
In
70 degree, wherever the endoscope points, the structure is 70 degree up.
Correct.
So you need to get used to. Ideal way is to practice on cadavers, not only identifying the structures with the 70 degree, you need to get used to instrumentation with the 70 degree as well.
Yes.
So like Deepak sir, look at him. His forceps is above the telescope. So telescope is showing the forceps.
Yeah.
So getting used to instrumentation with 70 degree is very important. Keep your instrument above. See what is he?
ENTrain, yeah.
Instrument first and then introduces the telescope behind.
Yeah.
So keep the instrument tracking. This you can practice best on cadaver. Besides that, if you are not getting cadavers, you can practice on nasal endoscopy on patients.
And again, what Satish taught me is the best way to widen the frontal sinus pathway is to connect the supraorbital cell to the frontal.
Yes, sir.
Isn't it, Satish?
Yes, very well. So you remove the party wall and widen the access to the frontal outflow.
Yes.
And see, immediately behind that supraorbital cell is the location of anti-ethmoidal artery.
Anti-ethmoidal artery, yeah.
Where is working close to, that is the area.
Yes. See the 45 degrees angle.
Yes. That is obliquely passing along the skull.
Yes.
Correct.
And this 70 degree work, Satish taught me completely how to use it, how to use the debrider on the skull base safely, removing the polypoidal mucosa millimeter by millimeter. Yeah, Satish, please get ready. My
Yes,
time is over.
We are all set. We are enjoying your surgery. Take your time.
No. Up, start karo.
Deepak, you are about to finish. Why don't you complete it? Everybody is.
I'm almost finished. That's okay. See, I wanted to show the anterethmoid artery.
Yes.
And that's it. You know, I don't see the remaining thing is just widening the cells. Will do it. See, he's the star of the show. There is no doubt at all. He's humble. He's always humble. He's more humble than me.
Yeah. That's why, Dr. Satish, I remember we used to do the webinar.
Okay, the uniqueness of the event will be, the uniqueness of event is the pupil has demonstrated first.
Yeah.
The master will follow now. Yes.
What Deepak sir has started, I would call it as a well begun is half done.
Yes.
The first case, the basic one, the sinus surgery, the surgery of landmark, the way he's demonstrating is something a treat to watch. And the best part, what you see is the visualization. 70 degree, your both limits on either side. You know, everywhere he is using the sharp instrument like shaver, debrider to preserve the mucosa. That's how it is functional. Because this entire function is ultimately going to be served by mucosa only. And see, everywhere, using the micro debrider, cuts sharp and saves the mucosa.
Yeah.
This is some, collection in the frontal sinus, secretions. He can flush also. You can flush also. That is also very safe.
Yes. I think you have purchased the hydro debrider, no, now? Or
Yes.
You have a hydro debrider, Satish, now?
Yes. So for such thick mucin, fungal material, hydro debrider is a good tool to wash out like a jet moving 360 degree all around.
And ours is one more unique combination, Sharaf.
Yes.
That the guru is 9 years younger to the disciple.
Even for all of us, for that matter.
Yeah, absolutely.
Deepak, age is just a number. That doesn't matter, boss. One doesn't stop learning. Like me, so it doesn't matter, So.
Amazing.
Can you see the frontal proper?
Look at the beak.
Yeah.
And the posterior table?
Deepak sir, can you bring it forward to show the axilla first?
Yes.
Just little more forward. So for everybody, what he has done, see the axilla, the most reliable landmark anybody can identify. Then go underneath the axilla. See the axilla, anybody can identify. Go underneath the axilla, sir, little bit.
That is the beak, na?
Go underneath, that is the beak.
Yeah, it is the beak.
And go underneath further, advance. And underneath the beak is going to be the frontal. Such a straightforward anatomy made easier by 70 degree.
Yes.
First axilla, identify the most reliable landmark axilla that you can identify with a 0 degree from beginning.
Yes.
Then just underneath the axilla with a 70 degree, you will find the beak. Then
and
follow the beak.
This definitely is the anterethmoid artery.
Yes,
No
that's the reason.
Yes,
100%, no doubt.
Yeah. Frontal sinus, posterior table, frontal beak, anterethmoid artery, middle fovea, posterior fovea, sphenoid. Satish,
Another advantage of using 70 degree here is, see, with this angulation where he's using 70 degree, the beak is far anterior. Your instrument towards the beak are far anteriorly directed away from the trajectory of anterethmoidal artery.
Yes.
So there is no fear of damaging. Artery is far behind and deep.
Sponge wash. Satish, you should start. Chalu karo.
We are all watching you.
नहीं मुन्ना भाई लगे रहो. Start. Start. Satish, you should start. Please.
Thank you, sir.
I'll go into PIP. You please start. Start with your case. 0 degree. Hello.
Laptop. Hello.
Yes, Dr. Satish.
So are you getting something, some scan on screen?
Yes.
Bolo.
Yes, sir, we can see that laptop screen. Okay.
I think we lost your voice, Satish.
Hello?
Yeah, fine.
So are you getting some scan, sir?
Yes.
Are you getting MRI?
Yes, sir, we able to.
Yes, sir, you can see that.
Hello?
Yeah.
Are
Yes,
you
Dr.
getting
Satish, go ahead.
MRI on screen, sir?
Yes, yes. It is very much
Okay.
there.
So this is a 17-year-old male with a classical complaint of nasal blockage and occasional bleeding. Young male patient with such complaints, on endoscopy, some mass in the nasal cavity behind gives you a suspicion of juvenile nasopharyngeal angiofibroma.
Right.
That's how it is clinically suspected. Since once you suspect an angiofibroma, which has a high propensity to bleed, we avoid routinely taking a biopsy.
Yes.
So what next is the radiology to substantiate our diagnosis on basis of certain clinical extensions of angiofibroma. It has some preferential extensions from where it arises, which gives you a classical picture of JNA with huge contrast enhancements and flow voids, making it a vascular tumor. So that is how. So this is a coronal contrast imaging to give you an overview. This tumor, see, that's the pterygoid process.
Yes.
From the anterior surface of the pterygoid, that's the center from where it arises. Can you see the center area?
Yeah, yeah.
Just, at the face of the pterygoid. And then it has a classical extensions all around. All around means this pterygopalatine fossa is like a crossroads from where this tumor invades the pterygoid bone. It comes in the posterior part of the nasal cavity, and from there it goes in the nasopharynx. From this pterygoid base, it goes to the sphenoid sinus by eroding the floor of the sphenoid sinus. It doesn't enter the sphenoid through the natural ostium. Then, from the pterygopalatine fossa, it goes up into the inferior orbital fissure. If I follow it, that's the superior orbital fissure. And if I follow it behind, that's the cavernous sinus. Superior orbital fissure is a continuation of anterior continuation of cavernous sinus. Let me show in the axial plane like this. See this? That is the superior orbital fissure. See the orbital apex there?
Yes.
And from it is extending towards the carotid in the cavernous sinus. So that is another preferential extension. Then, because it comes in the pterygopalatine fossa, it easily prolapses through the pterygomaxillary fissure laterally into the infratemporal fossa, which is a potential space containing a couple of muscles, neurovascular structures, and it has the ability to accommodate even large tumors by means of expanding and compressing the surrounding structures. And see where the tumor has gone far deep, even beyond, see that is the mandible behind. Even behind, anterior to the face of the mandible, going far laterally and far inferiorly down. See the huge, like a cricket ball again, prolapsing into the infratemporal fossa. Now, if you take the level, that's the level of the hard palate. See, that's the level of the hard palate. The tumor is going even 2 centimeter, almost 2 centimeter below the level of the hard pellet. Can you see?
Yes, yes.
That is how this tumor is prolapsing this way. So this is another preferential extension. And see from here, from the pterygoid, it goes down in the pterygoid fossa. That's the entire pterygoid fossa which is involved by the tumor itself. So, tumor in the posterior part of the nasal cavity prolapsing toward nasopharynx, sphenoid sinus, inferior orbital fissure, superior orbital fissure, cavernous sinus, in the pterygoid fossa, in the infratemporal fossa, and far laterally even into the cheek. So these are, see, classical extensions laterally. This is anterolateral and this is posterolateral. That is, here is the pterygoid process, invading the pterygoid process here. See this pterygoid process? And then going far laterally and behind the pterygoids into the deep part of the infratemporal fossa. That's how it goes down in the parapharyngeal space. Day before we demonstrated the huge one going in the parapharyngeal space and the temporal lobe. So these are the classical extensions of this tumor. Now, from surgical, point of view, there are lots of information you expect from radiology, and more radiological information makes surgical life more easier. Now, what all information required from the radiology to make your life easier? Number one, see this. This is T2 weighted fat suppress imaging.
Yes.
One of the reasons why these JNAs tend to recur, the so-called recurrence. This is a benign tumor like any other benign tumor in the body. If completely removed, there is no question of recurrence. Even if a millimetric part of the tumor is left behind somewhere, it is bound to regrow and then present as a recurrence, so-called recurrence, much difficult to remove. As the vascularity now is all unpredictable, it becomes more invasive. That's why the endoscopy has scored over the open approaches, because you have seen this tumor. This grows into various, foramen, fissures, crevices, everywhere. Endoscopy gives you ultimate visualization, magnification, right on the point. You can go with the telescope and see carefully and remove it under vision, which is not possible with the open approach. We have seen traditionally open approach, you try to remove the tumor, it bleeds like anything and ultimately you pack and come out. And you have no opportunity to inspect each and every foramen and fissure and, narrow areas where the tumor might have left behind. That's how endoscopy definitely has an edge over the open approach. It's not like we are avoiding an incision, which gives us a better approach. If any approach, even with a bigger incision, gives better outcome, I'll opt for that. We are not biased toward endoscopy or pushing every case for the endoscopy like that. So, another information. So, why this tumor tend to recur most often? Because it is left behind in the cancellous bone. In the cancellous bone of sphenoid and its processes, like pterygoids, greater wing of sphenoid. If this tumor infiltrates the clivus, pterygoid, or any Haversian system of the bone, which may look obviously from the outside, visualization looks intact, but the tumor might have penetrated inside, which can be seen based on radiology. And if it is, you can remove that, drill away that bone to prevent recurrence. So that's how we need some information from the radiology, and this is what the sequence T2 weighted fat suppress. Why fat suppress? Because all this bone contains marrow. Marrow contains fat, and fat brightens on T2 weighted imaging. If you suppress the fat, and anything then after suppressing the fat brightens the marrow area, has to be tumor. And this is what you can see. See this carefully on T2 weighted imaging. This is contrast. This is the tumor in the pterygoid process. See the tumor, hyper intense signal in the pterygoid process. Look at the normal pterygoid on the opposite side. It has a marrow, it brightens, but it is not brightening up because the fat is suppressed. If we take a regular, let me bring on a regular T2 weighted imaging. This is regular T2 weighted imaging. See now regular T2 weighted imaging, even the opposite side marrow is enhancing.
Yes.
You cannot differentiate from a tumor. In T2 weighted fat suppressed, the fat is suppressed and now nothing is enhancing, means there is no tumor. What an amazing sequence by means of which you can pick up any marrow infiltration in the surrounding which needs to be thoroughly exentrated to prevent so-called recurrence. This is of utmost utility, I would say, this kind of information. Second information, what you expect from the radiology, when it goes, intracranial, you need to have a clear demarcation whether it is invading the intracranial structures. Maybe, see this. This T2 weighted imaging showing the clear demarcation of the dura, everywhere, which is not appreciated on any other sequence like this. So here, even this tumor has a propensity to grow circumferentially from the area of origin and compressing all around. It is not generally invasive. The revisions can be invasive. We have seen the revisions, where the, unpredictable vascularity becoming more invading the dura, invading the brain tissue, truly invading the brain tissue we have seen. But the primary tumors generally do not invade and they grow by compression, not by invasion. So see, the interface with the surrounding is very clear. Can you see?
Yes.
See this. Tumor going in the orbital fissure. But all around, can you see the periosteal plane intact?
Yeah.
That gives a useful information that it is not invasive. Number 3, as it is going in the cavernous sinus behind, how to get to know whether the carotid is invaded or not? That's a very vital information. Otherwise, it always gives an apprehension to the surgeon. See this tumor from the inferior orbital fissure, superior orbital fissure. Now, that's the cavernous carotid.
Yes.
On contrast, enhancing like invading the carotid artery. Can you see this? But it is not truly invading. I said this tumor grows and compresses the surrounding structure rather than invading. And see this. Let me bring all the 3 sequences together to give you a clear picture whether it is invading or not. This is axial and this is here the sagittal. Now the first axial. See this axial I am and then I will bring the 4th one to give you a clear picture whether there is a carotid periosteum intact or invading. See now, on the axial. See, this is the petrous carotid artery where my cursor is. Can you see?
Yeah.
This is petrous carotid. Now going up, now I am going up. This is the horizontal petrous carotid. Very clear?
Yeah.
This is the horizontal petrous carotid. And this tumor coming from the orbital fissure. See this? This is the entire superior orbital fissure which is involved by the tumor. And from here anteriorly going through the superior orbital fissure, growing towards the cavernous sinus. That's the cavernous carotid. That's the cavernous carotid. And there is the, see this, periosteum all around the tumor. Periosteum all around the tumor, which is giving you clear picture that there is a thin periosteum all around the tumor, separating from the tumor itself. Can you see very clear or not? Let me change the window intensity to show you. Can you see the thin periosteum around the tumor?
Yes.
Black line.
Yeah.
No, see that is the periosteum that is giving you a classical picture that tumor. See the black line.
Yeah.
Giving you clear picture that the tumor is not invading. This information can be elaborated better on angiogram. So we have an MR angiogram. MR angiogram is non-invasive. See this, the same carotid artery.
Yeah.
Can you see the same carotid? The foramen lacerum carotid, the petrous carotid, and see this is the tumor which is coming behind.
Right.
That's the tumor. And see this carotid is distinctly separated from the tumor. See this. Tumor is not infiltrating, not giving any irregularity on the carotid wall. Can you see the smooth carotid lumen and distinction of tumor giving any irregularity? Can you see some vessel arising and going back into the orbit?
Right.
That is ophthalmic artery. Hello.
Yes, yes. Go ahead, Satish.
This is ophthalmic artery.
Yeah.
This is a retrograde branch from the first part of the carotid, which is going into the orbit. You can see very clear. And that's the cavernous carotid. So the tumor is coming onto the carotid, but not invading. Now, another important thing, what you expect from the radiology is the angiographic study. See this. What we want to know from this study, this is the cavernous carotid dividing into anterior cerebral and the middle cerebral. And these anterior cerebral joining to form the ACOM. That is anterior communicating. Behind is the posterior cerebral. And from here, this is the posterior communicating artery. That's the posterior communicating.
Yes.
Joining both the circulation to complete the circle of Willis. That's the posterior communicating.
Yeah.
The cross flow at the level of the brain can be seen well on the angiographic study. This is very important when you deal with the tumors around the carotid artery. Third important information from the angiogram. See, we know the principal vessel invading or supplying this tumor is this internal maxillary. How to follow this and how the vessel is entering? See, this is your external carotid, internal carotid here, external carotid here.
Yeah.
Follow my cursor. External carotid going behind the mandible. This is mandible.
Yeah.
And here it is divided. See, here it is dividing into two vessels. This outside going is the superficial temporal. And this one going in the maxillary.
Yeah.
See the maxillary artery.
Yes.
And see, I am following this maxillary where my cursor is. Follow this maxillary artery. Follow this maxillary artery all the way. See this maxillary?
Yeah. Yes, yes.
See where it is coming. Can you see?
Yes, yes.
That's the maxillary sinus. And this is coming just behind the maxillary sinus in the anterior most part of the pterygopalatine fossa. Can you see very well? Look at the maxillary sinus on this side and see with tumor expansion behind what has happened to the maxillary sinus. It has pushed the posterior wall of the maxillary sinus anteriorly. Classical Hallman-Miller sign. See, and in this anterior most part of the tumor, just behind the posterior wall, is the internal maxillary. That is where that is the basis of endoscopic excision, where you come by the Denker's approach from here directly onto it, open up the posterior wall periosteum behind the maxilla and catch the vessel first to devascularize to a certain extent. Now, this is the principal vessel, and see how much branching it is giving in this tumor to make it so vascular. See this? So that's the principal vessel which you have to catch over here. Now, if I do a 3D reconstruction at this level, let me show you. This is the vessel if I catch. That is the vessel. That is, oh. That is the internal maxillary network. And see, this is the maxillary artery. Can you see the maxillary artery here?
Yes.
This is the level of the palate. Again, this is very important sometimes. Otherwise, it is so difficult to find the maxillary artery. My level of the maxillary artery here from the hard palate is more than 2.8 centimeter. Can you see?
Yeah.
So once I open the posterior wall, I have to look for the maxillary higher up. Sometimes it is pushed inferiorly, sometimes it is higher up. And you really need to look at the vessel to devascularize the tumor. And it gives you such a great confidence where your artery is going to be. Can you see?
Yes, yes.
That is the maxillary artery, with the principal artery giving ramifications into the tumor to supply it all over. So that's how it makes your principle of endoscopic surgery. First, go behind and devascularize this tumor by taking this vessel, clamping this vessel, clipping this vessel, and then you can bring out this tumor. At no point of time you are supposed to go inside the tumor. No point of time. So our goal in this case, our plan is very simple. That's a huge lateral extension. Can you see this?
Yes.
So what we are going to do, the nasal space is occupied by this tumor. So what we'll do, we'll go behind and catch this vessel first, number one.
Yeah.
And then we will divide, this is the level of the lateral wall of the maxilla here.
Yeah.
We'll divide the tumor here at the lateral wall. We will remove the medial part of the tumor first, this entire medial part, to accommodate later this entire lateral part coming into the nasal cavity. Otherwise, if you don't remove this medial part, you cannot bring in the lateral part, as there is no space in the nasal cavity to accommodate that. So the principle, the planning is very clear. We need to have a good exposure. I'll take a good far lateral exposure. See, this is my lateral wall of the maxilla, nasal cavity. And what I'll do to catch here, I will remove this much of the bone here. This much of the anterolateral wall to give me full exposure of this region. This part I can pull out later on.
Yeah.
Okay? So this exposure will allow me the opportunity to take this vessel over here. So I really need to remove this much of the lateral nasal wall to go wide laterally to have a full exposure of the posterior lateral wall. Catch the vessel first, then we'll divide the tumor here. The medial part will remove first, and then lateral part will bring in and remove completely. So the plan is, wherever the tumor is extending all around, same way we have to pull it from everywhere. It is pushing borders everywhere, pushing borders towards the muscles in the infratemporal fossa, towards the orbital fissure, towards the cavernous sinus. Everywhere is pushing. So we have to remove. We have to completely remove the pterygoid on this side, and this tumor is completely infiltrating the pterygoid from top to bottom. See this pterygoid from bottom to top, completely infiltrated by the tumor here. That has to go completely. We will drill away and remove this tumor. And the part of the tumor little bit which is projecting in the sphenoid sinus after eroding the pterygoid, we will see by exposing the sphenoid sinus and pulling it down. So this is how our planning is very clear, and the radiology has enabled us to plan everything. That's why in JNA, we have to order adequate imaging. If you order just MRI, PNS, the radiologists are not going to give you more than 1 or 2 sequences and finish off in 10 minutes. Because in MRI, each and every sequence has to be shot separately. This kind of MRI, what we order, it takes almost 1.5 hours. That's why it costs money as well, but it gives us complete information what you can expect and make your surgical life easier, and you can do a better surgical work than rather going blindly and coming up with surprises intraoperatively. Any questions, sir, before we go ahead?
No, you have explained excellent way. The term recurrence probably should be replaced by residual tumor. As far as the
residual which regrows, yes. Residual which regrows, and the commonest reason of being residual is going blindly without adequate radiology.
Right.
Going without taking the vessels in control, with too much of bleeding and you are working blindly. And number 3 is the most common cause of residual is invading the Haversian system of this cancellous bone of the sphenoids and in processes and the clivus. So wherever on radiology, take T2-weighted fat suppress, wherever is enhancement considering as a micro infiltration, you must radically remove that bone, because this is a benign tumor. If you remove completely, it is never going to come back.
I think, Satish, the part of the bone you explained, probably that is one which is missed by most. And usually,
if I don't have this radiology, even I would definitely miss.
Right. And post-op, I think, say after a week or so, or what is your protocol to repeat an MRI, all the sequences to confirm that nothing is left out? Do you go for a post-op radiology?
Yeah, that's a very important question. See, the biggest advantage of modified Denkers is it gives you a lifetime opportunity of surveillance endoscopically, even in your office, in your OPD. So, with this kind of pre-op radiology, knowing what bone is involved, and intraoperatively, you execute properly by removing that particular bone completely, ensuring intraoperatively under endoscopic visualization. With a Denker's access in the post-operative follow-up, generally you don't need any radiology.
Right. That is one point which is very important. You explained earlier also, and that is what I wanted to emphasize. Don't always jump onto a post-op radiology if you can visualize properly. Because the second question arises, patient will say it is a recurrence, or it is a residual, which you left during the first surgery. So how to convince him?
See, this is a vascular tumor. Your visualization is always a challenge.
Yes.
Taking vessels into control is a challenge. And this tumor has a propensity to invade narrow spaces.
Right.
So there is always a possibility of leaving behind it. All your expertise, your radiological information, everything matters.
Right.
So you have to, in any given situation, this is quite a complex situation. Even in the simplest, you have to convince to always keep a possibility of a second look, need of, revising something, revising some complication, whatever. So you always have to keep in mind, informing your patients accordingly. You cannot guarantee anything in science.
Right.
But
that's very important point. Basically, nobody can say that my cases will not recur, however expert he or she may be.
See, with this kind of radiology, and executing it properly, we will discuss during live surgery, each and every step. You will see the advantage of radiology giving you visualization to each and every nook and corner. And it brings the tumor completely intact, rules out the possibility of recurrence. And we have been following these patients for years and years. We are now more than 10 years follow-up, doing well. And, with endoscopy only you can follow. In doubtful situations, intracranial invasions, and all that, you have to follow with the radiology. Otherwise, we don't even need radiology now. Exactly. This is how you follow. Now, look at this picture. This is T2 weighted, See the amount of vessels inside the tumor. This is what kind of tumor is this? Full of vessels. See, all these are flow wide. These are all big vessels into the tumor. These are all ramifications of vessels, mostly arising from the internal maxillary. In JNA, this is nothing but bunch of vessels with some fibrous tissue, and these vessels classically do not have, muscular lining, so they don't contract. Now, once the vessel is damaged, it has a propensity to continuously bleed. It doesn't contract. That's how it gives hemorrhages. So, the goal in this surgery now, my principal tool, my man of the match is going to be, cobblator. As majority of the vascularity is towards the surface everywhere, and we'll use the cobblator in a sequential fashion. Everywhere the tumor is exposed, we'll use the cobblator. That's how we'll minimize the bleeding. We will never advocate to enter inside the tumor unless you take the adequate vascular control. Never enter inside the tumor unless you expose from all around. I'll show you how to expose anteriorly, anterolaterally, posteriorly, medially, superiorly, everywhere, and then finally go into the tumor. So this entire surgery, 90% of the time will be, spent or invested in exposure, vascular control, and then finally we'll get onto the tumor. This is the primary principle we are going to follow, and that's how we are able to execute.
For surgery, just one last question. Watching you since years together, there is hardly any bleeding, but most of the people going for angiofibroma surgery, they always keep blood transfusion couple of units ready. So what is your protocol on that?
The same I told you. Exposure, coagulation, exposure, preparation. Even this patient, I've been giving antibiotic and steroids for last 6 days now to reduce the inflammation in the nose, because this tumor blocking all accesses to the sinuses, giving secondary infection, mucosal edema, vasodilation. You have to, prepare like sinus surgery by means of giving antibiotics and steroids I've been giving to reduce the inflammation of the mucosa. Then more and more coagulation, taking the vascular control, not entering the tumor directly. All these and adequate exposure, adequate exposure is the key.
Yeah, so you don't need any blood to be kept ready for that,
Yeah,
because
we keep standby, but mostly we don't need too much of transfusion. Sometime 1 unit or so. Like this case also, we might be needing 1 unit because very vascular. We don't know how, every tumor has a different structure. Some
Right.
tumor are more fibrous, some tumor are more vascular, and this tumor looks like more vascular in
And
spite
one
of being
more thing,
17-year-old. This is
Yeah.
too vascular looking like. Yes.
more thing, Satish, when you take out a bulk, this bulk contains a lot of blood, so you need some replacement. That's another logic about that.
Yeah. So this is all vessels only. This is all bunch of vessels only.
Right.
Secondly, with all these extensions frightening you, see, this is a huge infratemporal fossa extension. Believe me, it will come easiest like a baby.
Yeah.
No need to frighten. This infratemporal huge extension is going to come the most easier way, I will tell you.
Yeah.
Easiest. Anywhere it extends. If it is extending high up into the temporal lobe, it goes from the pterygoid roof into the temporal fossa. Similarly, it pushes the dura, you can bring it out easily. This cavernous component through the supraorbital fissure, you can bring out easily without any fear. So all these extensions need, after the dankers and medial part removal, all these extensions need just pulling out the tumor with adequate exposure. That's it. You don't need to frighten. And whatever, any given extension, you can remove endoscopically in a primary situation. Unless it is completely invading the carotid from all around. That's a contraindication because you need a lot of control from the, carotid in case it lacerates. When the tumor is 360-degree embedding the carotid artery, then you have to have, help from the endovascular team for the pre-op DSA, intra-op need of, coiling the vessel, pre-op coiling in case in a planned way, or, more neurosurgical help. So those are more complex situations, mostly revision, but by and large, in a primary situation, it is rarely needed. So we
Satish sir.
Hello?
Satish sir, namaste. Good morning. Myself, Dr. Manoj from Varanasi.
Yes, sir.
Sir, what is your take for this pre-op embolization? You generally don't go for pre-op embolization.
Generally, we don't know. You're right. We sometimes get the embolization done. It depends upon the, feeders which are going to the tumor. Let me tell you, in this situation, say this. What you see from the angiogram, let me tell you, once you have asked the question in a proper way, how to look at the angiogram to find the need of, embolization. See this. I'm just showing you how to look at the angiogram. Can you see the common carotid artery on both sides?
Right, sir.
Now I'm going up. Can you see the common dividing?
Yes.
Yeah.
This is internal, this is external. What is this first branch of the external? Anybody here going here? This is superior thyroid. Anteriorly. Can you see anteromedially?
Yeah.
This is superior thyroid artery. Can you see?
Yes.
Now going further. See carefully. Two more branches. Can you see? This is your ascending pharyngeal. This one. Behind. Medially. And this is anteriorly. This is what? Facial artery. Can you see?
Yeah.
Right, sir.
You have to look at each and every vessel if any of them are supplying the tumor. See this? So this was ascending pharyngeal. You have to follow each and every. Now keep an eye on the ascending pharyngeal only. See, this is ascending pharyngeal. I forgot everything. This is ascending pharyngeal. And this is not going anywhere. Now, this is your facial artery. See this facial artery?
Yeah.
Now
Yes, sir.
following the facial artery. See that I'm following the facial artery going above the mandible. Now going further behind. See, it gives off. This is occipital artery behind. And here, This one is the lingual artery giving medially. That's the lingual, that's the occipital, and now the external carotid going behind the mandible and dividing into this is internal maxillary and this is superficial temporal. You have to follow each and every vessel to know what all vessels are supplying to the tumor. If the tumor is supplied maximally by the internal maxillary, you can take control intraoperatively before entering into the tumor because it is in front of the tumor and you can take endoscopic control. If some vessel is the principal one and supplying from behind, which you cannot access endoscopically without mobilizing the tumor, without going into the tumor, obviously you have to embolize, otherwise it will not allow you to work. So this angiogram will tell you what vessels are supplying, how they are entering into the tumor, and whether this needs embolization or not. Now see, in this particular case, this is internal maxillary. And here the internal maxillary is giving a branch from behind as well. This is a very, very superior part. This is probably middle meningeal artery giving from behind. But the rest of the internal maxillary, the main internal maxillary is going into the tumor here and coming anteriorly. And that's why we'll take the control of this without needing embolization. Yes, if you take the help of added embolization, you can embolize the middle meningeal to further reduce the vascularity. We are going to encounter some bleeding because of the, but we'll manage it with the our tools, the Surgicel. We may have to use Surgiflow or something like that, but not the massive ramification is from the internal maxillary there. So once we take the maxillary in control, we'll be able to reduce the bleeding significantly coming to the tumor. This is how we work.
But sir, you are the God of ENT, and you have got hands of God. But it is not possible in every person who is operating this kind of angiofibroma. So any piece of advice for them, just like people like us, sir? Sir, आपकी मतलब every lecture and your every video is chapter of Gita. And even I have never met you personally, but I have learned so much from your videos, sir. I can't tell you. So people who have met you and who are in regular touch with you, I don't know how much knowledge they are getting from you.
We are all learning from each other. Thank you very much, sir. The issue is what I am emphasizing, what I learned, and every day we are learning. And what I am emphasizing here is to focus on radiology to make your surgical life easier. All the difficulties you can encounter intraoperatively, you can presume on radiology and accordingly deal with that. Otherwise, you are going to get surprises intraoperatively and you may have to cut a sorry figure sometimes to abandon the case, face more bleeding, complications. And according to the radiological imaging, you can warn your patient, you can counsel them that how it is going to behave, what we are going to do. So radiology is the key. Radiology is the science which is, developing much faster than the surgical science. It is technology. And it is time to take the advantage of technology as the patients are more demanding. Patients, now expectations from the doctors are, obviously much more. And whatever we can fulfill, taking the advantage of radiology is something significantly leaves an impact. So this is what the information about this case so far, what I have given is purely on the basis of radiology. I have not even opened the case.
Right, sir.
So let's see.
Just one question. Just one question I received from somebody in my WhatsApp. They say if they have to order radiology, what one thing we should order for and what should be a complete requisition for the radiologist so that they don't miss out on anything.
See, it all depends upon the pathology you are looking at. Like in this case, clinically, you're suspecting a JNA. You have to order T1 weighted multiplanar imaging axial corner sagittal. Every imaging is shot separately in a MRI. Not like CT scan, you can reconstruct in any plane. T2 weighted in all planes, T2 weighted fat suppressed in all planes. Angiogram, CT angiogram possible is much better than MR angiogram many times. Then you need to have a contrast imaging. You need to have a diffusion imaging. Let me give you an advantage of diffusion here. See this. That's the contrast picture. Now I'm bringing the diffusion. Many times you have been referred patients in children having a mass lesion like this, assuming angiofibroma. Diffusion is a bioimaging. It will tell you what is the tissue content. It tells you the water content in the tissue. So, malignant tumors have less and less water content, more and more nuclear cytoplasmic ratio. So, they are not going to give too much of diffusion, because diffusion is what? This MRI is like a magnetic field. It creates a magnetic field, and diffusion weighted imaging measures the diffusion of water molecules in the magnetic field. So, more water content, more diffusion. Less water content, diffusion restriction. So, see this on diffusion. On this diffusion is a bright, full diffusion. This is a tumor with full diffusion. That means it has more and more water content. It is unlikely to be a malignant one.
Right.
Just a couple of days back, we have been referred a patient with the same nasal mass, child, for angiofibroma, got the MRI, showing huge diffusion restriction. We took a biopsy, turned out to be rhabdomyosarcoma. So, diffusion only can differentiate, and identify the malignancy to a more than 98% of the time. We can, on the basis of diffusion, we can preempt the diagnosis of malignancy. So, all sequences of MRI are very, very useful to reach to a correct diagnosis, to get some useful information from some or other point of view. So, every sequence is important. So, adequate radiology is the key. Without that, you cannot, reach
Satish, the question was very specific. For angiofibroma, what radiology I should ask to my radiologist?
That's what I said, sir.
Yeah, so all this thing. Okay, I got it. So I think he got his answer. Thank you.
Yeah, the same one, what I said.
Yeah, true.
Satish, Dr. PSN Murthy, one last question. If you don't have all these facilities,
sir,
do you think a temporary clamping of the external carotid will do the job for a while?
Not really, sir. I don't agree with this. The reason being, distal clamping is not going to help, because this is not an end artery. Even if you clamp the external carotid, it is not going to affect the circulation there, because it has...
It's a very proximal, highly proximal clamping.
It has developed a lot of collaterals, and
the external carotid is not going to help, for that matter. It is not end artery. More and more distal clamping close to the tumor site will help more and more. That's why internal maxillary clamping helps more. More than that, if you do a microvasculature embolization right to the, microvasculature of branches of internal maxillary, it will help more. So, it all depends upon, kind of embolization is done. The, efficacy of embolization all depends upon the competence of the intervention radiologist, because otherwise it is sometimes risky as well. If your material happens to go into the internal carotid, circulation can give hazardous effects. That's been reported. So,
highly selective embolization is the key.
Yeah, yes. Nowadays, liquid embolization, highly selective embolization, yes, definitely useful. I don't deny that. It calls for a very, very competent work from the intervention radiologist. It costs like anything, which is again, sometime or most of the time, the cost is more than the cost of the surgery itself. Yeah. And if you follow a particular surgical protocol, that's what I'm going to share with you. Most of the time, you get away without embolization, without transfusion. So it's all depends upon planning.
I think most of what I have watched you hardly have gone for embolization. I just remember one or two cases where you
less than 5%
was from behind.
Less than 5% situation.
Yeah. Less than 5% was from behind.
Satish bhai.
Less than 5%. We can.
Yes,
Satish
sir.
bhai.
Yes.
Satish.
Yes, sir.
Satish bhai.
Yes, sir.
We can have rest of the discussion while operating.
Yes, yes.
Satish.
Continue with the session.
Yes, sir. We can have rest of the discussion while operating. Satish, continue.
So we can start our surgical part and we can continue the discussion later during surgery. Feel free to interrupt me any point of time. In a couple of minutes, we'll be back with the endoscopic picture. Hello. Hello.
Yes, sir.
One of the strategies our anesthesiologists adopt in these cases is to load with the fluid before surgery. Like this patient is loaded with more than a liter of fluid so that whatever blood loss happens is a diluted one.
Right, sir.
So the need of the transfusion is further reduced. Then this surgery is done under hypotensive anesthesia as well. Here the vessels are pure arterial ones.
How much fluid you give, sir, generally?
More than a liter, sir.
Okay.
More than a liter of fluid. And secondly, hypotensive anesthesia. Unlike sinus surgery, where the bleeding is mostly from the capillaries, here the bleeding is mostly from the larger vessels, arteries. So hypotensive anesthesia is the key in these situations. This is the primary picture. Are you getting the endoscopic picture now?
Yes, sir. Very clearly.
That's the tumor. That's the tumor going in the posterior part of the nasal cavity and nasopharynx. And see the intense red, angry kind of a tumor. So I'm just applying adrenaline on the surface. See, the moment you touch it, it starts bleeding. Even the slightest of the contact on the surface gives bleeding. Can you see?
Right, sir. But till now, tumor is not knowing who is going to operate him, sir.
Huh?
ट्यूमर को अभी पता नहीं है कि कौन उसको ऑपरेट कर रहा है. After that, it will stop pushing, sir.
You have to take the measures accordingly. So here, couple of minutes will decongest the surface. This tumor looks very vascular. I could see the arterial ramifications within the tumor, extensive ramifications. Looks very, very vascular. Let's see.
You are putting this adrenaline with Merosil.
Yes, yes. Initial surface decongestions on the nasal cavity. See this to open up the nasal space. Much better.
Right.
Tumor I have initially covered with the marrow cell so we don't come onto the surface with our instrument to damage it. Our goal is to give a modified Denkers first, so that we can, as I showed you on MRI, the kind of exposure we need. We need to remove this entire medial wall. That includes the lateral wall or the medial wall of the maxilla and the inferior turbinate as a separate bone. This is piriform aperture.
Right, sir.
So, and our upper limit is going to be the roof of maxilla, that is the floor of orbit.
Yes.
So here, वो दे दूसरा वाला देख. So first I'm using this coagulator band on the coagulation mode.
EVAC 70.
This is not EVAC 70. We use from ArthroCare Precise Max, and this is the different vein I've been trying from bones. Yeah, that's a different make bones in between just for the trial I've been using. See what I'm doing is surface coagulation.
Right, sir.
See this periosteum, which is richly vascularized otherwise. We have to keep all the time the fluid, this field better and better. See, this is my anterior limit. Now see for the audience, what is this here? Anteriorly, if you come to anteriorly here, this is your lower alar cartilage.
Yes.
So never come to anterior alar cartilage to give a deformity. See, I am right. If you come a centimeter anterior, you are going to damage the alar cartilage, and that's a disaster. Then you have to need to reinforce with the cartilage. Now, I'm using the cutting one. See, removing this mucoperiosteum.
Yes.
This coagulator doesn't work on the bone. Never try to use on the bone, otherwise that will ruin the band.
Okay.
This is my anterior limit. See the piriform aperture? This is the bone of the piriform aperture. Inferiorly, this limit is the floor of the nasal cavity. See this floor?
Right, sir.
Then this is the inferior turbinate, which has to go accordingly. If the bleeding comes on the bone, see this? Bone coming from the bone, never try to use the coagulators.
Okay.
This is the inferior turbinate, which is a separate bone which I am taking off. This is the bone of the inferior turbinate. See this? Bone of the inferior turbinate.
Yes, yes.
And this is where the inferior meatus is. See this inferior meatus?
Yeah, very clearly, sir.
Yeah. So now I can take all this inferior meatus, mucoperiosteum as well. You have to remove everything under vision.
For this bony part, you don't use debrider and other thing. No, only this coagulator.
Yes, the bony bleeding is never going to be come under control within a color. Band. Fast. The bony bleeding, let me tell you what can be done to the bony bleeding. See like this bleeding coming from the bone?
Yes.
I'm using my suction cautery, insulated suction cautery. See this?
Yeah, yeah.
On bone, never apply your coagulator. Here again on the bone. See this. So any bleeder coming from within the bone, see this?
Yes, yes.
You can apply your suction cautery rather than using the coagulator. Wherever the bleeding coming from the bone, you have to be careful not to use your coagulator. Bas. See now the field is good. Debrider. This part of the turbinate, see this? I can take away with the micro debrider. Band. You have to remove this inferior turbinate till the posterior wall of the maxilla.
Okay.
All this medial wall will go till the posterior wall of the maxilla. See the soft tissue you can debride. Bony part you cannot simply. This is the inferior turbinate bone. Irrigation all the way continues. This is what my assistant has been doing, irrigation, irrigation, irrigation. That's the inferior turbinate bone. See this?
Yes, completely out.
As you go behind, more and more bone has to go. Come later. Next one. Like this. Small pack. So now, this part I can leave here for a while. See this? My medial wall exposure is good now.
Yeah, almost
We'll
complete.
go further behind as we remove till here. Now we go to the anterolateral wall. And since the tumor is going far lateral, we need adequate anterolateral exposure. See, this is piriform aperture. This is my subperiosteal plane. Maintain this subperiosteal plane as you go laterally. There you divide the anterosuperior alveolar neurovascular bundle. By and large, your lateral limit is till the infraorbital canal. But nowadays, what technique Professor Paul Casanova introduced, we can even go beyond. Couple of times we do the transposition of the infraorbital neurovascular bundle to go even beyond. So now it is limitless. With the advancement in the technology, advancement in understanding the vascularity, equipments, surgical experience, this technique is becoming, the limit is becoming unlimited, sort of a thing. See, this is the periosteum which I am coagulating.
ENT surgery has become a game of power instrumentation.
Yeah, instrumentation has a big role.
Yes, sir.
See, now this part of the bone I have exposed has to go. And this way we will reach head on into the maxillary sinus. So this thin bone anteriorly I can punch out. Rest I have to drill, or you can use a chisel hammer. So if I drill here, I will be right into the maxillary sinus head on. See this. I will be right into the maxillary sinus head on. And then I will show you how much the bone to be removed superiorly, laterally, everywhere under vision. The most important structure coming in the lateral wall is the nasolacrimal system, which we have to deal with to prevent future epiphora. See, that's the entry into the maxillary sinus.
Right, sir.
No section. That's the interior of the maxillary sinus, you can see. A tumor bulge behind in the posterior wall. You can see that.
Yes.
So now you have to widen this more and more. This is my classical stylus from the Medtronic. This is coarse diamond, 4.5 millimeter. using 75,000 RPM with irrigation, under vision, 15-degree shaft, shaft not coming in the way. And it makes your life so easier. क्यों इरिटेट कर रहे हो? उठा लो ना, पकड़ लेना हाथ में, उठा। 1 घंटे में जाना चाहिए। See, my superior limit is going to be the floor of the orbit. We don't want unnecessarily accidental entry into the orbit at this place. I will further widen it more and more all around. This is our principal exposure, paramedian exposure to reach to the paramedian skull base. This you can do fast with the chisel and hammer as well, but that cannot be so precise. See the opening?
Yes, sir.
See the level of the roof of the orbit behind? See the level of the floor of the orbit. Now, since I have thinned this bone, I can remove it, punch out. See this?
Yeah.
Just behind is going to be the nasolacrimal duct. Behind the up is the nasolacrimal duct. This is your nasolacrimal duct there. Lower part I can remove. Duct is above. Wash. Yes. Now give me the drill further. See, I can go on, keep removing laterally till wherever we want for the adequate exposure. See that? Cobbleter. Cobbleter. See, whatever lateral exposure you want, you can take at this moment. See what I'm doing? I'm cobbleting this periosteum to stiffen, so it doesn't prolapse with the section inside. That's a very important point. Otherwise, it falls in with the section and makes your life difficult. See this? Give me the drill. See now? More bone we can remove now.
Yes, the cobbleter is the man of the match
throughout the surgery.
Yeah.
See, now more bone exposed, more bone you can remove. See?
Yeah.
Move complete, even if you want to complete anterolateral wall.
Yeah.
This is my left infraorbital now. See there.
Yeah.
That's the canal laterally.
Yes.
Here I am not going lateral to it. That will be adequate for me, as I am not going to, don't want to go lateral, as I will pull the tumor, whatever going laterally, under vision. See the exposure toward the floor. This now toward the roof.
Yeah.
थोड़ा पीछे करना सर. See, I am flushing with the floor. So I cut my nasolacrimal duct sharp close to the floor. If I leave it overhanging, it can get fibrous. So I don't want to leave it overhanging. You have to flush right to the floor. That is the key to prevent epiphora. See how superiorly we need to go. This is all bone over the nasolacrimal duct. Can you see?
You are making the nasolacrimal duct bare of the bone, and then you make a sharp cut.
Yes. Can you see the duct inside?
Yes, sir.
Yeah. Yes.
See the duct inside. See the duct inside.
Yes.
Drill. See how superiorly you are supposed to go. There's a very important catch point. And this drilling is so precise. It really, this cannot be done without such a drill. So precise. Okay. See the duct within the canal?
Yes.
So you have to remove the bone all around. बता दे। Debrider. See now, I'm just flushing it from all around. खींचो मत। See the bone all around, the duct being completely skeletonized. Drill. तो खींचो मत, खींचो मत। Scissors. See skeletonization. See now, being cut sharp. Hello.
Yes, sir.
Yeah, you can see.
That is what we want. एक बार में नहीं उठा। That was the uncinate process I removed. Could you see?
Yes.
Behind the nasolacrimal is the uncinate process. See this?
Yes.
Now, debrider. See what we are getting is this exposure, head-on exposure to the posterior wall of the maxilla. Could you see very clear or not?
Yes, very clearly. Very clear.
Above is your nasolacrimal system. See this?
Yeah. We could have, yeah, we could see the.
This is not going to come in our way now. Now, छोटे-छोटे दो पीस दे दो. See our tumor behind. This is the posterior wall of the maxilla behind. I hope the picture is good there.
Yeah, very good.
Yeah, very clear.
Now I will do some more work on the medial wall. This part I am covering the tumor. Yeah, one more. I am covering the posterior wall. Now this is the posterior wall, and I have to flush this medial wall all the way from floor to the orbital floor, flushing the entire medial wall completely. This tumor has a propensity to invade the inferior turbinate, propensity to invade the septum, but it never invades the sinus mucosa. It never invades the nasal floor. So accordingly, you have to take a call. See, you can keep optimizing your field by means of coagulating the mucosal surfaces. Bony surfaces you can remove. The all bones you have to remove. See this? Keep removing the bone. Now we will flush this with the floor. See this with the nasal floor. If you don't flush it, this will, hamper your instrumentation in the depth. So everything is being done for exposure. Now we have a good anterior exposure and anterior lateral exposure as well. See, our instrument should go inside uninterrupted. This is how the space being created for that. See this medial wall being flushed with the floor. You can see with the floor here.
Yes, yes, Dr. Satish.
At the same time being flushed with the posterior wall behind. See the posterior wall coming in pictures.
Yes.
Yeah, we can see that. Is the posterior wall thin?
Yeah. This is posterior wall. Divider. See, that's the posterior wall of the maxilla here. Where you see the tumor bulge.
No, is it very thin? Yeah, is it very thin?
Is it? What?
Is it very thin?
Yeah. Because of the tumor bulge, the wall become more and more thin with more and more bulge. See the remnant of the posterior inferior turbinate. See this?
Yes.
Now see more and more tumor surface is getting exposed, and this tumor is involving the middle turbinate. See this involving the middle turbinate?
Yeah. Yes.
More tumor surface is exposed, require more surface coagulation. This serves two purposes, not only to devascularize the surface and reduce the bleeding, at the same time allow the tumor to shrink.
So far, we have seen hardly any bleeding.
Yeah, just this is my more and more irrigation, which even gives you,
a much clearer field.
Irrigation is used normal saline or warm saline?
ringer or saline. See this tumor surface?
Yeah.
See the tumor surface, I am coagulating.
Yeah.
That's a part of the inferior turbinate. See, it has shrunken the tumor as well, along with devascularization on the surface.
Yeah.
This bone is the perpendicular plate of the palatine bone.
Yes.
This bone.
Yeah.
Yeah.
This has this anterior orbital third process and posterior sphenoid process, and in between them is the sphenopalatine foramen.
Yeah.
See this bone thoroughly.
Yeah.
So now, again, continuing the same thing. See this flushing with the posterior wall. See the posterior wall now.
Yeah.
See the picture, posterior wall completely flush with the medial wall.
Yeah.
No intervening bone is left. See this?
Yeah.
Yeah.
This is the kind of exposure which completes this modified Denkers. This is all posterior wall of the maxilla. Now what I am doing, removing this mucosa. Wash. Removing this mucosa from the posterior wall. See this very clear?
Yeah.
Exposing the posterior wall of the maxilla thoroughly. See, bone is distant at places.
Yeah.
And the tumor is bulging from behind, making this wall more and more prominent and distant.
Yes.
Now we have to remove this. See this thin bone you can pluck off.
Yeah.
If not thin, you have to drill off or you can punch out, whatever. What I am exposing is the pterygopalatine mucoperiosteum. Later. See the periosteum there behind?
Yes.
I can coagulate.
Yeah.
See this to make my life better.
Yeah.
That's the beauty of coagulator. Very good. Now I can take the help of bone punch, this Carrison punch.
Yeah.
You can use drill, punches, whatever. Remove this bone adequately. Nothing is hard and fast the way you are used to. You can do that. I been widening little more extensively because we have a huge lateral component.
Yeah.
I need to create adequate space to bring it inside. अब लेटा हटा हटा ये हटा तुरंत हटा दिया. See more and more periosteum in exposure.
Yeah. Yeah.
अब लेटा. Just a minute.
Satish, so there are a couple of questions from the audience. Can we
Yes,
take it?
please, please.
Yes, sir. So there's a question from Dr. Venkatasurya Madhuri Devi from Visakhapatnam, Andhra Pradesh. Sir, please comment on the role of dynamic MRI in assessing JNA vascularity. Role of dynamic MRI in assessing JNA vascularity.
Which MRI?
Dynamic MRI, sir. Role of basically MRI.
I just, your voice is breaking. Which MRI, boss?
Imaging.
Just one minute.
They have written dynamic
Dynamic MRI. Dynamic MRI?
Yeah, he is asking about dynamic MRI.
See, dynamic MRI is useful to assess the circulation. It helps in differential diagnosis sometime to differentiate the tumors like schwannomas from JNA, which have a contrast enhancement at certain part of the cycle after the contrast injection. Here, it is not so useful as far as the diagnosis is concerned, because here angiography is adequate to give you, information about the feeders. Diagnosis is based on the extensions. So dynamic MRI is particularly, I would say, not so essentially useful. That is more useful in the lesions of the parapharyngeal space, where you have a doubt whether it is a schwannoma, whether it is a paraganglioma, whether it is something else. So dynamic MRI is useful in places, but not very informative in cases of JNA, because that information we already have.
Yeah.
See, more and more exposure.
Yes.
Any other questions, please?
No, sir. As the questions come in, I'll let you know, sir. Right now, that is the only question.
Yes, please. Feel free.
Sure, sir. Thank you, sir.
The See, the focus is more and more on exposure.
Sorry, how far laterally you'll go?
Laterally depends. See, this wall I have given anterolateral exposure.
Yeah.
This wall I have given posterolateral exposure. Only this bone is left.
Yeah.
There's a centimeter bone is left in between. See this?
Yeah.
This is not an invasive tumor. This is just a pushing front curved section. I don't really need to remove this bone. There is not malignancy.
Yeah.
So I can pull out. I have adequate exposure to see from this anterolateral window and adequate exposure to pull the tumor from this posterolateral window. I don't need to remove this medial part of the bone unnecessarily.
I think once we have studied the scans and then we know where the extension is, it is the tumor which decides up to what extent we have to go. Will you agree with me, Satish?
Yes. How's the picture, sir?
Excellent.
Give the call later. About forces. Yes. Come later.
Dr. Satish, there is a question from Dr. Balakrishnan from Manipal.
Yes, please.
Please show foramen rotundum and Vidian canal. I don't think it is very significant here.
Yeah, I will show later.
Yeah,
I will show.
Yeah.
I will show later. Those are in close vicinity of the tumor involvement, but since they have asked, I will show.
Yeah.
Vidian must have been ruined by the tumor, but I will show you the location.
Yeah.
See the bone removal.
Yes.
See the adequate bone removal everywhere. Okay?
Yeah.
Come later. This is the periosteum. Now I will incise the periosteum. See what I have done? I have incised the periosteum.
Yeah. And separated.
to enter into the pterygopalatine fossa. That is the fossa per se, oblator. Now we are on the tumor surface.
Yes. Which part of angiofibroma is most vascular? Again, probably it depends on the feeding vessels, no?
Yes, yes. So by and large, peripheral part everywhere is vascular.
Right.
As it grows more and more, the central part becomes more and more necrotic.
Right.
See my vessel coming here.
Yeah.
Yeah. Yes.
Can you hold this? See, this looks like one of the vessels.
Yes.
What I will do,
Goblet it.
yes. Can you see the main vessel behind?
Yeah.
That looks like the main IMA.
Yes.
See, I told you I'm looking superiorly because my angiogram told me it is quite high up. See this?
Yes.
This is the
Yeah.
level of the floor. I am seeing so high up.
Yeah.
If you had seen the day before demonstration, it was showing 1.5 centimeters. So I went inferiorly and I found the vessel there.
Yeah.
With such a massive tumor, identification of the vessel is always a challenge.
Yeah. You need really a great exposure for that. And
I will show you exactly. Just I am exploring this region closely. Just a minute, just a minute. Just a minute. See the infratemporal fossa fat? Infratemporal fossa fat in picture? Hello?
yeah, please go ahead. Satish, there is a question when to clip and when to coagulate. I think
Clipping is a more certain method,
yeah.
more secure method. Coagulation of such a large vessel may not be so effective.
Right.
And this vessel, particularly when supply JNA becomes enlarged.
Maddo.
Yeah, that looks like our main vessel. I'm coming to in a minute's time. That's the main vessel.
Yeah.
I am working more and more laterally and up.
Yeah.
Because the tumor mass displaces. इसको pull कर, इसको pull कर. Just pull this a little bit. Pull this, yes. This is the vessel. Here, this is.
On the upper lateral part.
That's the main vessel. Can you see the vessel?
Yes, sir.
Later. It is so embedded within the tumor.
Yeah.
That's the important part of this surgery. Just keep opening up the space because I'm far laterally to take the trunk of the vessel.
Yes. We have to make space to put a clip or anything in that.
Yeah. Let's define first.
Yes.
Use tumor mass, use bulk.
Yeah.
That is the surface of the tumor.
Okay.
When you look for it, widen more and more surface.
Mm-hmm.
When you widen more and more surface, you get more space. Yeah. See one of the branch.
Yeah.
This is one of the branch. ये पकड़ ये this is the vessel.
Yeah.
There are n number of branches. Bigger the tumor size, more are the branches.
Yeah.
Every branch looks like internal maxillary itself.
Yeah.
Because it is enlarged.
Yeah.
So just have patience. Yes. Flip. Coagulate. I will coagulate this.
Yeah.
Every such bleeder can take you to the main vessel.
Yes.
Yeah, this is the vessel, one of the vessels.
Yeah.
See, I'm taking it off. See this, I am cutting it off
Yeah.
to go on the tumor surface. That is all tumor surface. One of the branch I have cut.
Yeah.
A lot of vessels in the convolutions of the tumor. See the area. We are right in the infratemporal fossa
Yeah.
with this kind of exposure. No. Okay. Yes. Yes. See, I am right in the infratemporal fossa.
Yeah.
See?
Can we get little more lateral exposure by cutting the bone?
Yes. Wait.
Yeah.
See?
Yes.
Little more lateral.
Yeah. Can we get little more lateral extension by cutting little more bone, drilling it?
No, not really needed. We have ample of space.
Okay.
This window, and we can see the tumor surface everywhere.
And a gentle pulling will not tear it off.
Yeah. So one or two branches we have already coagulated.
Yeah.
Cut. All this is all tumor surface.
Yeah.
Very nicely accessible. Give me a gauge piece. See, to orient you with the infratemporal fossa.
Yes.
बात करो. Hello.
Yeah, please go.
जी सतीश भाई, Dr. Dubey here, Bhopal. Hello.
Hello.
Satish bhai.
Yes, sir. I was on some phone call. Sorry.
Acha, no.
Sorry, please.
Nice to see you.
Are sir. Pleasure to have you always. So this is the exposure of the tumor, infratemporal fossa. You can
Yes.
see the entire surface of the tumor and see some of the
Fat.
intratemporal fat is coming in the view.
Yes, sir.
See, more and more infratemporal fossa fat you remove, you have more on the bigger part of the tumor surface.
Yes.
See, such a nice window you have.
Yes.
Later. We have more than adequate exposure for just coagulating the surface. Many of the branches, tumor branches. See, one more I am coagulating here and cutting at the same time. More you cut, more you release the exposure. Can you see?
Yes, yes. Most of the part is out.
I mean exposed.
Yes, exposed. And you always say exposure is the key.
See? Coagulate the vessel. See this?
And cut.
Cut. So this is way more and more tumor getting exposed this way. I'm looking for if some more, major tumor vessel if I come across. Rider. See the exposure of the infratemporal fossa.
Yes.
Later. Improve this fat, remove this fat and some soft tissues coming in the way to improve your further exposure. This could be one of the vessels as well. Tumor surface.
Good morning. Good morning, Dr. Satish sir.
Yes,
Dr.
sir.
Tushar Kanti Ghosh here from Kolkata.
Yes, boss.
Beautifully exposed basically. Now, you
My entire
target to cliff
infratemporal fossa
intermaxillary. Yes.
is exposed. Entire infratemporal fossa is exposed, and all the possible feeders on the surface I have
Yes.
coagulated here. Give me a gauge piece. Just for the timing, we'll leave a gauge piece over here with this exposure. Yes, boss. Anything to comment at this stage?
Just target to clip the intermaxillary artery, you know?
Yeah. So we found some of the branches.
Yes.
Supplying, coming on the surface, you know. With so many lobulation of this tumor.
So now no bleeding basically.
Yeah, the area looks good. That is the infraorbital nerve above, you can see.
Yes. Beautifully.
See the infraorbital nerve? See the exposure of the infraorbital nerve above.
Yes.
This is the complete exposure here. I'll leave it here for a while. And then we have this anterior exposure, we have anterolateral exposure. You can see. Now we'll improve our exposure superior to it, behind and medial to it. Give rider. Or give me the scissors. See the middle turbinate is involved here with the tumor. You can see very clear.
Yeah, so cut it, your target.
Below it is involved with the tumor here. I cut over here. Just above that. Like this. Divider. And then we'll go in the ethmoids and the sphenoids from above. Quickly. This is ethmoidal dissection. This one. Your lateral limit is the lamina papyracea. Quick. This you can finish off quickly. There is no. Just once define the lamina and then go along. Yes. See the tumor going up? Hello?
Yes.
See the tumor there?
Yes.
This is the tumor there. And that is the sphenoid sinus behind. Pass the close. Hear this. See this? The tumor from superiorly. Please see this. This is the superior surface of the tumor you can see.
Yes.
Very clear?
Very clear.
Yes. So more and more surface coming into picture, more and more surface coagulation is required.
See, more and more surface coagulation. I hope you are oriented.
Yes, sir.
Yes. See the interior of the sphenoid sinus below.
Yes, yes, yes. Likely optic nerve bulge.
That's the interior of the sphenoid
Sphenoid.
sinus.
Yes.
And this is the superior surface of the tumor. See the complete superior surface of the tumor. Complete superior surface of the tumor. See the medial and lateral tumor in continuity here. Hello.
Yes, sir.
Yes, yes.
So your target now posterior septectomy?
Yeah. So not now, but now this report the tumor since exposed. I will coagulate it first. Remove all intervening bone everywhere. See, now I will coagulate this entire surface. See the entire superior surface. Very distinctly. Is that clear?
Yes.
Your coagulator is the key. Hear this. See the superior surface of the tumor?
Yes, yes. Very clearly.
So this is all now medially. See there? This is the attachment to the septum.
Yeah.
Wherever it takes attachment, it acquires additional blood supply. Periosteal blood vessel. So here I have separated from the septum. Be very clear. See, completely separated of septum.
Yes.
Yes.
So quickly we have achieved the superior exposure. This is anterior exposure. This is anterolateral exposure. Tumor surface being coagulated all the time. And this is your superior exposure. Clear?
Yeah.
Right.
Leaving some right. Now we improve my medial exposure and exposure from behind.
I think Satish bhai, except from sphenoid sinus, it will take blood supply from everywhere it is attached.
Yes. Blood supply wherever it takes attachment to.
Okay.
Give me a pack, small pack. See the tumor exposed from so many sides.
Yes.
Now I will go medial to it. We need to have a full exposure all around when we pull it.
Right.
See this?
Yes.
Now, medial exposure. Okay. Yes. नीचे करो.
Sometimes nasopharyngeal attachment bleeds very curious.
Yes, yes. So what you need to do that, see now I am going medial to it.
Yes.
I am removing this posterior most part of the septum to go medial to and behind this tumor. This septal mucoperiosteum I am removing. This till the posterior edge, you can see.
Yes.
See this. This will give me opportunity to control the tumor from medial side, from behind, everywhere. See, you can go to the opposite side. So that's a very important part of the tumor control as well as tumor delivery. Can you see I am in the nasopharynx?
Yes.
These medial attachments invites the blood supply from the opposite side very often. See this? Very clear. Later, yeah. So now, I will cut off my blood supply coming from the opposite side completely. See this? This mucosal coagulation, submucosal coagulation completely lie in a linear fashion will rule out any blood supply coming from the opposite side. This has no attachment on the adenoid surface, never. Only this nasopharyngeal roof periosteum is the source. See the exposure from the medial side and behind? I hope you are oriented.
Yes, yes.
Tumor has been lifted. बता दे उसको. Yes. See posteriorly everywhere. What I have ensured, the nasopharyngeal roof periosteum. See this? This is the key which invites the blood supply from the opposite side, which I have completely, see this? Coagulated. Ensure there is no source of bleeding from the opposite side. Okay? See this tumor, which is the medial surface coming in exposure, being coagulated now?
Yes.
We have gone far medial and behind the tumor, the entire surface is being coagulated. See this? वो दे दे See the entire tumor surface being coagulated wherever it is getting exposed. Look at the tumor, look now. It was having such an angry look earlier when we started. You remember?
Yes, beautifully.
We have exposed from all around. Now is a very crucial point. To divide it in the midline, at the lateral nasal wall, to remove the medial component. Let me show you. See my basic exposure?
Yes.
That is the point at the junction of medial and lateral component. This is medial, this is lateral. Section. Can you see the distinction very clear? Clear or not?
Yeah, clear, sir. Looks like polyp only now. Bloodless filled.
It has blood bipolar. Now what I'll do before dividing with the coagulator, I'll take additional help from the bipolar here. See this bipolar?
Yes.
At this bottleneck. I'm using the bipolar at this bottleneck. Now I will use the calculator and divide this lateral, medial lateral junction. In a minute's time, this is planned division, so that we can mobilize the entire lateral component. Okay? Since it has a major lateral extension, so we had to resort to this planned division. Don't know. Connected? Any bottle? Okay, Viru. Where's the coagulator? खत्म हो जाएगा. Okay? Hello, पकड़ इसको middle.
Hello.
Hello, everybody.
Yes, Dr. Sotis.
Yes. Now
You are separating with coblation, lateral to medial.
Accepting little bit of the bleeding which will tackle, I am doing this planned division.
Yes, yes.
At the edge of this, see the bone there inferiorly, bone. See the bone?
Yes, yes.
This is a proper planned division. Full. See, with full irrigation. See the posterior wall? Expecting little bit of the oozing. See, I am just bang on the bone. See, this entire component has been pushed down. Can you see the nasopharynx?
Yes, yes, yes. You will now remove the medial part from the oral cavity.
Yes. See this bang on the bone, subperiosteal. See this mucosa, periosteum.
Yeah.
It's tenting. See this periosteal attachment?
Yes, 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 yes. An assistant role is very important. He pushes the tumor, so plane will be.
See this, it is free.
Yes, sir.
I can remove even through the oral cavity, nasal cavity also, not very big one. Give me the forceps. Clean section. Yes, pull this. See this? This is the medial component. Could you see this? Am I connected?
Yes, yes.
So medial component I have pulled. Section. See the nasopharynx very clear?
Yeah.
Some of the vessels here at the pterygoid zone you can see. This pterygoid bleeding is one thing you must understand, that this, see the bleeding coming from the pterygoid bone. This is difficult to control like this because it is mostly venous, and we'll remove this pterygoid process later. We have achieved, we have removed the medial part.
Yes.
And everything is under control. See this? Medial part has been removed, and we are ready to take on the lateral part now. See this?
Mm.
This section color. This pterygoid bleeding, the bony bleeding, wash.
Sometimes drilling required.
Yeah. It is always difficult to control, in the sense frustrating because it is venous bleeding. See this bone. So what I am trying to do here, I am using my section cautery over the bone for the time being. See this? Bleeding coming from the bone. Cobbleator. Now from this soft tissue can be controlled. See this? Much better now? Oh, no? Okay. Yeah. Color. See, whatever bleeder coming from the bone, see this? Never use the cobbleator over it. Yes. See, the field is good now?
Yeah.
So there are many ways to control the same bleeding. Now give me a piece of Surgicel. See this tumor which we have cut here is obviously going to bleed a little bit.
Yeah.
See this one. Now this surface I will press for a while. Under the Guru. Using the Surgicel in front will control for a while. See this.
Yes, yes.
There are ways to control the bleeding differently at different places. See the fill now.
Yeah.
So we have divided the tumor with little bit of the bleeding which was acceptable. See this. Now the main part we have huge lobulated tumor laterally which we have to bring out.
Yeah.
Watch please. These Surgicel is so good. Surgicel is what an excellent tool on the soft tissue surfaces. Just pack with the Surgicel and pack press on with the gauge piece. See everything, no bleeding.
Yeah.
Now coming to the lateral part. We took the advantage of this exposure and felt the various parts of the tumor in front of us. See this? I told you this removal of the lateral part now with this exposure is much, much easier. Much easier than removal of the medial part.
Yeah.
Yes, yes, yes.
You have to hold it, advance your hold, and keep bringing this tumor out and keep using your cogwheel on the interface. See one of the big vessels. Huh?
Yeah.
See now? I'll separate this vessel from the surface. Yeah. So anyway, see now the most important part. See this tumor being held. Section. One more concept. Can you see?
Yeah.
Yes.
Yeah,
Just
very
beautifully.
clearly. Very clearly.
The tumor. So one by one we are advancing our instruments to pull it. See this tumor which is being pulled.
Yeah.
Now see that such a big tumor being pulled.
Yeah.
See this surface. This is all, oh, what a massive one.
Yeah. And the surface don't have any adhesions. When we pull it out, there is no any bleeding.
This is pushed.
Yeah. So
I have removed my gauge piece.
yeah.
Yeah. आगे से पकड़, वहां से पकड़. Hold, advance. See, that's the tumor lobulation. And this is what I'm separating is the surface structure. See this? This section with the coagulator only.
Yeah.
Advance more and more. Pull it. Okay. Pull it more and more.
And with coblation, surface bleeding will stop.
Cleaning the surface. See that? There are surface vessels. Surface vessels. Yeah, I'm cleaning the surface.
Yeah.
Right. Everywhere. Just clean the surface of anything else than tumor. Do this.
Yeah.
Tumor has been pulled and held medially.
Yeah.
See how the adhesion being taken.
Yeah.
Just beautiful.
Stop later. Wait. See all the surface adhesions. Going into the tumor. You mobilize the adhesion, move the tumor is coming inside. See now the last bit of the tumor.
Yeah. So nicely come out.
Yes. Small vessels to tackle with coagulation.
Yeah. All.
If interested, you may get back, no?
More these adhesions I will not know the tumor will be released.
Yeah.
Basically, it is coagulation and irrigation that is going to help you. You don't have to put a pack and wait for it to come out.
No, it has to be done under vision. See now?
Yeah.
Adhesions released and tumor is
delivered.
Under vision, you have to see slowly after releasing adhesion, the tumor is got into the nasal cavity. Can you see?
Yeah.
The entire tumor is now in the nasal cavity.
Yeah.
What irrigation? Remove this.
Normal saline. Normal saline.
Yeah. Wait. Tumor is forced in the nasopharynx.
Yeah.
That looks like the vessel behind.
Vessels.
Can you see that?
Yes.
Yeah.
What I will do, just give me a clip. See this vessel?
Yes.
Most of the branches we coagulated.
Yeah.
And I'll put a clip here. Give me the coagulator. And cut this.
Yeah.
Now my tumor is placed. Oh. Give me a pack for a while. Just to see the structures better. I'll show you. Things are under control. A tumor I have put in the nasopharynx. I will show you. See now. Metal part where we remove the tumor is being packed. Okay?
Yeah.
See this part. I will remove the pack and show you later on.
Yeah.
Where is the tumor? Tumor is here.
Yeah.
What's this about? I'll take section in other hand. Yes. Now see where the tumor has come. Some more parts are there. I will show you.
Yeah.
The tumor is here in the nasopharynx. See the huge tumor.
Nasopharynx. Yeah, yeah.
Entire lateral component has been pushed in the.
Nasopharynx.
See this? This one.
Yeah.
Maybe too big to be removed from anteriorly. Lux. See this?
Yeah, yeah.
Oh my God.
Yeah.
Beautifully.
Big one.
Yeah.
Big lateral component.
Yeah.
Dumbbells.
Still we have some of the tumor remaining in the pterygoid and in the orbital fissure. See now the nasal cavity is opened up again.
Yeah.
Remove this lateral peg. Give me a wash. Give me a section. Come out the bleed, the lateral part. See now with this section, you can control any bleeder.
Yeah.
Yeah. Later. That is the remaining tumor above.
Yes.
Little bit.
See the infratemporal fossa surface. This is
Hello,
this.
come on.
This is a little bit of the pterygoid. Little bit of the pterygoid venous oozing. That's it. Nothing much.
நாளைக்கு வராரா 7 o'clock புக் பண்ணிட்டேன் ஒன்று சொன்னோம் வெப்பன்ஸ் இருக்கேன் வந்துடுவாங்க
Dr. Guru Swami from Mysore. He is asking what is.
See, this is the pterygoid component here. This is the tumor.
Yes.
See the infratemporal fossa, which is empty now.
Yeah.
This is your temporalis muscle. You can see laterally.
Yeah.
This is temporalis. This tumor we have removed from 2 centimeters below, pulled out everything. Little bit of the, this little bit of the pterygoid venous oozing, hardly
Oozing.
anything, hardly anything. You just pack. I will leave a cervical control. We have already clipped the vessel distally, further distally after removal of the tumor. See, this is infratemporal fossa. See this. See your can you see?
Yes, yes.
Yeah. This is your lateral pterygoid plate. See everyone?
Yeah.
This is pterygoid plate. This is lateral pterygoid plate. This is pterygoid fossa containing the tumor.
Yeah.
Now lateral to this is all musculature. See this?
Yes.
Yes.
Where the tumor was occupying and we have pulled out completely. See this?
Yeah.
Only muscles, nothing else.
Yeah.
So this, I'm leaving this gauge for a while. Now we have an important. This entire pterygoid is involved in the tumor.
So that is to be resected, and these are the potential areas. If we even leave a smallest part of the tumor, then it is a chance of again coming back.
See now, yes, exactly, sir. Now the tumor is left over. In the pterygoid process, pterygoid fossa, this is going to the inferior orbital fissure. See there up. This is superior orbital fissure and posteriorly it continues with the cavernous sinus. So one by one we will remove this thoroughly. First of all, let me open up the pterygoid fossa. See this under.
Yes.
I am removing this bone. See the tumor inside.
Yes.
See the tumor inside the pterygoid fossa. How did I know? From the
From
scan.
our, yes, scan.
Tumor is occupying the pterygoid fossa. The bone on the surface was looking normal.
Yes.
And see, now what I will do, one by one, see my tumor? Can you
Yes,
see
yes.
the V2?
Yeah, excellent.
See my tumor?
Yeah.
Section lagao. Yes. Look. Yes. Yes. See what I am pulling. Section lagao. Yes.
Yes.
See, I am pulling from the superior orbital fissure. That's the
Yes.
component which is coming. So, come on. See carefully. That's a very important part.
Yes.
See where it is coming from? Superior orbital fissure, which is in continuity from the cavernous sinus. Can you see this?
Yes.
Where this tumor has come from?
Yeah.
Behind is the cavernous carotid where my suction is.
Yeah.
See the space
Yes.
from where the tumor has come out. That is the superior orbital fissure and the component which was pressed in the cavernous sinus. See that?
Yeah.
This venous oozing is expected. And
Yes.
see, upar bhi karna. See my V2 laterally, that is going in the foramen rotundum. Somebody was asking, this is the foramen.
Yeah.
Here. Okay.
Yes, perfect.
Now I will surgery cell. Yeah, I will remove that.
The pull has to be very gentle, Dr. Satish. Otherwise,
Very gentle, very controlled.
because if you break up, then it is a bit more tedious to take it out, that small part.
Yeah, and never pack hard with the surgery cell. You
Yeah.
know, the nerves are in this. You never advocate packing hard in this region.
Yeah.
This all venous bleeding, a little bit,
Yeah.
which will control anyway. अच्छा surgical take. अरे यार. See, I'm looking for a small piece of surgery cell. Yes, this was pushed up. Now with the gauge. Section there. Section gauge. See this? This is a very important part.
Yes.
We could easily pull it.
Yes.
I told you, see the lateral component came out so easily.
Yes.
The skull base component came out so easily. What all these extensions which are frightening you, believe me, are not difficult to remove. Now the pterygoid component, the huge pterygoid component, see the tumor there.
Yes.
See, in the cancellous bone, see the bone underneath.
Yeah.
See how it comes out. It has to be a pulled, point out. I'll tell you how to pull. It should be a controlled pull. Let the bleeding come. Don't pack so easily.
Yeah.
Because we don't want to pack the tumor.
Yes.
All that. Yeah. Just to show you. Yes. Pterygoid bone.
Yeah.
See the tumor?
Yes.
Don't break it. See this. It should come out intact. Can you see?
Yes.
Yes. Yes.
Very
See
nice
the
case.
honeycomb bone.
Yeah.
See the free bone, honeycomb bone.
Yeah.
That is how a pull is. A controlled pull to selectively remove the tumor without breaking it. Could you see the movement?
Yes.
how it was pulled.
Yes.
That's a very, controlled movement. The way this is all the remnant tumor part. See the tumor bag
Yeah.
within the pterygoid fossa. Debrider. To me, the tumor has been completely removed.
Right.
Now, this honeycomb bone, I told you, when you remove the tumor from the pterygoid fossa, it has to be a controlled one. Secondly,
Yes.
it's press with gauze or anything. If you press with anything, you can press the tumor inside.
Yeah.
So always allow the bleeding to come out. Gallbladder. This is healthy bleeding coming from the pterygoid. See that?
Yes.
See this healthy bleeding? This won't allow the tumor to.
Yeah.
That's the pterygoid fossa. This honeycomb bone now, I am completely going to destroy it.
Yes.
The reason being, this could be a potential source of so-called recurrence. To me, the tumor has been completely removed. Now, give me the blood. Now, I'm not using the previous course diamond burr. Now, I'm using a different burr. You see, this is a pure. A bigger diamond burr to flush it completely. See this bone, how it is being removed.
Yeah.
This is dealing with a very good process to make sure that no tumor is left behind.
Yeah.
See this?
Dr. Satish, if you don't have the specialized burr, can you use the diamond burr, fine diamond burr?
Yeah, you can.
Yeah. But it has to be more controlled.
Yes. Now, somebody was asking about the video. Now,
Yes.
see here. This is your median canal. This one.
Right.
This one here. Later. See, this is how you have to fill off the pterygoid.
Yeah.
You have to flush the entire bone, not leaving any space there. Yeah.
So, Dr. Balakrishnan from Manipal, you have seen both foramen rotundum as well as the median canal.
Yes. And I have drilled this median canal. See, my median nerve is there.
Yeah.
Now see the bone.
Yeah.
Why I'm flushing this bone? I want to ensure that not even a microscopic residue left behind.
Left behind.
Yeah. Later. Now, first of all, from below, see that this is pterygoid muscles below.
Yeah. Yeah.
This is pterygoid muscles. And what you see is this venous bleeding from the pterygoid plexus. Can you see here?
Yes.
That is easily controlled with the Surgicel. Give me a small piece of Surgicel.
Satish, Dr. Udhav requested to show palatovaginal canal in relation to median canal.
Yeah, palatovaginal canal is infero-medial to it, somewhere here, which probably we have, destroyed now.
They are destroyed.
Now give me the drill further to remove. See this entire bone. Can you see better? No tumor
Yes,
anywhere?
yes, 100. Yeah.
and shift further. This is something you cannot do or don't do in open approaches.
That's not possible.
Yes. Probably later. This is all venous bleeding, healthy bleeding.
Yeah.
See, this is thyroid fossa from below.
Yeah.
Now I will show you all this anatomy in one go.
Yeah.
Remove all packs in spite of little bit of the oozing. You section work. Now see one by one to all areas. See, they are up. This is onodi cell and the optic nerve above. Can you see above there? This one.
Yes.
This is your sphenoid sinus. Can you see? Okay.
Yes.
Now this is your pterygoid base. Sit there.
Yeah.
See, this is pterygoid base. Absolutely clear.
Yeah.
Pterygoid fossa. See the bone. Completely. All honeycomb bone drilled of the sphenoid sinus. That is onodi above.
Yeah.
Now coming laterally. See, this is pterygoid. This
Yeah.
is the superior orbital fissure. See.
Yes.
See, this is your V2 going below.
Yeah.
V2 is just lateral to the section here.
Mm-hmm.
And superior orbital fissure is just above.
Yeah.
Section करना ऊपर. Section. ऊपर कर करो. हाँ. This is your section करो ऊपर. Yeah, this is your superior orbital fissure.
Yeah.
See that?
Yeah, it's clear.
Below is the V2.
Yeah.
This is your superior orbital fissure. Below is the V2. Now, here laterally. This is your infratemporal fossa.
Yeah.
Now, give me one by one. See everywhere, no tumor.
Yeah.
See the huge infratemporal component.
Yeah.
We have removed. So now, one by one, this is the Surgi cell or the soft tissue bleeding coming from the infratemporal fossa. See that? Just press with the Surgi cell, we'll remove this gauge.
Yes.
One. This is your pterygoid fossa and the pterygoid process.
Yes.
One. Press with the
gauge piece.
Yes. One small. This is for the superior orbital fissure.
Yeah.
Small gauge. Small gauge. See that?
Yeah.
Give me a gauge piece. For the nasopharynx to see.
Yeah.
So now, good.
Yes, see this oozer from the nasopharyngeal surface. Give me
Yeah.
coblet. This is just above the eustachian tube. See the eustachian tube below? See the nasopharynx pretty clear?
Yeah.
Just final touch going on.
Yeah, yeah.
Yes. Yes, just a minute. Yeah. Yes. Oh. See the bleeding from the bony surface, you know?
Yeah.
Or you could use a diamond, dry
Yes.
diamond, like we use in otology. See now all surfaces.
Yeah.
This is again for your information. That is onodi. See above.
Yeah.
This is sphenoid sinus.
Yeah.
This is your pterygoid complex. See where
Yes.
see my Sergi cell in the supraorbital fissure.
Yeah.
And now
Satish, again, Dr. Uday is asking, should you drill pterygoid plate as a precautionary case in all cases or
yeah,
based
depending
on
upon
your...
the radiology.
Right, depending on the radiology.
See now.
Yeah.
This is your infratemporal fossa.
Yeah.
With my Sergi cell in place. Can you see?
Yes, yes.
Pterygoid with the Sergi cell in place.
Yeah.
Sphenoid, onodi,
Yeah.
supraorbital fissure, everywhere.
Yeah.
Give me a small Sergi cell more. So you can ensure, see this panoramic view.
Yeah.
Yeah.
Full panoramic view to see all area. That's the beauty of endoscopy.
Yes.
Not only intraoperatively, but post-operatively as well. You don't need to go for the radiology unnecessarily. See now the nasopharynx.
Yes.
See the adenoid surface, which is always free.
Yeah.
Later. Adenoid surface is always free. No bleeding at all.
Yeah.
Excellent view.
Good job. Good job. Now, precautionary, I have already done. See now what I am doing? Coagulating the naropharyngeal roof periosteum.
Yeah.
See all extensions of the tumor.
Yeah.
All the anatomy. See the pterygoid process. See how it is cleared up.
Yeah.
Only flat bone all around. See this flat bone?
Yes, yes.
If I drill this flat bone, the temporal lobe is there up.
Yeah.
Up there is temporal lobe. From there only it enters into the middle canal fossa.
Yes.
Same way you have to pull it. That's it.
Excellent.
This is how you can remove the juvenile nasopharyngeal angiofibroma. And we have not transfused yet any bleeding, any blood.
Yeah.
See that?
Yeah.
Just we will give it a
Beautifully demonstration.
Yes.
And beautiful cleans.
Any bleeder, you can look. Any doubts? See now. But we still will pack for a day or two, and then we'll advise this patient juicing. That's
Yeah.
it. That's the final picture.
Yeah.
Yeah.
Thank you.
Any questions before we move to the Dr. Haldipur with another case?
I don't think there is any. Let me see.
The absolute hemostasis.
Yeah.
We haven't transfused any blood.
Yeah.
See, all extensions.
Yeah. Yeah.
So that's the approach. Thank you very much for your attention. Thank you. Thank you once again.
Excellent, Satish.
Yeah.
It was a treat to watch such an extensive surgery being done, which looked so simple in your hand.
I know it. See, this is anybody can do is doing endoscopic work.
Yeah.
We have to follow the principles of endoscopic surgery. And in JNA, we have to follow all principles of exposure and taking vascularity and control, use of coagulator.
Yeah. And we should respect all the landmarks before destroying them, any of them. And then we should first deliver the tumor and then take care of the other areas.
Yes, yes.
Thank you very much, Dr. Satish.
Thank you. Thank you all for your attention, and big thanks to Dr. Haldipur for giving this opportunity again. Thank you all, sir.
Thank you, sir.
Thank you, sir. Thank you.
Thank you.
Dr. Ghosh,
I think we'll wait for the feed, sir.
Yeah, it's there. Feed
Yeah.
is on. Yeah.
So meanwhile, we'll start. So we had excellent session from morning, starting with Dr. Deepak Haldipur sir, and followed by Dr. Satish Jain sir. All of you, and thank you very much. We have seen the large number attendees attending the program, and large number of postgraduate as well. Now we are moving to the third surgery, which is adenoidectomy and population. And we have two eminent doctors who will be chairing the session. Dr. M.K. Rajashekar sir. Sir is a professor in the department of Sri Balaji Medical College, Chennai. His specialization includes sinus endoscopic surgery. First surgery done by Dr. Ashekar sir at Government General Hospital way back in 1997. Surgery for obstructive sleep apnea. First surgery done by sir in the Government General Hospital in Chennai in 2015. And it was such a thing first, so it came in all the newspaper about this surgery. So thanks very much, Dr. Ashekar sir, for joining in, accept to be chairperson. Then we have another eminent doctor as chairperson, Dr. Naveen Patel sir. Dr. Naveen Patel sir is a senior ENT and head and neck surgeon. He's practicing since 30 years at Life Care Hospital at Ahmedabad. His special interests include transnasal endoscopic skull-based surgery, cochlear implant surgery, coblation tonsillectomy, and endoscopic adenoidectomy and transoral laser surgery. He has a special interest in pediatric OSAS and has largest series of more than 1,100 coblations assisted tonsillectomy and transoral endoscopic adenoidectomy in India. So, Dr. Naveen Patel sir, thanks very much for accepting to be chairperson for this session. Over to our chairperson to take the session forward. And the surgery is done by Dr. Tushar Karthikosh. He's the director of Ghosh ENT Foundation, senior ENT consultant at Apollo, Emory and Columbia Asia Hospital. establish an independent hospital, Ghosh ENT Foundation, and perform more than 20,000 surgery throughout the career. And he has conducted several surgical workshops on otology, endoscopic nasal surgery, and coblation. Also, is an active member of Indian ENT Association, highest cooperation user in Eastern Indian surgical faculty in several workshops. He's been invited as a surgical faculty nationally and international conferences, and he has several publications and is associated with JP Publications over a video atlas for ENT. And he is received prestigious Bharat Ratna Rajiv Gandhi Gold Medal Award for outstanding individual achievement in medicine and research. So, Dr. Tushar Ghosh, it's a pleasure and privilege to have you, sir. Over to you, sir. And over to Dr. Ashekar, sir, and Naveen Patel, sir, to conduct the proceeding. Sir, you're on mute, sir.
Just
Patel,
unmute
sir.
yourself.
Sir,
Naveen, sir.
Unmute, sir.
Yeah, it's really pleasure to be moderating Dr. Ghosh. He is a very nice dear friend, and Dr. Ghosh, over to you. You can start with the case introduction.
Yes, sir. Basically, it is a nice, and thanks Dr. Holdipur and Micro giving me this opportunity. I will show some cases. Basically, adenoid tonsil is the common surgery, Dr. Holdipur, common surgery by expert, how it will be managed easily. So, according to time, if permits, I will show some cases. First case, I will show the big tonsil and adenoid and 9 years of age. So sometimes age increases and adenoid fibrose. So I will show how it will be managed comfortably. So first case and then another case according to time. Okay, permit. First case I will show. Now just 1 second. So this is the normal tonsillar position and sandbag, and I use the microscope. Definitely if you use the microscope, then it will be very comfortable.
Yes, doctor, it is a very good important thing for all the beginners.
Yes, yes.
You switch over to microscope, and don't do a tonsillectomy with headlight. You have an access to microscope. You are a microsurgeon.
Yes.
And use microscope. It makes your tonsillectomy and adenoidectomy very easy, very comfortable.
And if you use the microscope, you will see every plane.
Yes.
I will get plane. I will show.
Ultimately, it's a precision, Dr. Ghosh, right?
Yes. Precision. And look here, this tonsil is the buried tonsil, no?
Yeah.
Not plane is clear sometimes. So how we manage? This is a difficult tonsil. So with coblation, it will manage. First, you just is the art. How will we manage this case? So it is here up to here. So I will first look at the plane. Just look at the plane. If your plane and the blue line will be there, and this is the under microscope is very much visible. Okay, look here, the beautiful plane has a big tonsil, and now I am going the laterally. You see the big tonsil.
You are going from superior pole to inferior pole.
Yes, first I am always prefer the superior pole, sir.
Right. So it is in a deep buried tonsil. It is easy to start from the superior pole. Go to the spine connective tissue plane and in the band facing the tonsil.
Tonsil, yes, sir. Look here, is a very difficult case. So I selected this case because sometimes easy case look easy, no? So how will manage the difficult case?
Exactly.
Yeah. So my target is the plane, to get the plane. Look here, every structure. Now, how to reduce the bleeding and how to reduce the pain? Because this is a tonsillar tissue. This is the peritonsillar fiber. So my target here, okay? Just easily like pen holding.
So remaining in connective tissue plane, doctor, right? Remaining.
Yes, this is the plane. So without microscope, this plane not identified properly. Okay.
So you are avoiding injury to the muscle, which in fact reduces the pain.
Yes. This is the beauty of coblation and beauty of microscope also.
Yes.
Look here. Is a huge buried tonsil.
Yeah.
Still. And grip change. Look here.
Yeah.
Look here. This is the different bleeding. No bleeding at all during field. Look here. Simply, slowly. I am removing the only tonsil. No. Look.
Near the inferior pole, tongue is coming very difficult there. No.
Yes. So don't hurry. Slowly. All tonsil will be removed very beautifully. Okay.
So Dr. Ghosh, which I have been describing and telling a lot of audience that this is like a book. You are opening it up like a book and
yes, sir.
Tonsillar pillar.
Yes, look how easily just
rolling it over to the posterior.
I have seen your lecture also. This book, I look here and don't search the plane. Just plane will be coming automatically and don't search the pillar. So if you remove the tonsil only, the pillar will be clearly seen.
So rolling it over to the posterior tonsillar pillar, right?
Yes, sir. So slowly, I'm moving. Now, if you see, here not clearly seen. Okay, so just leave it and just change the position and just pull it.
Always work with the magnification and with the vision.
Yes. Now slowly here, if you more scared, there is a chance of bleeding. Here, slowly and slowly, and just stop. Okay, so easy surgery, but sometimes we face all difficulty during normal conventional system. Okay, and also there is a lot of question. Second, reactionary hemorrhage, no, I have not seen. Definitely you have not seen also. There is a chance of reactionary hemorrhage. But to prevent reactionary hemorrhage, I follow some technique. How? This way, I rub it. Okay. If any oozing, capillary oozing, I just coagulate it to prevent the secondary hemorrhage. Okay, this way. Okay. If any bleeding point, automatically you'll remove. Now, this is the left-sided tonsil. I will do with left hand. Okay.
What is the temperature delivered at the end?
Temperature 55 to 60.
55 to 60 degree, yes.
Yes.
Younger generation.
Basically cold ablation.
Cold ablation, yes. And now my assistant press the uvula to avoid any injury of the uvula. Look, here is the buried tonsil.
Make sure that your suction doesn't catch the
yes.
A lot of uvular edema.
Yes, look here, this is the difficult case, all also conventional, no, because they're totally buried. Okay, how will manage? Look here, and here, pushing, here the last point of tonsil. So I always prefer the upper pole and left hand, tonsil left hand. Okay, look here.
So don't cross over the hand. When you are doing left hand, you hold it with right tonsil and work with left hand.
Yes, sir, left hand. So for junior, you should practice accordingly.
Practice, yes.
Initially, otherwise, sometimes the problem will be seen.
So the coblation setting, what you are utilizing is 7-3 or?
No, sir. I prefer 9-5.
9.5. So
initially for beginner,
yeah.
I always I ask, okay, you start with 7.3,
Yeah.
but when will be expert? Look here, still now not plain sim, too much buried.
Yeah.
Yeah.
So you are using 9.5 now?
Yeah.
Yes, sir, 9.5, totally 9.5. In adenoid tonsil, all time 9.5. Initially I also 7.5, but now for last few years, I am using the only 9.5.
So technically you are utilizing 9.5 for more coagulation and more cutting power.
Yes, sir.
Yeah.
Especially in adenoid, I don't prefer any coagulation, only ablation. Any bleeding point also I will show. The bleeding point also I will do only with ablation. This is the plane, okay?
Yeah, yeah. Nice plane.
Yeah, so good microscope, under microscope is possible, otherwise it's very difficult to get the plane.
Yeah.
So if you get the plane, look here, this is the tonsillar tissue, anyway, this is the peritonsillar fiber. So my target this plane, just like pencil. So beautifully it will all be clear. This is not a easy tonsil, this is a difficult tonsil. So for juniors, if you know the plane, the tonsil will be easy with coagulation.
So for the junior colleague, it's like peeling an orange out of an orange peel.
Yeah, this is the plane.
Yeah, you are working in that peel or that loose area or connective tissue plane.
Water. And water, you see always one sucker in oral cavity, okay? And also I prefer all time is the jet flow water flow.
Do you use a pressure cup around your
Pressure cup, sir. I will show the pressure cup. Always I prefer the pressure cup. In adenoid very much, tonsil less, but definitely use the pressure cup.
Use 4 saline?
Saline, 4 saline and 3 liter bottle. Because during changing I don't prefer. So in workshop, different area, I have not seen the 3 liter bottle, 1 liter bottle. So during surgery, I should change, But if you use a 3 liter bottle, then not required any changing.
3 liters. Yeah, good.
Yeah, 3 liter. So I will show here. Look here how I will manage the lower pole because there is a big tonsil. So microscopic position change and also my hand change. Look here. This is the lingual tonsil. So I will remove that part, and this is slowly because all juniors know, and with stress, sometimes pull. If pull, there is a bleeding, chance of bleeding. So don't pull, slowly, just do it, okay?
So be patient with the tonsillolingual junction, right?
Yes. So you will be definitely, you will be happy, after saying.
RBC. Coach,
yes.
RBC.
Hello?
Coach, I am not seeing even RBC.
Thank you. So without any bleeding, all difficult tonsil will be tackled easily, So this is the beauty of this coagulation. So
you've been using EVAC 70 extra HP, right?
Yes. And also the few minutes back, Satish says, Jane, with the man of the magic was the coagulation, Satish. Jen, tell me frequently. So here also the man of the magic is the coagulation. If you know the coagulation technology, if you know the art of this, and your life will be more easy.
Yes.
And you look here that in tonsil, no bleeding at all, and just rub it or scratch it to see the any oozing or not, no oozing. Okay. So you'll enjoy and you love to do this surgery. If time permit, I will show some cases. I posted some cases because sometimes there is a chance of by chance cancel or fever. So I posted a lot of cases. Already I have done 2 to 3 cases, because they are very kid, 12 up to 12, sometimes difficult. So I will show some cases, how we manage, and all juniors will enjoy to see the cases. After that, they will think that is very easy surgery, how will be difficult. Okay, I will show the how. This is the palate retraction, and now I will show the bending of the coblation wand, and how the wand will be same wand. I will show how it will be bent, and I will do the adenoid is a different position. Look here, my position. Today really I am happy, Deepak Huldipur giving me this opportunity and sharing the stage with like you all are stalwarts basically. I am the very junior person, I am the small ENT surgeon, but and also I am lucky enough, I am doing in front of all stalwarts. Yes, sir. Yes, sir.
I have been always talking about a transoral endoscopic adenoidectomy instead of changing your position.
Or transoral, 70.
Yeah, you can still remain into the same position. I have been propagating that.
Yes,
you have to see your technique also going from transnasal route.
Transnasal, yeah.
Yeah.
I normally will do with 0 degree endoscope, 2.7 pediatric endoscope. Okay. Look here, I am bending here this way, 30 and 60 this type, 30-70 or this way, just not acute bending is the. So here, this case, nearly grade 4 adenoid. How? This is the, I follow some technique, okay. So first I prefer from upper pole, okay. And lot of people not doing the coblation, and they told that this is a lot of time the coblation if used. But definitely you are the expert, definitely you know the not taking too much time. I will show very less time, no? How? Yes, look here how this way, from upper pole, upper pole.
You're starting at the upper pole.
Yes.
The Koina side.
Yes, I always prefer the upper pole, and I don't prefer any bleeding. I hate the bleeding during coblation technology. If I use the coblation, why unnecessary bleeding? No. This way, just movement. Look, my movement, my hand movement, all is very important for junior. So if you
So for all the junior colleagues and for the colleagues, he is utilizing wand with the movement. He is allowing the plasma to do the job for him.
Yes, because you are not a god basically. Though basic funda is the 0.5 milliliter gap from the tissue wand, but that is not possible. So I prefer the water pressure and the plasma. Look here, this is the plasma. If you use the more plasma and with the water irrigation, the beautiful plane. Look here, the beautiful plane. And look, my target first debride the tissue, and after that I will show the every plane, every boundary of the adenoid.
Yes. So what you are aiming at is typically a unique property of coblation, which is volume reduction of tissue.
Yes, volume reduction first. Yeah. Then I will show the how. Look here.
Oh. You pull it out from superiorly and you are going laterally now.
Yes. I will show every area of the water. Water pressure is very important for my surgery.
You show me how you are using
pressured cuff around the bottle is a very, very important thing.
No, I use a different way. I will show.
How you are using the water pressure.
Okay, I just showing just after few minutes. So here lateral side. No, how will complete the fossa progemoid? I will show the different technique I follow. First, the pressure not too much lateral should not go, because the if bleeding not under vision that part. So just after completion I will show how. Now the inferior part. Look here. Look my movement.
So more irrigation, the blockage of wand will be avoided, no?
Yes, I don't prefer in brass in my instrumental, I don't use any brass because the lot of workshop area question was sir, how will be clean, this is a blog, repeated, no. How will blog basically? If you fully irrigated, no, and movement, free the movement. Now you see how will we manage this part, no? This part is the pressure. Look here, this is the one technique. I will show the three technique. The fossa proximal area, three technique. This way, this is another technique, okay? This way, the pressure. Just give the pressure. Okay, another technique is you just engulf, because this part, no, sometimes hypertrophy after few years. So you just engulf this part, and you will see the fossa proximal area more. And another is you may use the angle endoscope. I always use the 30 degree endoscope, pediatric endoscope. I have, because you should require, sometimes if you face the bleeding, no, you just look this area, okay. So normally not required, because if you careful, this all area will be clear. No, I will show how much clearance. Now anterior to posterior. Now I will show the posterior part, the seed, the perimysial seed. I will show how is it clear.
You are aiming at the buccopharyngeal fascia actually.
Yes, buccopharyngeal fascia. Here the pharyngeal muscle, longitudinal capitis. Look here the buccopharyngeal fascia. Okay, you are happy? Yes. Definitely you appreciate. Yeah, okay. So no injury of the muscle. No charring of the muscle, no injury. So I will not break the fascia. I am not interested to break the fascia. So this is the beauty of this surgery. 100% removal, and you just give the guarantee to the patients, no chance of recurrence, because this is not a cancer tissue, no. So why there is the unnecessary recurrence if you do your job properly, no.
So if you block the fascia, you eliminate chance of recurrence.
Yes. And also I just leave some thin layer of the tissue, unnecessary, not required. Now this is the beautifully done, okay? Yeah. So you will enjoy the completion. If you see that, definitely you will appreciate the completion of this area, and also I will remove that area. Periosteal sheath, basis sphenoid periosteal. Look here. Yeah. This is the basio-occiput area, okay? Yeah. So you will appreciate, definitely you will appreciate to see the clearance. No, this is the beautiful clearance, okay? Yeah. Now you see from anterior to posterior, how much big adenoid is that, but no bleeding at all. You have not seen any hemoglobin RBC also, okay? Now this part, this way just debulking. Firstly, I will do debulking. Okay, and there is a chance of bleeding if you go this way, okay. And how will bleeding control? Any bleeding, just keep this way, just this way. Don't require the coagulation, just only ablation. So here I will go that opposite side, okay. This is the more comfortable. Yeah, this way. I go upper pole and this movement this way. So to avoid any bleeding, should do this way.
Very beautiful. Why did start at all touching the tissue?
Look here. Just, and if you go more medially, posterior part is septum, there is a chance of bleeding. Just keep away from this, okay. And look here. And you also enjoy the watching of the adenoid, no? How, without any bleeding, how the operation will be completed. So also you will be very happy. Okay. Sometimes Ebola will be disturbing. You should be careful because there is a chance of Ebola injury, okay?
So what you are actually aiming is removing the volume of the adenoids with hemostasis.
Yes.
And for which you use a pressure jet of your saline, which is a very
Yes.
technique for the beginner.
Very important. Look here, how I will manage.
And allow the plasma to do the job for you. Don't use it as a dissector. Yeah.
Only use the plasma. Look here. How. Sometimes this part will be ultimate difficult. There is a chance of block. So just move it. Movement. Just free movement. So there is no chance of block. And tissue will be.
If you char the tissue, it's very difficult to remove.
Yes.
The patient doesn't penetrate into charred tissue, so you have to be very careful. And
If too much charring, then problem. So here I am facing the problem because the uvula disturbing. So I just again I'll fix it. Change karo. So disturbing the uvula. So otherwise I complete in one shot.
Yeah.
I don't know. Next second. Yes. So sometimes this way you should your vein should movement different way, no, to avoid the uvula injury.
Yeah.
And also deviated septum. This position is very comfortable.
Yes, sir.
You are in this case no deviated septum. You are very comfortable now.
Sometimes if you want to take biopsy, this part is possible to take the biopsy. But normally I don't prefer. Look here, how I avoid the block. If there is a chance of block, stop it, and slowly go slow, and then automatically block will be clear. Okay, this is the another technique.
Yeah, you use the pool of saline.
Yes.
To relieve your block. You don't have to remove the vein. Use the saline itself to relieve your block.
Just a second. Problem with uvula.
What I do, Dr. Ghosh, is I use two catheters instead of one.
Yes.
To both the nostrils, I put two catheters so that they are absolutely out of view.
Oh, sometimes problem solve. No.
Yeah.
1 minute. Just 1 minute. দাঁড়াও না, আমি বলছি এটা শোন। কেন? So nearly completion, no? You will be happy.
Completion, almost completion. You are almost in the verge of completion.
That part only, during that part, you just take this way movement. Otherwise, sometimes muscle movement will be there.
Yes. There's the muscles contraction of passive and
yes.
That's the area where you get your passive hands reach, so it contracts.
Yes. So this is the passive hands reach, no? So
yeah.
This way slowly. Slowly you will complete your surgery. And after completion, you should check also tonsil position if later on any bleeding point is there or not.
Yeah.
So if any fog of your you ask assistant to give the yes. This way we prefer. All our assistant trained, so they give the water irrigation. Okay. So endoscope clear and area also cleared.
Yeah.
Now you are happy, nearly completion. Look here, this is the perimyceal seal, buccopharyngeal fascia. And
so the beauty of this machine over the debrider is that
yes,
working even into those venous plexus still doesn't bleed because it coagulates.
And also the beauty, I am not charging any. I am not taking any injury also to the buccopharyngeal fascia. Okay, I am working over buccopharyngeal fascia, but no way to the injury to muscle.
Yes.
Look here, how beautiful, no instrument. Look here.
Yeah.
So if you are doing practice, so beautiful. Okay. So 100% removal, no, without any charring.
Yes.
And I prefer sometimes 1 or 2 thin layer. One layer if preserved, then no problem, because that to prevent the muscle spasm. Sometimes patient complain.
Neck pain.
Neck pain, yes. So I also ask the any pain, no problem. Any pain clear gel also is sufficient. And you see the definitely you will enjoy clearance, to see the clearance. No, definitely you will appreciate the beautiful clearance. No.
Yes, doctor.
So just after few days you will see the one scar mark and all tissue will be there removed. After 1 or 2 months, only scar mark. If you do endoscope few days after, then some slough, some thick exudate will be there only. Okay. So my lateral boundary and upper boundary all will be now the boundary full. I will see the full.
Yes.
Upper pole, lower pole. Okay. The perseverance ridge and laterally. So you are happy. The fossa Rosendo area already. Yeah. This is seed beautifully. And this is the shunt tube.
Good dissection.
Okay. So definitely you will be happy after seeing this type of clearance, no?
Yes.
And look here, beautiful clearance.
Yeah.
Thank you so much. And also you see,
very good.
you should see no bleeding at all.
Yes.
So time is there, so I will show my next case. Okay.
Show me the bottle.
Any questions, sir?
External device, yes, that is what.
Oh yes, external, yes.
External devices, the pressure.
How my position here? This is the position, and show the that portion. Pressure back. So the pressure back. This is this. So this is the look here.
No, camera is not there. Camera.
No. This. This is the pressure bag. Okay, look here. How? This is a 3 liter.
And then you put a pressure bottle.
Yes. And this is a 4 liter, not 3 liter. 3 liter normal saline bottle. Okay, and it's a more comfortable. And one case is more comfortable. Otherwise, if you place the 1 liter bottle and the pressure bag, then should change, because I always maintain the free water flow. So this is the beautiful, and some definitely you should ask some question. How will be managed? Patients will be managed, and sometimes patient complain pain. Okay, definitely. But in adult cases, definitely sometimes patient complain pain. But in case of kids and here also pain is very less, and also secondary hemorrhage very less. If you know the proper plane, because you have seen my dissection. During my dissection is the buried tonsil, difficult tonsil. But here I always follow the tonsillar lymphoid tissue. So lymphoid tissue here and peritonsillar fiber all time. peritonsillar fiber. So I'm using my wand over the lymph tissue, not the peritonsillar fiber. That is the beauty. Okay. So just pulling slowly, automatically, leaving the behind the peritonsillar fiber, not exposing any types of muscle basically. That is the beauty of this, and also headache-free surgery. If you do the case, and after that, just 4 hours after, so all patients will be discharged. Though no headache at all, basically. So previous days, conventional definitely tonsillectomy. Sometimes, if you are expert also, we have faced a lot of time the sometimes bleeding, primary hemorrhage, reactionary hemorrhage, all time. Secondary hemorrhage definitely here also may we face, but here that is a beauty. Here the not too much secondary hemorrhage, should not go in OT basically. Just counsel the patient and just tablet, tranexamic acid, sometimes injection. That is sufficient to reduce the bleeding. But in case of conventional, sometimes you should go the OT theater to reduce the bleeding, to control the hemorrhage. Okay, definitely. Yes, sir.
The commonest question which me, you, or all the surgeons are asked: what is the rate of secondary hemorrhage in your series, in your patients? How much secondary hemorrhage do you see with coagulation? Because coagulation is always blamed for increasing secondary hemorrhage because of previous malicious reports. Now, what is your experience? This is our real Indian experience.
Basically, I think that is the totally different system is different. If you do the properly, secondary is very less. Because comparison, what is the comparison basically? You are expert. If you are a professor of the one institution, you have done 20 years conventional tonsillectomy, suddenly you just grip, suddenly you adapt the just 1 month coagulation tonsillectomy. Then you are comparing your experience 20 years conventional and comparing with the 1 month expertise with coagulation. That comparison totally wrong basically. But if you adapt the technology and long year, no learning curve will be there. And when you are expert, then is no headache basically, no. So it's very negligible secondary hemorrhage, and all assurance to the patient, don't panic if any spotting in any capillary oozing. No, just take the tranexamic acid and cold water gargling. And believe me, for last few years, so definitely I am doing a lot of cases. And also, I can't remember any case admitted in our institute or not, basically. And no OT, at least no case in OT after secondary hemorrhage. I have never fell after coagulation.
So
that is the main beauty of this.
How many cases you use one wand, same wand?
Basically, if tonsil adenoid, big adenoid, sir, one wand will be finished. And also, I ask the party, I will fresh one. Sometimes in case of during septoplasty also, some adenoid is there. So, I take the old wand also. That is the honest speaking. But in case of kid, also I always take the fresh wand.
So secondary hemorrhage is increased if you reuse the wand.
Yes. That is also.
Don't reuse the wand if you are doing a tonsil adenoid together.
Yes.
The same wand. So you are utilizing same UX70 for both the things, the tonsil and the adenoid.
Tonsil adenoid, okay.
So you
basically
used up. These wands are made for roughly about 16 minutes of a continuous use.
Yes.
If you do a tonsil and adenoid together, probably you are nearing that age of the wand, the lifespan of the wand. So do not reuse the wand. That is what is our strong recommendation.
Yes, if reuse and then no plasma, sometimes as a diathermy cautery, then there is a chance of bleeding, no?
Chance of bleeding.
So yes. So if you learn the technology, if you adapt the technology, and when you are expert, definitely, then life will be simple, sir. In case of tonsil adenoid and adenoidectomy, you think about adenoidectomy, there is very negligible. Only adenoid. So this case only adenoid. So here I will show. So adenoid, how much age and grading. And I always prefer the all cases
Great.
Endoscopy. Great, and endoscopy examination, not X-ray. I don't believe properly with the X-ray. X-ray definitely patients came with my in my center with the X-ray, but I always prefer also endoscopy, because if I sure this case will be comfortable with the look here, this case. Look here. 1 minute, just. If I am comfortable, the patient will relieve with this operation, then I will only do. Sometimes X-ray is very difficult to assess. The adenoid is there, but that adenoid creates a problem in ear, or really recurrent sinusitis or recurrent nasal problem, recurrent fever. So you should first assess the patient. You should look here after palate retraction. This is a huge adenoid here. So assess with the endoscopy, and endoscopy also correct way, not above, place the above, not below, this way, and panoramic view or should be there. This is the proper endoscopy, and all septum, upper part, lower part, palate, comparison with palate, all are required do endoscopy. So here, look how will we manage this way. So now again the same concept from upper pole. So this is the beautiful instrument. So
you start at the roof of the nasopharynx and assess and reach up to the fascia right from the beginning, so that the plane is defined.
Yes, yeah, because I prefer always from above, upper pole, because always very easy to get the plane. Because sometimes from lower pole get the plane, sometimes it feel difficulty. So I always promote the just take from above. Also my junior all of and also in different workshop I am showing this technique, and always lots of doctors also following this technique, and they also enjoying this way, because if you go this way there is a chance of bleeding. Here I will show this way there is a chance of sometimes bleeding. Don't go this way, this. So because your electrode all time you are under vision. Your electrode under vision, look, and ground electrode also under vision. So this is the very important. If you go beyond your so time is less, and bleeding basically in case of children 2 years. Yesterday also I have done one 2 years and one 2.5 years. So that is very difficult with micro debrider, no? Yeah. But I'm sure if I put the endoscope one shot, I will remove all adenoid tissue.
Yeah, so your preference in a younger children is removing both tonsils and adenoids together, or only?
Yes, no, only adenoid. Sometimes only adenoid, because if no complaint and grade 2 tonsil, I don't prefer the tonsillectomy also.
Okay.
I always I ask the adenoid is the main culprit. I don't believe the tonsil is the main culprit. In my practice, my experience, that adenoid is the main culprit. If you do adenoidectomy, lot of problem will be solved. Sinusitis in case of children, sinusitis, all are due to adenoid problem. Recurrent cough and recurrent fever also due to adenoid, because the adenoid obstruct the pathway, no? So adenoid. So there is a chance here. Look here, the fossa of Rosenberg area. How will manage? Because if you manage this way, there is a chance of bleeding. So take this way. Pressure, and this way. So there is so because the hidden area, no, this is the hidden area.
Right.
So this way, otherwise for juniors there is bleeding, and then you will be tensed, because that part is the hidden area. So that way you just take that way. Take the pressure, give the pressure, and you will see. and also that part is to remove.
So
In microdebrider, that part removal is very difficult. But with coblation, this part is easy. Because if you see after doing the endoscopy 4 years after, sometimes this is the hypertrophy. No. So you just do this way. And also fossa Rosenthal area also will be clearly you see. So this is the also tricks for juniors, how will we manage that area.
So there is a association between the sphenoid sinusitis and adenoid hypertrophy in children's. So
yes.
Regulations, if you see an adenoid, get on the CT scan of PNS to rule out the sphenoid sinusitis.
Yes, sir. And also pediatrician does not believe. Did not believe. Say doing the CT scan, no. But believe may not require any CT scan. Just if you do CT scan in case of adenoid, here the bleeding, no. Not coagulation, just ablating. Use the ablation. And the pediatrician also, the sinusitis, they are interested more sinusitis. Because in definitely your experience also, you are very experienced surgeon. If you do adenoidectomy properly and give the was, no, sinusitis all will be clear in case of children.
So in a given scenario when there is a coexisting sinusitis, what is your take? Do you go for adenoidectomy first or you wait for the sinusitis to resolve?
No, I do adenoidectomy and just explain the party and good irrigation and good antibiotic that is reduce the sinusitis.
Okay.
And if frank polyp
covered the adenoidectomy.
Yes, if frank polyp, then the different scenario. Yeah. If only secretion, no, light, little bits. I have seen lot of cases also. The Prompok, the party, no, already different doctor told that sinusitis is there. I told, I do the definitely MMA or something, but definitely you will see that nothing will be there. Yeah. If only secretion. So if you don't do any sinus surgery also, big adenoid is there, just clean the adenoid beautifully and just wash only few days and good spray, anti-allergic, good antibiotic, that will be clear everything.
Okay. So this is a common problem which you will face when you have an associated coexisting sinusitis. Just don't believe in only treating the sinusitis, remove the adenoids and then treat sinusitis vigorously.
Yes.
In a pediatric age group, the sinus surgery is not a common thing which you offer.
Yes. But main problem is some advise the CT scan, no?
Yeah.
But we believe the endoscopy examination. So in our OPD, all time we do endoscopy, every kids with the pediatric endoscope.
Do you use a pediatric scope?
Pediatric scope and flexible scope also.
Flexible scope.
Mainly pediatric rigid scope. Yeah. But if not cooperative, then pediatric flexible scope also we have.
So, and how do you grade them? What is your endoscopic grading of the adenoids?
Endoscopic bleeding.
Grading. How do you
grading? If touches the palate, then grade 4.
Yeah.
And basically if touches a huge adenoid, if this block the institution tube,
yeah,
then moderate to large basically, that should, if patient complain the ear problem, then you should do encounter the. And also if a small adenoid not blocking the institution tube, there is a mild adenoid, mild moderate severe tube. So
you grade them according to your endoscopic image.
Endoscopic image.
In the palate, it is almost a severe adenoid for you.
Yes. Yeah. If it touches the palate normally, sometimes if breathing forcefully, then opening, just slight bit opening, that is should encounter the problem. Should do. And also if you see the institution tube blocking will be there. The block and also patient complaint is there here, recurrent OME, then you should do. Otherwise, moderate adenoid, sometimes you may observe with conservative treatment.
Okay.
But more than moderate, you should do surgery. Patient will be benefited because he comes to doctor because there is a problem. Repeated cough, repeated fever, recurrent fever, and also the facing problem, no, growth hampered. If big adenoid, no, there is a total well-being, hampered well-being. This is a good common surgery, but neglected by pediatrician or also some ENT surgeon. But
there is a big discussion among the pediatricians to remain conservative.
Yes,
the patients about the role of immunology.
Yes,
that this is going to affect the immunology. So we'll have to become aggressive in telling our patients that look, it's not going to disturb your
immune system. And first of all, and also going suffering every month.
Yeah.
Also, if you do the adenoidectomy and once a year, suffering will be less. But still pediatrician also told the no, adenoid is required, adenoid is reduced, and also series. I have series, no, 55 years, 35 years, 32, 56, all are huge adenoid was there. And teeth alignment also different, no?
Yeah.
But still all are theoretical. The adenoid will be reduced. Adenoid will be reduced automatically. What is automatically? How reduced? Lot of pediatric OSA patient convert to the adult OSA problem.
So neglected adenoids, even on the part of ENT surgeon colleagues also, is to be warned that we'll have to really be conscious towards removing adenoids at an early age.
Yes.
Yes, they are actually future OSAS patients. So if you don't do that at right time, they'll end up into
This is a station tube opening also, good AROA, no? So these patients now also suffering. And all time, I ask the patients, if you do the adenoid surgery, no, repeated suffering, and prescription of the pediatrician also will be less. Because the thick prescription volume, no?
Yeah.
Lot of prescription. When adenoid will be done in once a year recurrent cold fever. Okay. Only vaccination required.
Okay.
Look here, the beautifully.
Yes.
So here up to Passaman's reach, complete adenoid removal. Yeah. So above to downwards. Look here, from above to downwards, and you will love the technology, because if you know the technology, if you do the surgery, no bleeding at all, no?
Yeah.
Here, and why unnecessary bleeding, packing, bleeding? In bleeding also just this way. And also after surgery, just water irrigation, okay? So that will reduce the slight bit of exudate. Water, cleaning water with the, yeah. So, look here beautifully, and also if you see some tissue, no, and above this part, this is the shunt tube. That part also sometimes required in case of young adult also. Don't live this way. So definitely you will appreciate the cleaning with the coblation. Look here. So it's very easy, no, looks very easy. Look here. So look, the beautiful clearance. Look here. Definitely, sir, you will appreciate.
Yes.
This is the technique of cleaning, no? 100% removal possible, and width of few minutes, 15 minutes, and also 6 minutes. Now your question or some question arises. Yes, sir.
So in an endoscopic adenoidectomy, not the blind technique is gone.
No.
Always an endoscopic adenoidectomy, doctor. Exactly right. The message, please pass on that endoscopic adenoidectomy is the practice. It's a standard of care.
Yes. Without blind technique, I think should obsolete.
It's obsolete.
Yeah, obsolete. You have no coblation. Definitely, you may do with micro debrider, but you should know the perfect technique. Otherwise, all are not very expert with micro debrider. No, sometimes I have seen in micro debrider also the lot of injury, and also the scarring, also a lot of injury. But you should know the technique properly. Otherwise, very difficult. I will show one case. I think time is there. One case I will show. One tonsil again. Otherwise, that case was difficult case. I'll show one adenoid tonsil, and I finish within of 30 minutes again. So my time is up to 2. Definitely, I will finish. I started late. Still, I will finish within 2. So definitely you will enjoy, and all juniors also enjoy. There is a bread and butter, tonsil adenoid, but tonsillectomy with the simple technique and adenoectomy with the endoscopic adenoectomy should do properly. Is the tonsil adenoid to both? So here is a big, show the picture. Here also endoscopic picture. Look here, the big adenoid. Okay. So all time we prefer the endoscopic picture first, and definitely my suggestion, when you first do the surgery, before that you just put the one antibiotic course. Definitely you will also your Texan. You will prefer the one antibiotic course, good antibiotic course, because I have seen a lot of patient. I have seen congested adenoid, sometimes thick secretion. If posted after 15 days, no, again there in between the day there is again chance of infection. So I prefer all time before operation 5 days or 7 days antibiotic, because this type of problem I have faced. Now you may comment about this.
So basically, a course of antibiotic ahead of your surgery, just last 1 week, is better than,
Yes.
and then you are not operating an infected tonsil.
Yes. Also adenoid, sir.
Also adenoid also.
Definitely, yes.
If you one course of antibiotic, bleeding will be less.
Course of antibiotics, sir. So for juniors, the same position, but microscope. Take the microscope. Otherwise, it's very difficult.
What is the focal length of the microscope? Length 200 or 4 or 300?
Oh no, sir. 250. 250 for magnification. 250. Here I am using the extradovarioscope, but this is the 250. 250 around, because it is a varioscope, so slight bit of changing maybe. But when I use a normal OPMI, the lens 250 is a sufficient, sir. Here is the varioscope.
So basically, you don't have to change the lens of the microscope. It is 250 is sufficient for your tonsil.
Yes. Tonsil 250 is sufficient. But this varioscope advantage is the larynx, no? So should not change. Hey, And this is from beginning, the packing.
Dr. Ghosh, there is a question from Dr. Anand Acharya.
Yes, sir.
Can you please comment on the capsule of the tonsil? The capsule of the tonsil is one which is going to show the dissection plane, Dr. Saib.
Yes, basically it is the knot.
Explain them, how do you create a plane between the tonsil and the tonsillar capsule?
Yes, sir.
And do you prefer doing a tonsillotomy? Do you do a intracapsular tonsillotomy?
So basically, this is the not properly intracapsular, but partially intracapsular. Yes. This way, but sometimes intracapsular, sometimes in tonsillolith type, sometimes tonsillolith, or sometimes any cyst. This way, just like adenoid, is the tonsillotomy possible? But I less prefer. Sometimes also to remove the controversy, styloid removal. Sometimes I do, sometimes tonsillotomy. But normally I prefer this way, this technique.
You prefer extracapsular tonsillectomy, the classic tonsillectomy.
Yes. Right? Yeah. But capsule not properly exposed.
Yes. So you are going to be between the capsule and the tonsillar tissue in that loose areolar tissue plane.
Yes, loose areolar tissue plane. That is the beauty of this coblation. Otherwise, very difficult. How will we manage in conventional technique? No.
So a lot of people have been propagating the intracapsular tonsillotomy, and that is also the technique which people follow. But in Dr. Ghosh's case, he is doing tonsillectomy.
Yes. Look here, sir.
Yeah.
This is also buried tonsil, okay?
Yeah.
Look here the movement. No, here you see the movement?
Yeah.
So here, up to here the tonsil is there. So pull it. First pull it. My target is get the plane, no?
Yeah.
So, if you're not getting the plane, that is a problem. This is the plane, okay?
Yeah, yeah. So anybody who is watching this, please note that the vent is facing the tonsil. It's not
Yes,
the
sir.
other way around. It's never facing the capsule.
Look here. This is the tonsil, this is the peritonsil fiber. Here will be the capsule. So, basically not propagating the intracapsular, but look, capsule will be preserved, no?
Yeah.
This is the plane, no, sir? Look here.
Yeah, you are seeing a
Beautiful, beautiful plane. That is the magic of this technique. If you get this plane, no, operation will be very simple. Look, beautiful loose area tissue will be preserved.
Your vent is towards the tonsil, not towards the bed of the tonsil.
Yes. Then slowly.
The vent is constantly facing the tonsil.
Yeah. Like friendly attitude with the tonsil, not with the muscle. Now grip change, okay?
Yeah.
Look here. This is a beautiful plane. No, here just this way.
So the beauty of microscope there, you will never leave behind the tonsillar tags.
Yes.
See, he is dissecting the tonsillar tags also very carefully because he has a microscopic vision.
So microscope, lot of advantage. Demonstration also, recording also, training, teaching also, all. That's very easy, no?
Yeah.
My all juniors now doing the same technique. Okay. Look here, this way.
And the last request for a fantastic tea. Pentaprolol 15 liter, dog ठीक है, especially the request for the harmonic. Okay.
This way, pull this way, and pull this way, and here, look here, slowly.
So tissue under tension is better for dissection.
Yes. And don't pull too much, then there is a chance of bleeding.
Just
slowly.
Gentle tension, yes.
Yes. Slowly and slowly.
Yeah. Traction, counter traction, traction, counter traction.
And some doctors prefer also coagulation here, but I don't prefer too much. Some doctors prefer this way. So I do this. I use always ablation basically.
This is a very good coagulator actually.
Yes. If you do slowly, look here, the beautiful, no drops of blood basically. So, and just this way. Okay, now we are happy, no?
Very good. हनी बारी मैंने लास्ट टाइम आपकी जो थी नॉर्मल दवाई वो दी मैंने उनको एंटीबायोटिक वगैरह गरारे भी करा लेकिन वो
Say any comments?
No, beautiful doctor.
Thank you. Sir, you are the master. So, sir, you are the master. So, any comments from the master?
No. Excellent, Dr. Ghosh. Excellent.
Yes, thank you.
You are demonstrating clearly how to go into the correct plane. It's a plane which is very important.
Yes, plane. You look here again. Left hand, left tonsil, left hand. And pull. Don't cross your hand. So initially life you just practice properly.
We need good experience. You are using left hand, no?
Using left hand.
Very neat.
Also, some juniors also started, sir, I use the right hand, I am practicing, sir, but not required, no.
There's a paratonsillar vein. There's a paratonsillar
Yes. So if you see the paratonsillar vein, you coagulate from above.
Yeah.
Just above, okay.
Yeah.
Normally, if you maintain the plane,
You are above that tissue. Yeah.
Yes. Look at the beautiful plane.
Paratonsillar.
Every time, beautiful peritonsillar fiber. Look here, the peritonsillar fiber.
Yes.
So just
paratonsillar vein should remain on the capsule, never with your tonsil.
Yes.
That's the correct plane.
Yes, this is the correct plane. Look here. Look the tonsil and the peritonsillar fiber. So now the easy job, no, childish job. If you know the plane, don't search the posterior pillar. If you remove the properly tonsil, automatically your posterior pillar will be there.
The voice change would come if you produce injury to the posterior tonsillar pillar.
Yes.
To the anterior pillar. So make sure that you preserve the posterior tonsillar pillar correctly.
So water should be collected from the oropharynx. Otherwise, the problem.
Should be collected from the oropharynx.
Tushar.
Yes, sir.
I am Dr. Sanjay Agrawal from Indore.
Arey, boss.
What a wonderful demonstration.
Thank you, sir. Thank you. Arey, you are the master of masters, sir. Yeah, thank you, boss. Yeah, look here. No RBC during the surgery, no. That is the beauty, no. If you shows the parents, no, this type of surgery, so definitely he or she will be interested. If you lingual tonsil will be there also, just do this way. Okay. So this is the just beautiful tool if you know the technique.
True.
So I prefer the one sucker always in the oral cavity, okay? This is the oral cavity. My assistant doing the job, but here anyway removed.
So you put a soft rubber catheter via the nose into the
This the look here, this. This.
Yes,
See?
yes.
This is the more comfortable, no? All now here, if you see the any just after operation, always should check if any red area, any RBC, just do coagulation. Yeah. So just rub it, because to prevent not primary hemorrhage, to prevent the secondary hemorrhage, because slight bit of oozing sometimes due to after removal of the crust. No, sometimes slough is there. No, sometimes slough will be there. So
for the audience, we all coagulation surgeons see a lot of slough. Don't get worried about this.
Yes, just gargle.
Gargle.
Gargle is enough. Look here, no bleeding at all. No, just rub it. Rub, scratch, rub. If you're look, scratch, rub. Definitely you are happy after seeing this type of tonsillectomy. No headache, no. Just 2.5 minutes, 5 minutes, tonsillectomy finish, headache free surgery. Now I'll show again the adenoid.
Your post-operative instruction to your patients. How do you manage them post-operatively, brother?
Basically, simply same day after 3 hours food. Okay.
Yeah.
First liquid ice cream, and kids are love ice cream, to take the ice cream.
Yeah.
First ice cream and then juice type, juice juice type, and at night discharge, definitely after afternoon discharge. At night semi-solid diet. And from next day, sometimes some kids are not preferring take the food, but I force the party definitely should take the proper hard food. Chewing, basically all pain due to muscle spasm. So chewing and talking too much. Sometimes kids are prefer not to talk too much.
Which gargle do you advise? What is your gargles which you advise?
Gargle basically hexidine type gargle more common. Sometimes some mixing is there. One is the Culora simethicone type composition. Slight bit of soothing effect is there. And also now I prefer last 1 year Disprin also with Disprin tablet. So pain will be a slight bit of less. This is a gargle and good antibiotic. Clavulanic acid, amoxicillin clavulanic acid, and good one painkiller 7 days. And also I prefer, for my printed paper is there, SOS tranexamic acid, because sometimes after 10 days you have seen slight bit of sometimes spotting blood coming after 10 days, 12 days, sometimes up to 15 days. So I ask the party, don't panic, just take this tablet suddenly, and then if you require the call me. So otherwise sometimes patient will be very worried, mouth bleeding oral cavity. So this is not common in kid, this is the adult.
So secondary hemorrhage is two types. One is called venous small clot.
Yes, this is all of venous.
Arterial. So when you have an arterial secondary hemorrhage, that is the only one which will require return to an operation theater. The small venous clots don't get panicked, they'll get washed away.
Main beauty is the coagulation surgery. We have never seen any arterial bleeding after secondary hemorrhage. No, that is the. Look here, the huge adenoid.
Yes. Endoscopy picture, please.
I saw.
We have external picture. Please put endoscopic image, please.
Slight bit of spar is there.
Okay.
The huge adenoid, no?
Yeah.
So in case of huge adenoid, I from next day I will prefer also both way tube. All time we are learning, no, during any workshop. So still now today I am putting the one catheter, no. So from tomorrow I will put the same time two catheter also.
Yes.
Yeah, that is the very good point. Sometimes use a huge adenoid. So how huge adenoid we manage?
Yes.
Look here. Definitely I will finish off 2 p.m. My time 12 to 2 p.m. Look.
So you showed varieties of cases. You showed 2 tonsillectomies, 3 adenoidectomies.
I have also said two cases. I will finish after that, because sometimes I have put here today also 7 cases. I don't know, different cases there, but 7, because if one case is cancelled or one case is fever, something is a problem. No, in workshop that is a very problem. So in workshop all time I prefer, in last with the Deepak Haldipo I have organized one workshop. At that day 20 cases I have kept, because if less case and cancel is there, then problem started.
Yes.
The workshop main is the case, no. Theoretical discussion, okay, fine. This is another conference is there, but workshop means workshop.
Workshop, yes.
So case.
Yes.
So case is the main.
Yeah. So you start off at the roof of the coina and start at the roof.
Yes, again, main is from upper part, roof of the coina. Sometimes definitely you have face also the 2 wand required. 2 wand.
Yes.
Huge adenoid.
Huge adenoid. You may require one more additional vent to be opened up.
Yes. And also just I have done one case, one ENT surgeon's son.
Yeah.
So he astralized the huge adenoid, but young adult.
Yeah.
So then I saw that two hands, but sometimes is huge adenoid and adult adenoid also, no?
Yes, yes.
Oh,
Anal
very
adenoid
difficult.
is very difficult adenoid is actually.
Yes. This is a slight bit of age is more and huge adenoid. Sometimes also you have seen the homeopathic adenoid,
Yeah.
a fibrotic adenoid. Because homeopathy, sometimes I have faced a huge adenoid and very fibrotic.
Yeah.
All are homeopathic adenoid. And you ask the party, all are taken the homeopathy long term.
Long term. Okay. This is what is called homeopathic adenoid. I'm learning
Homeopathic.
something new from you.
Homeopathic adenoid.
They go on trusting the homeopathy and then eventually they end up into surgery.
So homeopathic adenoid means there will be time. This also I think the homeopathic adenoid.
This is homeopathic
Oh,
adenoid.
homeopathic adenoid. Because so difficulty will be there and maybe two adenoids will be there required.
Yeah.
Homeopathic adenoid. So your movement, more is the movement. Look here, my movement. So I don't allow any block or clog
Yes.
of the.
So the take home message for all the people is that use saline under pressure.
Yes, sir. So if you
want to do this kind of surgery, make sure that you have a saline under pressure. Cold
saline under pressure, saline. Main is the saline.
Saline.
I've seen lot of doctor less saline using less saline, but 2 to 3 times blocking.
Yes.
So I use the, and also charging will be less, no? If you use the saline, look at the saline, all time saline.
Yes. This technology works with normal salines because you are working with the sodium chloride being produced from
yes, sir.
sodium ions being produced from sodium chloride. So if your saline is more, you produce better cloud.
Don't go for juniors, don't go beyond your limit, because it is septum and beyond limit, sometimes bleeding will be there and then is a problem to tackle. Go another side. And if you think the problem is there, stop it here and go other side.
Is actually like typically two halves of the adenoid. One adenoid you remove from the right nostril, another one you remove from the left nostril.
Beautifully tell. Two halves of the adenoid. But most of the 60-70% adenoid from one house.
Yeah.
Possible.
Yes.
We are grateful to social media because you are sitting different place. I am doing from my setup,
Yeah.
my patient, no,
Yeah.
and all will be visible beautifully. And thanks also Deepak Holdipur again and again. He organized such a beautiful hybrid workshop.
So technology is improved.
Technology.
Technology.
And all after COVID, more importantly after COVID.
Everybody started accepting this kind of technology.
Yes. So sometimes in adverse situation, people benefited, no?
Yeah.
In COVID,
Used to have advantage of the science.
yes. So COVID we learn lot of things.
Yes.
If huge adenoid, just debulk properly. Don't allow any bleeding. If bleeding, then surgery will be clumsy.
Yeah.
Just debulk it properly. And upper pole, you will see the periosteal sheath. I will show. Already previously I have shown.
To me, looks like that your vein is almost about to go.
Yes. So I keep this different type of adenoid. So otherwise people thought, though adenoid is so simple sometimes, so small adenoid. So all types of difficult situation you should learn, no?
Yeah.
So tonsil definitely is a simple surgery, but simple surgery, how the bleeding will be controlled, no? This way. So juniors should not panic when you see the bleeding.
Yeah. Some
Just-
coagulation technique, then they go for coagulation. They press the coagulation pedal. Am I correct?
Yes, sir. And you see the blocking, no, I never allowed any block. Look here, if there is a chance of blocking, just movement, just see the movement, and also the clock, yeah, already gone, no. So I don't prefer that brass cleaning, your momentum of the surgery, no, be hampered. Now see this coming, okay?
Yeah.
So now,
Yeah, little more, inferiorly. Yeah.
ব্লেড রেখে চেঞ্জ করবো ব্লেডটা ওইদিকে যাবো যখন ব্লেডটা চেঞ্জ করবো ব্লেডটা হ্যাঁ সেটি রাখবে টেবিলে রেখে দাও না So here this is the huge adenoid.
Yeah. The homeopathic adenoid.
This is the big adenoid.
Yeah.
So the real conference case,
Yeah.
workshop case.
What's the age of the patient, this patient?
Age দেখো তো 13, no?
30.
14.
Adolescent, typical adolescent.
Yes, this is the difficult. So all types of case I kept because sometimes and 4 years, 5 years is very simple adenoid, no?
Yeah.
Very soft. But I should show the difficult adenoid also.
Yeah.
And also a slight bit of adolescent tonsil, no?
Yeah.
5 years to 6 years is very easy tonsil.
Yes. That is something which people who are learning should do the pediatric tonsils first before jumping on to adults.
Yeah.
Adults and adolescents, yes.
Basically, problem is the normal tonsillectomy during post-graduation or start. And they think the coblation is the basically instrument dissector.
Yeah, but it's
So
not.
that is the not dissector basically. That is the main problem. We are doing with the plasma, not using the instrument. You see the plasma. I am using the plasma. If you slowly sometimes I move this way to prevent churning.
Okay.
And this way, sometimes without seeing the technique, without seeing the tissue, there is a chance of bleeding. So you should go different way. Slight bit of spar is there, but 80%. And again this way. Look here, lot of pediatrician told the adenoid reduced the age after 7 years. This is the 14 years adenoid, sir. Huge adenoid.
Yes, it never goes away. Adolescent adenoids are neglected adenoids. And it's a real fault lies on pediatricians.
And all basically totally well-being hampered.
Even people fix with orthodontal treatment and never treat the adenoids.
If bleeding, no, this way control. If bleeding, if you see bleeding, just don't panic. Just go this way. No coagulation. Just ablation. Just ablation. Your bleeding will be stopped.
You have very good assistant who is pressing the saline bottle.
Yeah, so all are trained basically.
Gate assistants are very important.
Yeah. Sometimes in different part when I go out to demonstrate the problem. Basically 1 liter water and pressing the water, not interested.
Yeah, your assistant is watching, and when there's a bleeding, he's pressing more. He's very good guy.
And sometimes for junior, if smoke is there, means there is a chance of block. So just out, movement, slight bit of movement, and then start again. Because the tissue within the wand.
That is a technique. Yeah, you have to. It's a lesson for youngsters.
Yeah.
They always press it over it. The blocking will occur. Blocking of the hand will go. So if you don't press it, the blocking of hand will be avoided.
This is a huge adenoid. Still, I don't allow any block. No wand.
Because you are moving it. No, you are not pressing over the tissue.
Yeah.
Constantly you are moving the wand.
Yes. Okay. Moving is the most important part.
Yeah, this is the lesson for younger generation.
Water. Let change water. So water finished. So I will change the water. Okay, just 1 minute. So 3 liter water is very important.
Yeah.
Fresh. This. Quick. Ready? Sometimes also you see the endoscope foggy. I kept the wand just close to the endoscope, so foggy clear. জলের স্পিড বেড়ে গেছে, জলটা একটু কমাও। So different type of case I have demonstrated.
Yes.
During my 1.5 hour, basically, I think I started.
You started at 12:30. You had 1.5 hour. Yes.
Yeah. So I'll stop within of 5 to 10 minutes.
Yes.
Because the another this way. You will look here. The technique, endoscope fogging. I just not touching. Just going close to the endoscope. Okay.
Yeah.
This is another technique.
So,
now I'll finish. Near I would finish.
the 30-degree bend is more than enough, no?
Yes, sir.
The bend, when you bend the band, 30 degrees.
30 degrees, sir. Yes, sir.
More than enough, no?
Yeah. So this is the fossa vaginal area. How we'll manage this way? This way. For junior, this is the good technique. You may follow this technique. Okay. Press it, and this way. And another also technique, you just take it. This is the all are adenoid type tissue. Okay, so all fossa vaginal tissue removed. Basically, in microdevice, this is very difficult. Basically, sometimes bleeding started, sometimes surgery required, but in coblation, no problem at all. You see, these are slight bleeding, no tension. Now I will finish. So this way, no, look here, nearly panoramic view, all area clean. First I will show the periosteum, periosteal sheath. And in case of adult, not required so much. I think this is enough basically. This is the buccopharyngeal fascia. And this is the periosteal. Okay, sir? You will appreciate definitely.
Yes.
Yes.
White portion.
Yeah, very good dissection.
Yes, yes. So now I am nearly completion of this surgery and huge adenoid tonsil. So your water irrigation is the key point, and your movement. All time my wand move. Look here, this is the movement. আর কটা কেটে অজয়কে স্টেপিসটা ইয়ে করতে বলো তো, স্টেপিসটাকে রেডি করতে বলো 3 নম্বরে। আচ্ছা 3 নম্বরে। হ্যালো,
Yes, tell me. Yes.
Yes, sir.
So good dissection, Ghosh.
Yeah, thank you so much. Look here, the ischemic tube, and if you think that this is the extra portion, sometimes it disturb in adult. So we just sometimes no during OSS surgery this should remove, no. Pharyngeal fold. So during surgery also you may remove this part. Okay. So I think you will appreciate, no.
Yes, yes, yes. Very good.
And I thank you also. The junior also definitely get benefited. How look here, the perimyxil is beautifully buccopharyngeal fascia. Okay, all
that everything.
Yeah.
Dr. Tushar, it was an excellent demonstration. Excellent.
Thank you, sir. And definitely I will hand over if any question, if Dr. Deepak Holdipur, sir, present or not, I don't know. Hello, sir, Deepak, sir.
Deepak Aldibar. Oh, Deepak. Thank you, Aldibar. Microphone.
Yes.
For giving this opportunity for me as a chairperson.
Thank you so much, sir. Giving me this opportunity and your valuable comments, and also that is the definitely extra benefit for me. And I'll accept all.
Ghosh, you are from Kolkata, you are doing surgery. I am watching from Chennai.
Chennai. Sir, thank you so much. I'm lucky, sir. Any question, and definitely I am ready to answer. And definitely that is another case is there, but definitely my time is gone.
Hello.
So I leave to definitely we should leave. So already another case of ready, but I should leave. My time is up to 2 p.m. So I will leave now. Any question or Deepak Holdipur is there?
Yeah, I am here.
Oh, yes, sir. All.
Hi, Naveen.
Yes, yes.
Naveen boss is also here.
Yes.
Yes, sir.
Okay.
Yes.
So,
Kumoshai, thank you.
thank you, boss.
Khub
Thank
follow.
you.
Khub follow. Thank you.
Thank you.
Thank you.
Thank you for giving me this opportunity.
Over to the conference
no problem.
venue, over to the conference secretariat, please.
Yes.
Thank you very much, Patel sir and Dr. Rajshekar sir for chairing. Dr. Ghosh, it was wonderful. I just would like to share, there were 1,600 people who were watching your surgery
1,600.
across.
Thank
Out
you.
of which 500 physically they were present and watching it live across the world. So many countries also people watched. Thank you so much for wonderful. Lot of people giving positive comments, and they have learned a lot from your session. Thank you very much, sir.
Thank you very much.
Thank you.
Thank you.
So, we are Dr. Patel sir and Dr. Ashekar sir. Thank you for chairing this session.
Thank you.
We are moving to the next surgery by Dr. Vishwas sir on pediatric septoplasty. We have three eminent chairing ENT surgeons who will be chairing this session. We have Dr. Jyotsna Madam. She is the member of prestigious Rhinoplasty Society of Europe and Indian Medical Association and Association of Otorhinolaryngology. She has played many roles at the Association of Otorhinologists in India. She is ex-president of AOI, Thane branch. She is a founder member of ARSI, which is Association of Rhinoplasty Surgeon in India, and a member of FRCSA, which is Facial Reconstructive and Cosmetic Surgery. She has presented many papers in state and national level. She has many publications to her credit, both in the national and international level. Dr. Jyotsna Madam, welcome to the program and thanks for accepting to the chairperson. We have Dr. Jaskaran Singh sir. She is a professor at Sri Guru Ram Das University at Health Sciences. Amritsar, somewhere echoing. Published more than 30 research articles and he's a governing body member currently. Special interest include rhinology, head and neck cochlear implants and facioplastic surgeries. Dr. Singh, welcome and thanks for accepting to be the chairperson.
Thank you, madam. Thank you. Thank you so much.
Working, huh?
Thank you, madam.
Then we have with us Dr. Shafraqul Islam sir. He sir is a senior consultant at JLMN Hospital, Srinagar. He has performed more than 2,000 rhinoplasties and has presented numerous papers and invited talks on rhinoplasty at national level. Sir, it's our pleasure to have you as the chairperson. Welcome to you, sir. We have, can I hand it over to the chairperson to take the session over? Dr. Singh, sir, over to you, madam. And
Yes, madam. Yes, madam.
Yes,
Thank you
sir.
so much for
sir.
the opportunity, madam.
So, can you, Dr. Krishna, put the slide of Dr. Vishwas, sir? Dr. Singh sir, this is the intro slide, although Dr. Vishwas knows, he is well known, but we just put one slide as a formality, sir. Over to you to introduce the surgeon of the rest right now.
Okay.
Yeah.
Yes.
Hello, doctor. Yeah, we are with you.
Good afternoon, Dr. Jaskaran.
Sir, how are you?
I'm good. I'm good. Thanks for coming over.
Yes. No, it's my honor, and I'm really thankful to you and Dr. Deepak Khatipur for giving us this opportunity to be with you.
Thank you. Thank you. Can I proceed with the permission of the chairpersons?
Yeah, please, sir, please. I hope other two chairpersons are also online, but I'm not seeing them right now. But you can start over it, sir.
Okay, sir. Thank you. At the outset, I would like to place my thanks to the Micro Knowledge Academy and the Senior Vice President Manjula ma'am, and then Vice President Durga Prasad ji for making this possible year after year for the ENT head and neck surgeons. And it has become a university in itself with a lot of resources for all of us to learn and practice. And the best part about this ENTrain workshop, when it is done, is it is a doctor-centric platform wherein they ask what surgeries they want to see, and that is the one which is demonstrated in these workshops. And in fact, the Micro Knowledge Academy team, the Microlabs team, has been very, very benevolent in supporting these workshops year after year. And it is due to my mentor, Deepak Haldipur sir, who foresees that common ENT surgeries done by common ENT surgeons should be showcased more often so that we are all in a good learning stage as well as a performing stage. Now, without much delay, the team which has joined me here is the anesthesia team headed by Dr. Jaidev sir and my associates Dr. Safina and Dr. Vitun, who are the fellow. And today we are going to demonstrate a case of pediatric septoplasty via the rhinoplasty approach. Now, this case for you might be quite simple and straightforward as compared to what surgeries you have seen since morning by Deepak sir himself and by the legend of ENT Satish Jain sir and Tushar Kanti Ghosh sir. That has been wonderful surgeries. I hope I can teach some basic information when handling pediatric septums via the rhinoplasty approach. Now, if the slide can come up on online before we begin the surgery. Yeah, a few pertinent points which we want to mention before we start off. Yeah, Dr. Vitun, who is my fellow from Thailand, he is going to explain a little bit about the patient.
Okay. The patient is 8-year-old boy. Chief complaint is about left nasal obstruction and mouth breathing since birth. He have a normal birth delivery with a delayed speech with hypernasal voice. Easily catch cold with your discharge coming from nose, mouth breathing, and snoring with apnea. Prolonged nasal infection when he got the cold, and no history of trauma or surgery of nose before. He has a normal academic grade. From the physical examination, from the external view, he have a deviated nose to the left with broad middle nasal, middle nasal part and flat left maxilla. From the nasal endoscopy, he have a left septal deviation with spur and mouth breathing behavior. From the frontal view, he has a broken brow tip line, and the upper third and middle third of the nose are disjunction, and the broad tip and the mid and broad middle third. From the profile view, you can see that the low lattice and the basal view is broad nasal tip, horizontal and small near, and also abnormal columella relation. Is this endoscopic view? You can see the left from the left side of the nose. He have a left septal deviation with spur and my enlarged adenoid.
Thank you, Dr. Vitun. So if the camera can focus towards the CT scan done for this child. So this patient has been having breathing issues and sleep apnea issues for the last 5 years. Being 8-year-old, he is not able to sleep comfortably, and most of the time when you see him, he is having mouth breathing, and his parents say that he keeps tossing around in bed and has apneic spells, which they've shown many places. But then for the fear of performing a septal surgery, many have rejected and asked him to wait till the age of 18 years. Now, coming to the CT scan here, I will just go over the theory in some time. If you can see from the anterior end, you can see an anterior dislocation of the septum of the maxillary spine. And as you move ahead, you can see that the teeth roots or the tooth roots also start appearing. Can you zoom out, please? Yeah, the tooth roots also start appearing. So just under the anterior maxillary spine, the tooth roots are there. And you can see how the tooth roots are crowded at the palatal level. So what we can actually understand from this CT scan as you go down is the cartilaginous septum is more bent and it is just sitting above the tooth roots. or rather the maxillary crest as well as the floor of the nasal cavity is very thin and the septum is resting on it. So to understand, if you take skull base as one plate and the palatal plate as the other plate and the septum as the letter I or the alphabet I in between, the growth of the nasal skeleton happens in a fashion where the skull base plate grows down, palatal plate goes up, and the septum moves forward. So the septum has a very, very crucial role in making sure the palatal or the alveolar growth happens and the teeth or the tooth roots spread out, as well as the nasal projection comes about. So this is to do with the brain growth as well as the mouth closed status during the sleep. So if the patient or the child has a mouth closed, so he's going to keep the tongue against the palate, thereby molding the palate from below. Thereby the septum and the growth of the midface also follows from there. If he keeps his mouth open, let's say due to a bad nasal obstruction or the septal deviation or adenoids, he keeps the tongue away from the palate in the closed position. Thereby the molding effect on the alveolus is lost and this crowding remains as it is. Thereby the midface growth or the alveolar arch spread out never happens. You can see that the deviation here is along with a spur almost touching the lateral wall here. And these are deviations which you need to help the patients breathe better, because on the side where he has the deviation, and you can see that there is paradoxical turbinate hypertrophy as well, and some amount of ostial block on the right side. Next slide, please. So as you go posteriorly, you can see that there are patchy ossification of the cartilage. That means the spur continues posteriorly as well, as you can see here. And when you reach the posteriormost segment, you can see the choana appearing. There is some amount of pneumatization of the septum itself posteriorly towards the rostrum of the sphenoid. Can you just go to the next slide, please? Yeah. So if you look at the axial cuts, again, looking at the pneumatization here and the amount of deviation that you can notice. Next slide. Yeah. So we just want to bring to your notice the presence of the adenoids. So it's not always the septum that is blocking it. There's a mildly enlarged adenoids as well that could be the cause for the nasal obstruction in the child. So before you list the patient on to a septal surgery, please do an examination of the adenoid tissue. So what I want to actually bring in salient points with the CT scan. Next slide, please. The CT scan is not routinely performed in children. We prefer a pediatric diagnostic nasal endoscopy since we had it from another center. We are just showing it to you here. Now, the septum is the key to midfacial growth and alveolar spread. And this is something that we all need to concentrate on, because whenever a patient comes to us for a septal surgery in the pediatric age group, we kind of defer the surgery thinking that you will disturb the growth plate. Now, leaving it behind for such gross deformity will actually disturb the midface and the alveolus and the nasal growth rather than touching it. Now, what we also saw was the septal deviation was from anterior to posterior. That means there has been a buckling of the septum from above downwards. Now, this buckling, one, it will move the septum to one side. So, if you look at the profile view, it will also move the midface up and down. That I'll just show it to you in the other slides. Now, just go back to the slide where there is a basal view. Yeah, you can see that this side of the face is flatter, while this side is more prominent because the deviation is to one side. Now, just trying to come to the frontal view again. Just come to the frontal view. Yeah. Now, here, though we are not interested in the aesthetic points, I would just like to mention a few pointers to what can be happening inside for the septum. If you can see that from the glabella, you are having a straight nasal bone. Then there is a slight deviation or a breakage of the brow tip line, and the tip is also rounded and broad. There is some convex deformity on the left side. So that is meaning to say that the septum is possibly lying like this, and looks like the K-area definition is going to be okay. Basal view, please. Yeah. So you can see here the alar columnar relation. Although we are not talking strictly about the aesthetic sense here, the columella is short, but you can see the supratip lobule is much more bigger. This is the case in children. So don't try to achieve anything aesthetic in a child. This is how the normal children's nasal tip is going to be. What we can notice here is the nares is very, very narrow and small. So if you want to do a septal surgery through this small nares, possibly many times we will either underdo it or possibly go to an area where we are not supposed to go and disjoin and cause later growth disturbances in the long term. Next slide, please. Next. Yeah. So what are the key points for surgery for us today? Now, these are the points which are of debate for us. Whether you need to do it for the function and cosmesis. Function always stands first above all the cosmetic concerns. Now, exposure over minimal access. Now, the question might be, why can't you do an endonasal approach or an endoscopic approach? The problem is, one is the size of the nares. Second is when you are having, as I mentioned already, a small nares, you will tend to either underdo or possibly reach an area where you're not supposed to reach because you're only having a tunnel vision. Now, when you're dealing with the septum, whether to retain or to resect. So this is a big question. When in an adult septum, you tend to resect more, whichever is deviated. Whereas in a pediatric septum, try and utilize batten graft to straighten it rather than resecting it. The same thing is construct versus destroy. Do not crush or score or incise. Try and construct more often. And don't try to be showing that we can do a surgery fast. Go slow, observe all the areas. Make sure we have handled the areas which are deviated and left behind the areas which are not deviated. So septum is not here for us to be taken out. It is there for us to build so that on that pillar, the face also grows. Next. There is one more presentation. Dinesh?
One small question. If this child would have been less than 8 years, you say around 6 or 5, would you have with the septoplasty? I mean, what are the exact indication for you to take up a pediatric septoplasty, sir?
Yes, sir. So normally, the pediatric population, when we are looking at the septal growth itself, there are 3 septal growths. One is between the 2 to 5 year age group. The second septal growth is at around the puberty. And the third is around 19 to 25, which is not much, but it is quite significant if you're considering the aesthetic concerns. Next slide. So in a child which is about 8 years, what you need to understand is you're doing it for a functional concern that the child is having apneic spells and possibly a adenoid which might be blocking it. But at the same time, if the septum is the cause of these apneic spells and there's persistent severe deformity which is growing to one direction and not allowing the child to be comfortable in sport or in daily life, or if he's having repeated infections, nasal infections which last longer as compared to the 1 week, then you better counsel and consent and do it. These days, the approaches to the septum is quite safe. That's why very well knowing what not to do is more important than what to do as compared to an adult rhinoplasty approach. So one caution or one word of advice for all our younger colleagues is, if a patient comes to you for a septal surgery in the pediatric population, even sometime up to 20-25 years, you can actually consent the patient for a second surgery because there is going to be some amount of growth even after you do the septal surgery. Next slide. So just want to bring your notice to this. Can you show the slide here, please? Yeah, show the slide here. I will show this to you inside the operation field also. Now, this is a pediatric septum. This zone is zone number 1, or the anterocentral zone, or the cartilaginous zone. Now, this zone here, 2, is the sphenospinal zone resting on the maxillary spine or the crest. Whereas the zone 3, facing towards the nasal dorsum, is the sphenodorsal zone. This is responsible for the growth of the nasal skeleton outward. Whereas the area number 2, or the sphenospinal zone, is responsible for the growth of the maxillary prominence itself, and also responsible for the occlusion and all that. So this is the critical area. Now, what we have to notice here is the cartilaginous skeleton is more rather than the bony skeleton. So there are few areas on the septum which have to be handled, which should not be touched as well. Dr. Jaskaran, did I answer your question or you want more?
Yeah, right, sir. Right, sir. I mean, according to, literature, you were saying after 5 years we can counsel the child for septal surgery, pediatric septal surgery.
Yes, sir. If there is a severe deviation, I would definitely go ahead. But then I would minimally list it at 7 years plus, just to keep that safe zone of late growth even after the first spurt. Next slide, please.
Dr. Schwarz, in your workup, you also have workup for maxillofacial workup also for pediatric septum cases. I mean, you also assess for maxilla or mandible also at the time?
Yes, sir. Yes, sir. We do show a pediatric dentist for all the occlusion and the dental issues as well. And we make sure that if at all orthodontic treatment has to be started, gnathic treatment has to be started, we let them know well in advance that it is a combined treatment and not just the septum alone, because sometimes patient innately has a retroprojected maxilla, which needs to be handled by other kinds of modalities rather than septoplasty alone.
Right, sir. Right, sir. Right.
So bringing to the point of the aesthetic concerns on can you play the slide itself? No, in the sense it comes onto the screen of the audience. No, not you. I think Dinesh will do it. Sir, can you see? Go back to previous slide. Yeah. So in children, sir, we should not try to achieve an adult aesthetic nose. The reason is children look beautiful or cute, you would say, because of their shorter dorsum and their projection being less and the tip being rounded. So we are not doing the same things what we would do in adults. We would just leave behind the virgin pediatric nose to look the way it is. The columella is short the way I showed you in the patient as compared to the adult. The nasolabial angle is also larger. In adults, you might see a 90-degree nasolabial angle, whereas in the children, it will be obtuse. The nasal tip is flatter, and the nares will be obviously horizontal and more rounded. So when we are trying to do any tip work or dorsal work, we need to remember that we need to keep the septum as it is. Now, this question, what you asked me that time, sir, I've already mentioned about the nasal breathing issues. But many times, parents will come and ask you whether there is any problem with the child, because later they can have a psychological stigma because of the aesthetic concerns. But this is not a absolute indication. It's only a very, very relative indication. And I wouldn't list a child for septal surgery via the rhinoplasty approach just because they have a psychological stigma to it. I would rather counsel them to come back at 17, 18 years. Or as the classical teaching is 2 years after menarche or 2 years after the boy child has his mustache. So if you're also assessing with a pediatric dentist and they tell you there is a possibility of dental malocclusion, facial abnormality, and there is sleep apnea issues, then you go ahead with the surgery itself. Next slide. Now we just want to show this video here to showcase what actually happens. These are some patients. You can see how high the palate is. Now, this was what I was telling you earlier. The deviation happens like a eye plate. So the movement of the alveolar or the palatal plate causes the septum to buckle, and that can be possible because of this when there is no opposition of the tongue against the palate. So if you see a child which is mouth breathing in your OPD sitting in front of you when they're not having a cold or adenoid tissue, try and address it and see if there is some problem with the septum itself. Next slide. So this is another patient we just wanted to show you. So what has actually happened is, again, the buckling has happened. And because the septum could not stay inside the envelope between the skull base and the palate, it has moved out. And you can see that the anterior maxillary spine area is very prominent because the septum has actually come out of the piriform aperture onto the external face itself. Now, this, when you see from the frontal view, you can see that there is caudal dislocation, medial crura is prominent on one side, and there is almost a S-shaped deviation that you can see in this child. So why we are telling you all this is, don't just look at the nose alone. The palate is as important, and the form of dental occlusion is also important. Next slide, please. So the indication I did mention to you already, and the growth spurts that we have to be aware of. Now, if there's a highly progressive distortion, we need to do it. Now, this is the third time we are doing the pediatric septoplasty via the rhinoplasty approach. Every year we get this on a top priority list asked by the ENT surgeons to showcase this, because this is something that everybody wants to do but is scared to do as well. Next slide, please. So what is the approach? Now, if your nares are quite wide, if you are having only a septal work to be done, we can do via the endonasal approach. So rhinoplasty approach is not mandatory. It is only when you are having a gross septal deformity which cannot be handled by that small nares opening, then you go for a rhinoplasty approach. If you are having any concerns for the external nose, then obviously rhinoplasty also approach would also be best. Few things to be remembered, which I'll be telling you as I start the surgery, is don't incise the incisal nerves that is on the base of the anteromaxillary spine. Next slide, because the sensation goes away, and many times the children complain that the teeth sensation is not there and there's likelihood of biting their lips. So just going on to one or two basic points, this area between the quadrilateral cartilage and the purpinal plate of ethmoid is responsible for the growth of the nose and the midface. Try avoid separating this and separating the upper lateral septal assembly. Next slide. So I'll just let Dr. Safina tell a few points about the various age groups and how the long-term results are, while I go on and start off the surgery in time. Dr. Jaskaran, any questions so far?
No, sir. Please proceed with the surgery, sir. We are with you, sir.
Give it to her.
You've nicely elaborated all the queries, sir.
15 number 9.
Your picture, sir. Surgical field is not in the view.
Yes, sir. Coming in a while. We are just arranging few things.
Can you just tell us what infiltration you have done, what concentration of infiltration you are using, sir?
Yes, sir. So what we did was we took a equimolar mixture of 2% lignocaine with adrenaline with 0.25% bupivacaine, infiltrated about 25 minutes back, so that there is sufficient decongestion as well as hydrodissection. So what we'll do is possibly after we finish the surgery or in between when we have time, we'll show you how the long-term follow-ups of the septoplasty done, because I've been doing this for the last 12 years now, and I have some of the long-term follow-ups with me to showcase to you. So if there are no questions from the audience, I can proceed with the surgery. Dr. Jaskaran?
Please proceed with the surgery, sir. In whatever questions are there, I'll keep on asking you, sir.
Yes, sir. So normally in an adult, we try to keep the incision at the mid-columnar point. So here, try and keep it as low as possible. So the same things what we do is go for a stab incision, go for an inverted stab incision. This will be more horizontal as compared to a vertical scar in an adult patient. Then draw the horizontal line. Again, draw the horizontal line laterally. So once you do it, place your knife against the soft triangle. This is the blunt edge. So run it down to meet the horizontal line just behind the reflection of the medial crura. Is it clear on the camera, sir? Dr. Jaskaran? So this, run your knife with the blunt edge against the soft triangle and the belly of the knife against the back end of the medial crura.
Zoom up, sir. Please zoom up, sir.
Zoom out.
The field is zoom up. Zoom. Can you zoom the picture? So it's away from the screen, sir.
Just watch it. Dinesh, can you help us?
Now it's better, sir. Now it's better.
So we are using the side camera as well. So please tell us when we are out of focus or you need some help in visualization, sir. We'll try to list it in angle scissors. So what we have to remember is soft tissue is going to be more in a pediatric septum and tip. So try and be as meticulous as possible or detailed as possible without trying to be too rough. Now, many people might ask this question as what happens to this scar as the child's scar heals? So believe me, in the long term, the scar becomes almost invisible and you won't even see it. So what we do is we tunnel the angle scissors under the skin, but over the medial crura, and then use the 11 number blade just to split out the previous incision that you have made and separate the soft tissue. Is that clear, sir, on the camera, or should I adjust something else?
Please zoom, sir, please zoom in. Your beat-on picture, we need more of a zoom in, sir.
Yeah. Niranjan, can you help us with that, please?
Beat-on picture, sir.
Cut.
The one with the beat-on, sir. Not with the side.
So you can see our assistant is placing the knife upside so that the cutting edge is up and not down. You can actually place it down also since it is running on the surface of the scissor. Control. So same thing again, the opposite side. Need the knife again.
Now it's better. Keep this, sir, keep this view. Now it's better.
LR retractor. Knife, please. Knife.
What precautions you will take while you are approaching the soft triangle areas, sir?
Yes, sir. So what I told you again was the blunt edge of the knife. I keep it upward towards the soft triangle area and I don't try to cut there. I only cut inferiorly. So, and then I tunnel with the scissors, protecting the medial crura. We need to remember that the lateral crura will be quite fragile in children. So as I am palpating, my thumb here is actually giving me a real-time feel on where I am going. So I keep it very superficial and run on the surface of the medial crura. So then I use my knife and just incise it, keeping the knife. I don't keep the knife like this. I keep the knife upside like that. And again, each cut has to be separately handled than cutting one go like this.
Right.
Okay, sir? Hello?
Very nicely. It's a very nice demonstration. Very good, sir.
I hope the camera is able to transmit.
Camera is, yeah, it's getting transmitted, sir, but in between we will be needing more zoom. So when we need more zoom in, I'll just let you know, sir.
So here what will happen is we will be getting the columellar artery. So
Right.
that might tend to ooze for a while. Knife again. Mop, please. Mop in a way that I'm able to see what I'm cutting. Okay. Thank you. So you can see that the V is maintained. Yeah. Bipolar, please. So the columellar vessels will be here. Pottery not working. I'm pressing. Is the cautery connected or not? Yeah.
What
now
is the
it's-
wattage of current you are using at this area?
Sir,
At what?
10, sir.
10.
10, 10. Very low voltage because you don't want to damage the ligaments as well as the skin tissue. And I'm using a pointed tip there. So coming to the question, why do we have to really do all this via the rhinoplasty approach while you can do this entire thing via the septal conventional approaches, angle scissors? One is obviously, sir, as I told you, you will get a panoramic view, skin hooks please, of the entire septum, which you will be able to handle, and you will see it as I go inside, how much of the deflection is there, which requires to be handled carefully. The second thing is, now when you're having a tunnel vision into the septum, you will start thinking that the deviation is everything, whereas there might be a lot of areas which are not deviated and straight. So trying to remove only the deviation, you might actually affect the perpendicular plate of ethmoid, which is actually important for us to retain for the nasal growth itself. Now, the cartilages here are very fragile, as you can see, and I'm just moving my instruments gently and spreading it so as to be able to sit on the medial crura. Mop, please. Yeah. Keep saline irrigation with you. In the conventional rhinoplasty, what we would be doing by now is trying to tug at the tissues so as to get a better visualization. Now here what we are doing is slowly and steadily, mop please. So these tissues here, the intercrural tissues, will contain some blood vessels. So try and cauterize them before you go ahead. So
to preserve the ligament of Patengi, or you will take away the ligament here, sir?
Yes, sir. So what you're seeing now, this ligament here is the septocolumnar ligament, which you can see here, which is coming from the tip down to the intercrural tissue. This is the superficial ligament.
Picture is not, sir. First, sir, please ask them to put the Vietnam picture, the front side, not the side.
Yes, sir. Yes, sir.
Front view picture.
Please don't change. We are actually seeing the VTOM only on the
This
screen.
one only, sir. This better.
Is that okay now?
Right, sir. Right.
So this is the ligament
Now
of
it's
Pitanga.
fine, sir. This is the picture we want, sir.
Yes, sir. So this is the ligament of Pitangai, superficial ligament of Pitangai. So this is the one which defines the tip. And in children, this is the one which causes the rounded appearance. So what we're doing is cauterizing more towards the cartilage, less towards the skin. So keep it more towards the cartilage and gently cut it. So what you will see now is the intermediate crura appearing. I am manipulating with my fingers as I am doing it. Now near the soft triangle, I use the impression of the intermediate crura itself to gently slide my scissors. I don't use any sharp instruments there. I am gently sliding it and using it. Is it visible, sir? The medial crura here, intermediate crura, medial
Yes, sir.
crura,
Yes,
and
sir.
intermediate crura. Okay. Now I will
Very
shift.
nicely. Very nicely.
Now I'll shift my skin hook to the intermediate crura. I need better skin hook. Hold this.
Of, I mean, like in the
Elar retractor.
surgery, would you be suturing ligament back, or you will keep it cut only, sir?
Yes, sir. The ligament of Pitangai is important for the growth of the nasal skeleton because it grows as one unit. I need better skin hooks, please. It's not holding. Yeah. Hold this. So you're seeing I'm using the alar retractor only on one side, slowly releasing the lateral crura, and I'm using the scissors to release the lateral crura from the skin or at the lower border of the lateral crural cartilage. Now, I hope the image is magnified for your visualization, sir. Mom.
If some more magnification can be done, it will be better, but it is well appreciable.
Yes, sir.
If some more magnification can be done, please do it, sir. If
Yes,
it is
sir.
possible, sir.
So this is the deep ligament of pitanga. You can see this, sir. Can you see?
Yes, sir. Yes, sir.
Yeah. So the superficial and deep, the superficial attaches to the front face of the medial crura. Deep attaches in between the medial crura. It's okay. Scissors. I mean, cautery and scissors. So as I mentioned earlier, I'm cauterizing towards the cartilage more and releasing it from the cartilage. We got better skin ops. So I don't try to be. Sorry, sir. Keep saline irrigation. I don't try to be very, very dogmatic with the supraperichondrial or the subperichondrial approaches, but I try to retain a little bit of perichondrium on the cartilages, especially in the pediatric rhinoplasty. The reason is this perichondrium also guides the growth. I need a skin hook, please. Better one. Is that better now? Visualization? Can you see the intercrural ligament, sir? Mop, please. Mop, please.
Ligaments are there, sir.
This one?
Get in between it, that is better. Hello?
Yes, sir. Can you see this intercrural ligament here? Between the crura. Intercrural
Yes, sir.
ligament.
Yes, sir. We can see. We can see, sir.
So that is the
We can see, sir.
thing which has to go for you to open up the septal window. Now this, obviously when we are closing it, we are going to make sure that that suture has to be coming to close that. Now I'm going to sit on the cartilage and try and open up the lateral crura. Can you see the lateral crura now, sir? On the right side? Dinesh? Again, lateral crura on the left side. And few ligamentous attachments from the tip or the skin to the cartilage itself. Is it clear?
Yes, sir.
Yeah. So why this needs to be cauterized is, this acts as a marker for you to reattach the ligaments when you're closing it. Or you can put a marker with your pen and keep the tips there. So you can see there is one marker here, second marker here. So when you're reattaching, put it back. 1, 2, and 3.
Right, sir. 3.
So I'm going to go up and slide my instruments. Next, peanuts, lid retractor. So move from the sharp alar retractor to a soft lid retractor. Keep the peanuts ready. Don't keep putting water. It's only when you need to visualize the small things. When there's blood, don't put water. Okay. So the question again is, if you can see the orientation of the medial crura, it is like this, but the lateral crura is towards the nasal bone. Can you see the direction, sir? The lateral crura here is more towards the nasal bone itself. This is called as lateral crural malposition in the sense of adult aesthetics. Dr. Jaskaran, are you with me?
You, sir.
Hello?
First, yeah, we are with you only, sir. Please carry on, sir.
Yeah, what I was trying to tell was the lateral crura is more towards the medial canthus than the lateral canthus. And you can see
Right, sir.
how thick the ligaments are in a pediatric population. And this is obviously a useful ligament which will guide the nasal growth later. So again, we need to mark it with our cautery.
Right, sir. And sir, how far you will raise the flap now? So it will be like a rhinoplasty flap or somewhat shorter, sir?
No, it's only this angle between the lower third and the tip up till the columella. If you have got access to your septum, then that has served the purpose.
Okay, sir. Okay. In this particular patient, sir, you will be, are you planning to put us a nasal spine suture for caudal dislocation or a batten graft, sir?
So nasal spine suture is actually a very important suture to be put in the pediatric population. But then you also need to see how much of the soft tissue is there. Now in adults, what we do is we try to drill the spine. In children, we don't drill the spine. That is something you stay away from.
So it is from the perichondrium, sir, where we are putting the suture then?
Yes, perichondrium would be the best, and try and utilize a absorbable stitch like PDS rather than a non-absorbable stitch like Prolene. So what I'm trying to do now is just expose slightly for the benefit of my movement the dorsum. The important rule in pediatric population is not to separate the upper lateral from the septum and the K area to be not to be disturbed. So obviously I don't need to go onto the dorsum, but I'm doing this just to allow me to move my retractors little up and down so that I get a better visualization.
Right, right.
Right. So you can see how thick the fat is. Can you see that, sir? That we don't see
yes, sir, we can
in pediatric population. It's quite thick.
Can
in the adult population.
Zoom 1 point, sir? Sir, can somebody just zoom for 1 point, sir? Zoom
Yes,
up,
sir.
zoom in, sir.
Dinesh, I need your help here, please. Dinesh?
Because as you are going deeper, sir, we will be needing more zoom.
So you can see the amount of soft tissue here.
Right,
can you
sir.
see amount of soft tissue here? That's
Yes,
all.
we can see, sir.
That's the one which is causing the roundedness. Please don't try to take it out trying to sculpt the nose. That's the wrong thing to
Right,
do.
sir. Right, sir.
So all we are here all the time, we should be thinking about how to approach the septum in the most
that's it.
safest manner, while also making sure that we get the best possible exposure. Careful. Yeah. Keep it like this. Is that clear now, sir? Just hold it there.
Yes, sir. Yes, sir. Yes, sir.
Is the zooming better now?
Now, better, sir. Zooming better, sir.
So you can see the direction of the lateral crura now. It is moving vertically up.
Right.
It's not like this. In a conventional adult, it will be like this. Or in some people, it will be towards the medial canthus. But in this patient, it is like this.
Yes, sir. Okay, sir.
Has Dr. Shafkat also joined us?
Sir,
No loose ends, please. No loose ends.
Sir, I'm not seeing right now.
Okay. So what I was telling was the rhinoplasty approach, one is required to tell us or give us a panoramic view. Second, if the deviation, if the deviation is more than 30 degrees off the base, then you will need to do something called as an extracorporeal septoplasty. And in children, if the K area is not deviated, then extracorporeal septoplasty will help us achieve it. But if the K area is deviated and there's a deviation here at this point, then I need to expose all the way there and make sure that the deviation, if at all it is causing functional issues, to be handled. Hold this cartilage holding forceps. Just hold it like that. So now what I'll try to do is cut, relax. You guys are pulling too much. Relax, yeah. Relax means relax. Yeah. Cut in between the intercrural space. Try to get into the pocket of the mucoperichondrium gently. Now you relax this. Relax this. Yeah. So can you see the caudal septum is here? Dr. Jaskaran?
We can see the caudal septum now, sir.
Yeah,
we can see the caudal septum.
It is occupying the entire nares here. So we need to approach this from this side. So we need to go laterally like this. Keep mopping.
So you will approach through a deviated side or a non-deviated side, sir?
I will try to reach the caudal end first by palpating it slowly.
Right.
And then I will see which side is deviated. So we are all used to doing a lot of adult septums. So we cut without much thought. But in a pediatric population, try and resect less, retain more. That's what I was telling earlier.
Right.
Go slow, go slow, go slow. Nothing happens. But you're going slow now will make sure that the child is comfortable for the next 40, 50 years, or rather how long he survives, because it will avoid a second surgery. It will also avoid probably a external deformity issue. So I'm trying to move the tissues on the caudal septum to see.
We don't listen. So we are getting a side cam. Yeah, that's better.
So there are two approaches here. Once you find the anterior septal angle, to attack from the anterior septal angle. The second approach is the front face of the septum itself, that is this edge, or to attack from the anterior septal angle. Can you see that caudal edge, sir?
Yes, sir. Caudal edge we can see.
They will be very fragile, so I'm trying not to hold it with my forceps. I'm trying to hold the soft tissues attached to it.
So instruments are same as adult rhinoplasty, or these are separate instruments we are using, sir, for
Yes, sir.
pediatric?
It will be the same, just that I use the size 1 speculum, the scissors which are more sharper, and the cartilage holding forceps which are smaller. So most of the deviations or deflections in the pediatric septum start off from the maxillary spine itself. So always make it a point to go down to expose the septum from below. No, wait. So I'm going laterally like this, all the way down. So this is one approach. You approach the septum from the anterior direction, or you incise at the anterior septal angle and attack here. So there are two ways. So what the rhinoplasty approach gives us is this dynamics. So you can visualize the septum in a triangular fashion in this way, so that you can address it accordingly. More, please. So sharp pointed scissors.
In this, so what is the status of spine in this patient? Spine is in mid. is it midline or deviated, sir?
So the spine is not there much. You saw on the CT scan, I think.
Right,
It has
sir.
gone to one side, the bony spine, but it's not much. It's the cartilage itself which is deflected off the spine.
Right, sir.
I'll just show you in a while, sir. Just trying to get the because the septum is quite fragile and wobbly. I want to go a little slow here and not hurry and try to tear the cartilage, because every piece of cartilage here for us it is crucial.
Right, sir.
Suction. The attachment of the mucoperichondrium will be much more rigid as compared to the adult. So I use a sharp pointed scissors, or rather a broken tip scissors, just to elevate this. Can you see this, sir? So I'm going on the side of the deviation itself. Is it visible?
Right. Yes, sir. Very nice.
Okay. So if I take out my light, I think it doesn't be so obvious. So I'll try to keep my light. Sharp pointed scissors.
No, sir. That's a thoda zoom. Please zoom in, sir. Like now, as we are going deeper, we need more zoom pictures, sir.
Correct, correct. Dinesh?
छोटा सा छेद है ना, जैसे नाक बन के फुग्गा फुलाओ.
Okay. Want more zoom?
तो डेली सुबह एक फुग्गा फुलाओ आप, एक बैलून खरीद लो.
Wash, please.
तो सुबह सुबह 20-25 बार और शाम को 20-25 बार फुलाओ. ठीक है ना? और एक गोली केवल सुबह खाओ.
Get the sharp SMR elevator. Sharp SMR. Suction inside. Suction inside. Here. Need to suction to show me the septum. Is it? Okay. So what I did was just go over, hold it, hold it, hold it, hold it correctly. Yeah, hold it back. Yeah. So Dinesh Pal is trying to arrange the, get me the gauze piece, gauze piece. I need to see inside.
So are we separating? Are we going to separate septum from the upper lats?
That's what, sir. No, I don't want to be doing that. But if my approach limits and gets limited, only the anterior end I will be opening and then suture it back. But I won't separate the upper laterals and the septum. So that's a crucial zone for us to handle. So for us, this much is sufficient.
Right, sir.
So sharp pointed scissors, please. So the zoom part, I think they're only able to do to a certain limit. If it's
no issue, sir. I mean, it is appreciable. No issue, sir. We can see. No, that's not a very big problem, sir. I was just trying to make it somewhat better, but this is very good picture.
So basically here I'll be telling the points which needs to be done and should not be done. So get me the first size speculum, please. Drop it down.
So you have exposed the septum on one side now.
Yeah, still exposing.
And still exposing, right? And other side, then afterwards you'll be going on other side.
Yes, sir. So first what I'm trying to do is retain the mucoperichondrium on one side correctly, and then go on to the opposite side.
So right now you are doing on a deviated side.
Yes, sir. This is the deviated side to the left. And I'm going down onto the maxillary spine itself. The thing with the pediatric age group septum is it's very tight always, the attachments. So it won't raise up immediately as soon as you put the incision. And it will be buckling a lot. So the spine is here, but the septum is, you can see my spine is here. The septum is way away from the spine itself. I'm sorry, this part I don't think you will be able to see as I go into the septal pocket. Suction. Sharp pointed scissors.
So if possible, please show us with endoscopic view if it is possible for you.
Yes, sir. Niranjan? In a while, I'll just expose the septum on one side and then come back to you, sir. Second size, please. Don't dip it in saline and give, okay? SMR elevator. Sharp. Can you call Dinesh? Can you call Dinesh? Dinesh? I'm going inside deeper. So they want to be able to visualize what should we be doing. Yeah. Can you get it arranged? Sharp pointed scissors. Out, out, out. Don't come in the way. So the same principle as before, the anterior and the inferior tunnels. I don't use the suction elevator here because the bleeding is not much. At the same time, the attachments are amenable to the regular SMR itself. I'm just sliding my instruments rather than trying to sweep. Now, this is something that our juniors can do. Many times we learn to sweep the instruments from up to down. To try and avoid sweeping the instruments and use the push in this fashion rather than sweeping up and down. Sharp pointed scissors.
Field is very nice, sir. Very nice field by your anesthetic, sir.
I think I should thank our anesthetists who are benevolent enough to give us this field. I'm sure they have reduced the heart rate and been.
What is the heart rate you are maintaining at the moment, sir?
Heart rate 70, sir.
Very nice.
In an 8-year-old child, they're maintaining 70.
That's very good. Very good. Very nice.
I think we are spoiled for choice and pampered too much.
So we are not getting the VTOM views, sir.
Yes, sir. So what I'm trying to do is, Dinesh, come here. That coupler which is there, that is much better. Take out this whole scope thing.
Yes.
Just attach that coupler. I think that coupler is there. There's one more which came in the box there. There's one more box there, no? That box. There. Here. Last. Yeah. There is one coupler in that. Just put that coupler. That is better. We showcase inside rather than struggling with this scope. First, get that sterilized and put it there. Dr. Jaskaran, give me some time.
No issue, no issue, sir.
We're
Just carry
trying
on.
to improve the visualization. Here we are okay.
But can we get the front side view, sir? We are getting the side. Yeah, that's better.
I am going inside deeper and deeper, third size. I am not opening this envelope here. I am trying to retain it. All this approach is only so that I'm able to get a 180-degree view. So that 180-degree view, if I get, rather than that 45-degree angle of visualization with a conventional Freer's incision, I would have better advantage in handling the septum rather than looking at the septum very, very small. No, that one. That coupler there. Not that coupler inside. Same thing as this, what you had here, no? Yeah, you please do all that arrangements. Meanwhile, I'll keep raising the flaps inside, okay? Niranjan? Okay. Cartilage holding forceps. Scissors, please. So only when you are defined the anterior edge, this intercrural ligament can go. This I'm doing only to improve our visualization much better. What's the time? Okay.
Caudal septum from spine, sir.
Yes, sir.
Inferiorly.
So from the spine to the anterior septal angle is our window. Sharp point.
Right. Yes, sir. Exact picture now.
Put a double hook here.
I have a VTOM now, sir, in front view, not a side view.
I'm sorry, the visualization being a very small area, considering that it's a pediatric septum, we are having
We understand, sir. Still, you are doing very neat dissection. Very nicely done demonstration, sir. Very nice demonstration.
Thank you. One thing that helps us is doing a hydrodissection with our infiltration much earlier to the surgery. Most of us, we infiltrate and then we immediately put the incision. So it's a good practice, which I learned from Deepak sir, to infiltrate for some time and then leave it so that the field becomes decongested and much better. So it'll be likely that you will be getting out of plane many times. So please keep getting back into the plane so that your dissection is comfortable and bloodless. So many people use knife here. Many people use sharp SMR elevator here. I prefer this instrument, which possibly is my own old broken scissors whose tip was sharp enough, and I'm utilizing it to raise it, as you can see. Put your full hand there. So as we go inside, I think the cameras will have to change. So till that time, I will keep operating and showcasing the outer parts, sir. So if you noticed, I never held the tip like this. I'm holding the cartilage forceps against the entire caudal end of the septum so as to not tear it through. It's very fragile. It's hardly about 1 millimeter suction. Yeah. Yeah, please. Scissors, please. Angled scissors, please. Yeah.
I think you are switching over to a new camera, sir.
Yes, sir. Just give us some time.
No issue, sir. Please arrange your things. Meantime, please keep on telling us, sir, what you are doing.
No. What are you doing? What are you doing? That is not required. Coupler, just a coupler, no scopes.
Because of stains, the coupler is okay.
Huh?
Because of this
Huh. Okay, so I'll suggest to you, take out the scope. Put that plastic coupler. The other one.
Yeah, new one, whatever it was.
You got it from...
Yes, I got it, the new pack.
Okay, take out the scope. Wait, please. Huh? Just put coupler and camera. Forget about the scopes. Yeah. Bring it forward. The whole thing, the whole assembly, bring it forward. Move it there. From there. Huh? There must be one thing here, no? No, you should come here. So this is the planned position. It's there. Pointed scissors. Hit the suction elevator, please. Connect the suction elevator. Okay. Scissors, angle scissors. Just hold it like this with your same thing, with the septum, with the suction itself.
So meantime, camera is getting fixed. Please tell us what you are doing, what steps you are doing right now.
Sir. So I'm finding that the septum part is duplicated.
Right, sir.
Anteriorly. So I'm trying
It
to
is
delineate it.
duplicated inferior. It is duplicated inferiorly, sir.
Yeah.
Oh, yeah. Now we are getting the picture. Yeah, it's much better pictures. Now we are getting the picture. Yes.
We'll just try to focus it, sir.
Yeah. We are getting the picture, sir. It's a nice picture now.
Out. Just hold the cartilage. Yeah. Hold it far back. Yeah. Just hold it there. Out. So your instrument is dipping into the field. No, SMR elevator. But keep it at the tip itself. Okay. Sir, can you see now? Just current, sir. Sharp pointed, sir.
Hello.
Yeah. Can you see now?
Yeah. Vishwas sir, picture is clear.
See, we can see apart from this septal cartilage you have here, I can see there is some amount of duplication here. So we're just trying to delineate it. And once I'm able to delineate it, I will be able to raise the flap. So the other way to do it is I'll approach from above. Is the image better now?
No, image is far better, sir. This image is very good. This we are getting through VTOM now, sir?
No, that's a modification done by Dr. Vikas Kulkarni. What he did was he developed a pinhole camera using simple plastic. And then all we did was attach the spice camera to the pinhole coupler.
So after the surgery, just show us the attachments. It's very good thing you are saying.
Yeah, I think we can show it now also.
Yeah, if it is possible for you to show us.
Yeah, definitely. So I'm trying to raise the tight mucoperichondrium envelope on this side. Suction, please. Is that better, sir?
Yeah. Very
can
nice, sir. This is far better view. What we are getting now, sir.
Okay, I think we should thank Dr. Vikas for thinking out of the box. Hold this, please. So all we did was replacing a 10 lakh scope with a
Is it commercially available? It is commercially available, sir, or can you just show us, like?
Yes, sir. I'll just on the side camera you can see, I think, no? Can you?
No. Right now we are not seeing, sir. Just your picture, which is very good.
So can you see inside?
No, yes, sir, we can see inside, sir.
Okay. I just want you to observe the various areas where I'm going out of the field. Can you see this is bare cartilage? This is bare cartilage here, but in between there is some mucoperichondrial attachment. Can you see that?
Yes, sir. Right, right, sir. We can.
Because that's a tight corner and a concave edge. Is that better now?
It's very, very good now, sir. Far better.
Yeah, hold it. So the only difficulty with a pediatric septum is the fragile tissues. So your assistants are very important to hold the tissues apart gently while you elevate the septum. So you will need to have your assistants to be understanding about the need for gentle handling, which they are actually. In fact, I am being more vigorous here, trying to raise the flaps faster. But then that's how the cartilage is, and you can't do much about it. Can I have the speculum, please? Second. Suction, elevator. Thanks. Hold this. Keep the sharp pointed scissors with you. So there was some ooze, so I decided to shift to the suction elevator there. So the convex edge is actually the easier part to dissect, that we all know, I'm sure. The concave edge is where the mucoperichondrium is attached very, very tightly. So you can try to see, you can see
Your
that
hand is coming in between, sir.
I'm so sorry,
Yes.
sir.
No issue. We understand like the area as such.
Scissors. In the concave edge is where the mucoperichondrium will be tightly attached. Angle scissors, please.
So you are working more inferiorly now, sir.
Yes, sir. I am going closer and closer to the spine area. So this is the only luxury I have, is the front part of the septum. After this,
Right,
it
sir.
all becomes the part where I can't do much, or rather, I can only expose and keep, but I can't remove. So this is how the septum is. Can you see, sir? All bent on itself. This is the caudal edge, which was thick.
So we are not getting the front. Yeah, now it's fine, sir.
So this was how it was.
It's bent one separate. Yes, sir. Yes,
Yeah.
sir.
So I'm just getting inside, sir. So what I'll do is I'll dissect a little bit more and show you from the coupler itself inside. Is that okay?
Yeah, yes. Sir.
So this is the window we got, sir, with the rhinoplasty approach. Can you see?
Very, very excellent exposure, sir. Very nice.
Yeah, without disturbing the upper lateral assembly, without disturbing the spine.
Spine, sir. Yes, sir.
And I'm sure this is a surgery which many people do routinely. I'm just touching upon a few basic points for our young colleagues who would like to do or who would like to help a child but are scared that it might cause some growth disturbance. So posteriorly, the septum is lying flat or rather horizontal. So if you can see the way my instrument is moving, sir, I'm moving in a horizontal fashion. Rather than like this, my instrument is in this fashion. I'm moving like this.
Right.
And the maximum instrument, or rather the speculum that I can introduce inside, is the second size.
So we are not getting the picture, sir.
Really?
Just yes, sir. Sir, keep this one only, sir. Please keep this picture only, sir. No side picture.
Audiovisual, please understand what they're saying. Do not change as per. So what has actually happened is that the maxillary crest has also gone to the side, or rather the bony
Right.
crest has gone to the side. And thereby...
So your hand is in between.
Yes, sir.
Yes,
I'll just change the orientation of my instrument. Just a second.
Right.
Is that better now, or it's still on the way?
No, we are seeing, but it's still on the way. We understand the area is such, but just show us the spine once, which side it is deviated.
Yes, sir. Just a second. I am reaching the lower parts now. I'll expose it and show it to you, sir. Angle scissors, please.
Good afternoon, Dr. Vishwas.
Hi, ma'am. How are you?
Yeah, I'm good. Sorry to join late.
No, that's okay. You just come upon the right time.
Yeah, I can see the picture. It is quite
Wait for that,
clear.
please. Yep. Hold this.
Or you can show some part in with endoscope. Have you already
Yes,
shown
ma'am.
with the endoscope?
Not yet, ma'am. I'll show in a while.
Yeah.
I'm just going on to the spine.
What is the age of the child?
8 years, ma'am. 8 years. Give a saline wash, please. It's okay. Same section will do. Yeah. So what we have done is just the exposure with the rhinoplasty approach, ma'am.
Okay. So he mainly had complaints of obstruction of the nose?
Yeah,
Or
along with
yeah.
along with an apnea.
Okay.
So sharp pointed scissors, please.
So you have done a CT scan in this patient?
Yes, ma'am. So it was done outside. We don't normally advise a CT scan in a child. That's the practice in Trustwell Hospital here. So we try to do mostly the pediatric diagnostic endoscopy itself.
Okay. So you rule out the adenoids by endoscopy? Like
Yes, ma'am. We
patient is
try and
having, yeah.
avoid any kind of exposure. Is that better? Little down.
Hand is coming here.
Yes, ma'am. Just a second. I'll just expose the bone.
Yeah.
The bone is lying horizontal. So I just wanted to get me the third size, please. I'll just come in a while. Yeah. There's the other third size, better one.
So he had external deformity also, or it is just that functional problem?
Little bit, ma'am. Nothing of major concern. Parents were not concerned about the external deformity. They were more concerned about the breathing. The child has been having breathing difficulty since the age of 3.
Oh, okay. And no adenoids, not significant adenoids?
It was only mildly enlarged, ma'am. So we obviously looked into it so that should not be the cause when we have taken out the septum and still you have left behind the rest of the obstruction there.
Yeah.
So I'm just trying to delineate the horizontal spine, which is lying down. Sharp SMA. I mean, the field has been excellent thanks to our anesthesia.
So what is the youngest age that you advise the septoplasty, since the patient was suffering from 3 years?
Straight section. Ma'am, until 6 years, I don't operate unless it is a deflection and completely blocking the nose. So sometimes we get this neonatal population. I need a better, thinner section. I have a thinner section. So neonatal population wherein they call you from the ICU and say that the child is having nasal obstruction due to a caudal dislocation. So that's the rare case where we go and through the sublabial approach, we relocate the cartilage back and place a stitch. We don't resect anything. We just relocate the cartilage back to its columnar pocket. Apart from that, my minimal age would be 6 years plus.
Okay.
So I am at the left nasal cavity trying to see where all the obstruction is there. I think now we'll have to change the angle of our coupler instrument so as to help us look inside better. Can you change it, Niranjan, or whoever is helping out with the audio visual? So I have a very sharp SMR elevator just to elevate the inferior tunnel. So by sharp, I don't mean that it is sharp at the tip. It is sharp enough to slide on this one rather than glide on it. So I'll just try to explain it with the illustration later. Now, if it glides on it, it is likely to tear. If it slides on it, it is likely to elevate. Leave it. Suction. Yeah, give a wash, please. So the coupler needs to come from higher up so that they are able to have a look inside.
So it is a rhinoplasty approach, but you have not separated the upper lateral cartilages from the septum.
Yes, ma'am. So the window is about 180 degree. Need a better one. Something longer. Is it better visualization now, ma'am?
Yeah, a little bit focusing is needed.
So what has happened is the maxillary spine here has bent like this, or rather I'll show it with the maxillary spine and the crest. I think they're just adjusting, which is supposed to be like this, has bent and curved like a mushroom, like that. So I'm just going under the inferior tunnel to raise it up and then align the septal cartilage to it out. So what I'm being aware of is not going deep into the anterior maxillary spine because the tooth roots are going to be there. So by going there, you are actually going to tear off the incisal nerves. And if children lose the sensation on the teeth, one is the dentition is affected. Second is chance of a lip bite whenever they are chewing. So I can only demonstrate the spine, but I cannot go and lift it up too much. Give a wash and clean it nicely so that the visualization is better. Yeah. Speculum, second size. Suction, into suction. Get the endoscope ready, Niranjan, to showcase inside. Okay. So there is no magic to this surgery. It is just that there is a lot of buckling that has happened. Cartilage forceps, please. With the least damage, we need to do the surgery without affecting the growth centers. Now, what has happened, ma'am? You can see the whole cartilage is bent like that. That's because the maxillary crest is also
Yes, quite
gone
bad
laterally.
deformity.
It's like this. So, and that has caused the spur as well. Can you see the spur? Hold on. Is the spur visible, ma'am?
No, we can't see the spur actually.
This one? That better?
Yeah, a little bit better.
Yeah.
Yes. So he had history of trauma or
no
history
history of trauma, madam. So we were quite insistent on asking that history again and again, but then he did not give any history of trauma. Obviously, many times children falling away from the bed is a common possibility, which parents might not have noticed or the child might not have mentioned it to the parents.
Yeah,
so
that's
that is
true.
something we need to factor in. So in all possible cases, I take that there is a possible microfracture from a trauma. So this is how the septum was lying. Now, because it is so fragile, with my speculum itself, it is lying flat.
That's, yeah.
So now what I'm allowed to do is the anterocentral zone, which is cartilaginous, can be resected while I maintain the septal height. For example, if the septum is deviated like this, I can resect this part and I can resect the maxillary crest here and allow those edges to stand on each other.
Okay.
Because there is an excess here, imagining that the terminal phalanx is taken out on both the fingers, you allow the middle phalanx to lie on the middle phalanx of the other side. So just remove the tips which are causing the deviation like this. So these two edges come together and lie straight. I'll just show it to you in a while, ma'am. I'll need the turbinate scissors in a while. 11 number knife. So
when there is acute fracture line.
Yes, ma'am.
Yeah.
So I make a gentle cut here at the maximum point or the highest point of the spur. So I'm being very conservative in removing anything here. That is the limitation of the septal surgery, is you have to remove just what is visibly deviated. Don't try to remove too much. Give the angle scissor itself. And one thing that we need to avoid is carrying our cut too posteriorly to join the vomer or the perpendicular plate of ethmoid. Can you see the division that I did, ma'am?
Yes,
Is it visible? I think you
Yes,
need to move
definitely.
the coupler a little ahead. Let it come here where my instrument is right now. Bring it forward. Come forward. Yeah. So this is the most crucial part that they need to see. So please keep that visualization intact. Can you see, ma'am?
Yes, we can see now.
Okay. Turbinate scissors. So go slow on the.
So that is the lowermost part of the septal
cartilage.
Am I correct?
That also, I'm keeping the bone in view.
That
and
is the
cutting-
maxillary crest.
Yes. And that's also deviated. So I'm still being conservative on the cuts. Turbinate scissors. The deviation, as was seen in the CT scan, is going all the way posteriorly, mostly a bony deviation. Okay, SMR elevator, sharp SMR elevator. So the cartilage will be very fragile, so you can actually cut with your sharp SMR elevator also, but be aware that it can carry the cut between the vomer and the cartilage itself. Turbinate scissors again. I use turbinate scissors a lot to do specific cuts rather than trying to manipulate with other instruments.
So in this case, you have preserved the caudal 1 centimeter strut, and you took the incision behind that.
Yes, ma'am. So I have preserved most of the caudal edge. It is just the edge which is coming out. So this is how much I removed.
Yes, very minimum part of it.
Very, very minimal. Just the edges which are outside. Now, once we see a deviation like this in an adult, we get tempted to remove the parts inside, and then later we will see a saddle nose deformity. So, trying to be as conservative as possible. Sharp SMR elevator. So there was some amount of stress due to the cartilage's deviation there. We just removed it. Now I'll see what's the bony deviation causing to the nose. There is some posterior deviation still on the cartilage, but I'll address that later once I'm able to see the cartilage in entirety. When it is half visualized, I don't want to be manipulating and cutting excessively. Straight section. This is stuck there. Can you release it? Suction, please. I need some saline irrigation inside. Thanks. Thanks. Okay, turbinate scissors. Sharp SMR.
So still you are on the cartilaginous part?
Yes, ma'am. There was a spur which was there because of the cartilage. I'm trying to loosen it up.
Yeah, we can see a part of it. It's going quite behind posteriorly.
Yeah, ma'am, all the way behind.
Under the vomer?
Yes,
Maybe.
right under the vomer. So the rule is not to separate the vomer and the cartilaginous deviation, or rather the quadrilateral cartilage, third size. Release dressing forceps. Ma'am, is the visualization inside better now?
Yeah, It is much better. We can see what part, where you are working. Your hand is not coming in the way.
Coming in the way?
Not, it is not coming in the way. We can see it properly.
Now, I've always had this thing with pediatric septoplasty. Demonstrating or showcasing is little difficult because of the tight spaces involved, but I'll try my level best to be very clear with you, ma'am.
Yeah, very well seen. Otherwise, also septoplasty in adults, also in maybe in postgraduate days, it was difficult to visualize. And those days we were not doing much of endoscopic septoplasty, so it was more of imagination. But now with the
yes, ma'am,
all facilities available, endoscope cameras and everything, the pictures are more clearer.
So this was a spur there.
Yeah.
Still, there is one more piece which is mobile but not coming into our instrumentation. What's the time?
So anything specific in the consent do you discuss with the patient? I don't know whether you have already discussed with this before
I
the
did
surgery.
already mention it, ma'am. For
Okay.
all patients with pediatric septoplasty, we list them for a second surgery. We always list them for a second surgery after they are adults. So that is something that we do mandatorily, that we tell them that there is a very big possibility of a second surgery because of the growth spurt. Although we take maximum precaution not to damage any growth centers. So the growth centers are, one is the spine housing the anterior edge of the septum. Second is the K area. Third is the interface between the quadrangular cartilage and the vomer. Fourth is the interface between the perpendicular plate of ethmoid and the vomer. So if there's a deviation there, then many a times the nasal cavity there would have become roomy already. So you don't need to many times remove deviations there. It will automatically readjust if you remove the stressors. I'll just illustrate it in a while. What I'm trying to explain. I need the fifth size, please. Fourth also is fine. Let's see if it goes inside. Yeah, fifth size. Fifth, we have a narrow fifth one. Take out this cartilage. Can you look at the second set? Is it slender? Yeah.
Good afternoon, sir. Sir, our one of the doctor is asking one questions to you.
Okay. Yes, ma'am.
So, is Dr. Ananda Acharya from Hyderabad, Osmania ENT Medical College. He's asking that what is your take on nutrition of cartilage when are elevated on both sides of cartilage?
Sir, many times when we do rhinoplasty approaches, when we raise it and then we place it back, the cartilages are anyway supplied by diffusion, sharp SMA. So there is no problem to the survival. In fact, when we do septal perforation repairs, we place a cartilage in between the flaps and allow it to heal. So both sides of the flaps can be raised, definitely. So sometimes the fear is if you raise both the sides, will the survival be compromised? No, nothing like that happens, sir. It's been seen over many years. But of course, I agree with you. The teaching earlier was don't take out both the sides, try and retain one side so that the vascularity is not compromised. But time and again, the studies and long-term follow-ups have proved that it is not mandatory to retain that, sir, or retain that principle.
Okay, thank you so much, sir, for answering the question.
So I've gone up to the posterior end of the septum. Of course, with the bony spur still intact, I'm going slowly and steadily to raise off the cartilageous spur. Release dressing.
पीछे 50 छात्र में है। हाँ 50 माइक्रोग्राम के पास नहीं।
Other
बीच में दूरी तो नहीं। वो तो रेगुलर चल रही है थायराइड वाला। लेकिन अभी भी थायराइड बढ़ा हुआ है थोड़ा सा उसको और अपने को बढ़ाना पड़ेगा।
Top SMR elevated.
उसको 1.5 कर दो। 75 कर दो। ठीक है 3 महीने करके फिर मुझे दिखाओ।
So what has actually happened is the septum cartilage has bent again and is sitting reverse direction now. So I'm just trying to delineate that. Sorry, I'm not able to show that.
सर इसमें मशीन सजेस्ट कर रहे हैं।
हाँ मशीन सुनाई दे रहा होगा। हाँ सुनाई भी पड़ता है लेकिन भूल जा बहुत तेजी से। वो तो वो करेगा। खानों में कोई मैल में कोई उसके कारण तो नहीं। हाँ तो बिल्कुल साफ है दोनों साफ।
सर ये मशीन बड़ी कॉस्टली है इसका क्या मतलब?
There is some audio which is disturbing. Can the audio visual take care of it?
Yeah. Cartilage forceps. So what we did just now is remove all the stressors on the cartilage from posterior. Now this fracture line is still there. Can you see, ma'am?
Yes.
Yeah. So the posterior, whatever stressors were there, saline wash.
So I have just one question. The cartilage, the spur when you removed, so that was the junction between the cartilage perpendicular plate and the femur, which has to be disarticulated?
No, ma'am. I have not gone to the point where the perpendicular plate of ethmoid is with the cartilage. I have only gone to the maxillary spine area and on the crest.
Okay.
So this is all I have done, the inferior strip.
Not up to the femur?
No. The most of the cartilage, the pediatric septum is, most of it is cartilaginous. The bony part is very, very minimal. So that minimal part also we try to retain it. If there is a spur at that point, then obviously I'll try to handle that by realigning it. So I just want to show inside. I'm not sure if it is seen. Is it seen?
No, inside part we can't see. You'll have to change the direction of the camera.
So I removed the cartilaginous spur there. The bony spur is still sitting there. So without much of delay, just clean with sterilium. So here, ma'am, basically this surgery was to make sure that I get at the posterior septum and I'm able to retain the caudal edge. Earlier, the caudal edge was here. We brought it back all the way here.
Can you centralize, please? Picture is not centralized. Yeah.
Now, if you have seen, as a conventional rhinoplasty, I have not gone and split the whole area, not raised the whole thing. All I've done is the exposure anteriorly. That's it. Just so that I'm able to get this. So the caudal septum was here initially. It was like this. Okay, so by releasing the stressors, I've got it back to center. But of course, there is a septal fracture there that I need to handle it. I'll show in a while how I'll be handling it. Just using the cartilages which I possibly just took out now. Second size. What's the pulse rate and BP? Okay. Sir, can you see the maxillary spine here? Dr. Jaskaran was asking.
Yes, yes.
You can see, right? And this caudal edge has gone beyond it to one side. So what I'll be doing is getting the whole thing to the center and fixing it like this so that one point of fixation is there. Okay, and then whatever the fracture line is here, that also needs to be handled. So if I can raise the maxillary crest here, in a while I'll be showing you where exactly the deviation is affecting the whole cartilage. Sharp SMR, please.
Bye-bye.
Third size. Third. Do we have another third size which is better? Fourth. So the maximum space that is available for me is just the speculum. That's about it. The space wouldn't be available normally if you are doing an endonasal approach. We just have to take the precautions for the same, suction smaller. Turbinate scissor. Sharp, strong elevator. The other one. Yeah. So I just shifted to a stronger elevator to be able to raise the maxillary crest posteriorly. Touch, please. Quadrant. Whenever there is a deflected septum like this, there will be aberrant vascular channels in the bone. So it's likely that there can be a spurter from the base. Packing. Okay, give me the fifth size. Fifth size. Fifth size. Suction, please. I think what we have to do is put the endoscope and show you now. If not, you won't be able to see what all I'm doing inside. Difficult because this whole thing is coming in the way. And Touch, please. Touch with cautery. Yeah, neuropathies. Keep a ribbon wick for packing. Keep a ribbon wick for packing. Give. Put it inside. Bigger neuropathies would be essential. So posteriorly, the deflection seems to have become better. Checking on the right side. I'll just check it on the left side. Section, please. Clean. Suction also clean. Hold. Just switch off the top light, please. Ma'am, can you see the spur lying on the floor almost? Is that seen or not seen?
There is a little bit darkness inside.
I'm sorry, I think we need to get the
Maybe.
scope in. Only with the scope we can see, I think.
Yeah.
Sterlium clean. So you can see with time the septum is slowly moving into the midline.
Yeah. That is looking much better now.
Yeah, so
Quite straight also.
that's the main purpose, ma'am. I mean, if we remove the stressors, that should be enough actually.
Yeah, that's true. Looking much better.
I'll just remove the spur which is causing the obstruction on the side, but I need to show you this with the endoscope. Niranjan, can you help us with the endoscope? SMR elevator. Yeah. Are we getting the endoscope in the same time?
Coming the endoscope.
Packing. Endoscope ready? Same endoscope, huh? Any other endoscope is there? Any other endoscope? I think the feed will be difficult for them. No, okay.
Can you please tell how you pass the suture, sir, from pericontium? Can you just elaborate once again, sir?
Yes, Dr. Jaskaran. So, can you repeat again? I heard it partly. Sorry, I was looking at something else. This is the bony spur I'm removing. Can you see?
Yeah. Reproduction. So that bony spur is from maxillary crest?
Yes, ma'am.
Yeah.
I want to show you inside because that would help us understand the whole thing. I'm just waiting for the endoscopes to come in.
Okay.
Sharp elevator.
Changing the camera.
Sir, we'll just change the camera. So there is a, because the spur was very sharp, there's a tear posteriorly, but then I wouldn't be worried about it because one side I've kept the flaps intact. And it will also help us in the drainage. Scope ready? Saline wash inside. Savlon. Scope is ready to be shown. I'm sorry because this part is not seen. I'm just putting the endoscope inside. Ready? Savlon. Put a gauze piece inside. Yeah. Do the focus, please. Do it. Do the focus. Thank you. Let's do the white balance. Just hold. Hold. Okay. So this part where the spur was there, you can see that the tear is here. This is the cartilage and the purpura plate of ethmoid suture line. Can you see, ma'am?
Yes.
So don't disjoint that. That is what we usually do. You can see the bony spur, which was like this. I've removed parts of it. That's the remnant there. Okay. And the other side, I'll just show you. There's some cartilage yet left behind here. I'll just take it out and show once again. So anteriorly, all this area had the mushroom type spur, means it was arched below towards the nasal floor. So this entire area I've taken it out. And more importantly, what I've done is retained everything. I have not raised too much, kept more of the quadrangular cartilage still intact. I'll just show you with the wash now. Enough.
So whole idea is to remove minimum as possible.
Yes, ma'am.
keeping the growth centers intact.
Yeah. So I'm not going to go. Let's say there is a deviation up to the choana, ma'am. I am not going to go there because that is one more beam of support. And that is something, again, we need to avoid moving.
Yeah.
So many people, they feel that posteriorly also you should remove the spur or the deviation. But if you look at the nasal architecture, the posterior part of the nose is anyway roomy. So if you
Yes.
can keep that pillar intact, then nothing like it. Turbinate scissors, please. What's the time? So I use the turbinate scissors for very specific cuts. I don't want to move with the gouge. I don't use a gouge in a pediatric population because there have been reports of gouge slipping into the dental roots and spoiling the dentition forever in the post-operative period. So never try to use them. Okay. Cartilage forceps, please. Oh, this is too short. Okay. So most of the septum is still intact. We have not opened the apolateral assembly. We have not divided too much of the spine. You can see that the spine envelope is here. We will come to this now. Dr. Jaskaran, you were asking something earlier. Asking me to show the periosteum.
I think he wanted to know how the
Sir,
sutures are taken.
I was asking about the periosteum from where you will take the suture, sir.
Okay. Just give me a second. Third size, please. Yeah. Cartilage forceps. So you can see that the spine is still here and it has slipped to one side. So if you expose the spine here, this envelope is comfortable enough to get you a hitch for the PDS. Only thing is you need to place the spine, cartilage on it and then suture it. That I'll show in a while. I just wanted to introduce the scope and show it to you as to what are the parts which have been removed and what are the parts which have been left behind. Scope, please. So most of the cartilage is intact. Can you see, sir? It's almost like I haven't removed anything. The cartilage is sitting on the floor itself. This is all cartilage there and some amount of cartilage at the back. The spur has been removed. I'll just show the side opposite the opposite side perichondrium. Just hold. Suction. So that's the opposite side perichondrium and the cartilage which has been removed just on the inferior crest.
Yeah.
And all the attachments superiorly. Now what we generally do is in an adult septum, we move high up under the upper lateral cartilage here. We try not to touch this area because that is where the stressor forces will be. The main stressor here is from the excess cartilage on the inferior part rather than the superior part. So I'm just taking you to the point where the perpendicular plate of ethmoid and the cartilage interfaces here. So try not to separate that area, and you've already seen in the CT scan that there is pneumatization, and that septum is definitely going to be problematic. So now I'll just go get me the 5th size speculum, dip it in saline and give. I'll show the left side. Space, hold this, please. Suction. I just want to show you a remnant spur despite our removing so much. Can you see that spur part, which is still remnant?
Yeah.
So this was where the spur was indenting the floor of the inferior, or rather the nasal floor and the inferior turbinate itself. You can see the concavity there.
Yes.
And now this last part here, I'll try to remove it. Now, once done, that should take care of all the septal deflections posteriorly. Now, all I have to do is anteriorly, I have to correct the deviation, not by scoring, not by trying to remove the excess cartilage, but by strengthening it using a straight piece of cartilage. If I've strengthened it with a straight piece of cartilage, that should be more than sufficient. I need something which goes all the way back, but it's too slender a space. No space at all to reach. No. Size 4 is okay. I need an instrument to take out the spur. Grasper. No, it's too big. Suction pressure to increase, please.
Do you use any specific instrument which are different from other routine septoplasty?
Ma'am, I use a pediatric lux forceps and size 1 speculum, suctions block.
Suction block.
Suction block. Okay, turbinate scissors. Apart from that, nothing, madam, except that out. Suctions working or not working?
Suction pressure to increase.
And if the patient is having severe external deformity, then what is your take in those patients, like who are requiring osteotomies or?
Ma'am, if it is less than 14 years, I don't do osteotomies. If it is less than 14 years, I definitely don't do osteotomies or hump reduction or any kind of bony work superiorly. Sterling, please. It's only inferior that I do. The reason is many children, the growth would have kind of slowed down at that age, which allows us to correct the external skeleton. If a child or a teenager comes with a request for getting their nose shape corrected, can you take this out? This. then I would reject it and then tell them that you wait out till you're 17 to 18 years and then we do it. But if it's a very gross deviation, I will counsel them and tell them that there is a possibility for a second surgery, even if I do a correction right now, because we are anyway approaching the septum through the rhinoplasty approach. You would benefit, you would benefit with a straighter nose. I never promise a 100% straight nose, because with time, there is some amount of deflection that happens.
Yeah.
And that I'm sure all the rhinoplasty surgeons would have experienced.
Yes, that's true. So ideally it is 17, 18 years of age.
Yes, ma'am.
Where
Ideally.
rhinoplasty would be.
Yeah, even in the 17, 18 years age group, ma'am, the 6% of the population, it is seen that they continue to grow their nasal septum until 25 years. So it's always better to err on the side of saying that I might not be able to give you a perfect result, but I will give you a straight nose as much as possible. Now, the function here or at this surgery in this conference is about breathing, SMR elevator. So if I've established the breathing, the outer part ceases to kind of come to their notice. But if they're very, very concerned about it, that is something that I list early on and tell them, if you're coming for cosmetic surgery, please, this is not the place to do.
Yeah, that's true.
Okay. Let me see with the scope. I'll just put the scope in. Sorry to keep you blind for some time. And the nose is so narrow that the 4 mm scope doesn't go. Sorry. I'll just try to pull the... That's okay. Just give a wash there. That was where our spur was. So we'll try to go past that. Yeah, wash please. Yes, thanks. This is stuck here in the coupler. Here, scope is stuck in the coupler. Thanks. Hold this. Keep a 50 PDS, please. Yeah, scope, please. Ma'am, this is the posterior part, nasopharynx.
Yes. Yeah.
So mostly the spur has been removed. So my role now will be just the anterior part. Okay. So I'll just go to the opposite side and see what is the role there. Suction, please. Hold this.
This is good.
Clean the scope. I think it is fogging. Just hold the scope there. I just want to clean the suction to me. Yeah, ma'am. So
Yes.
that's how it is.
Nice.
Yeah.
Yeah.
Okay. So mucoperichondrium is intact here, the concave part and all that, and the deviation is reasonably corrected. So now we fix the coupler back, get the second size speculum. Niranjan, give a wash. Give a wash.
That was a 4mm endoscope you were putting?
Yes, ma'am. That's why it was. But what happens if I put a pediatric scope? Again, it becomes a narrow visualization. So I thought I'll try and show with the 4mm scope itself.
No, if the 4mm scope is going so easily inside, that means the breathing passage is quite clear.
Okay, ma'am. Thank you. So I hope now the only thing I'm left with is straightening that fracture and fixing it to the spine in front. So sharp SMR elevator. Number knife, please. Put the coupler, please. Cartilage forceps, please. Hold this. Sharp SMR elevator. So I just want to bring to your notice one point here. Ma'am, can you see this? Hello?
Yeah, we can see. Yeah, this is better.
So the maxillary spine is high up here and the cartilage is overriding it. Can you see this?
Can you centralize, please? Yeah, you need to adjust the camera.
Niranjan, top light on, please.
Yes, we can see the picture now.
Yes, ma'am. So you can see that the spine is here and the cartilage, instead of being on it, it was resting like this. That is in front of the spine. Can you see this?
Yes.
Okay. So that arrangement is because the cartilage had buckled like this. So that means to say this part is actually excess, the lower part.
Yeah.
This part. So we will need to sacrifice this.
That's true.
So it was lying like this because it was excess and staying away from the spine area.
Yeah.
So now let us imagine that this is excess and this is the spine that you're seeing. All you need to do is fix it here. Once you fix it here, that curvature what you're seeing, instead of scoring or cross-hatching, just get another piece of cartilage to straighten it. Now you placed it inside the pocket or the columnar pocket, and then you close the incision as you would do for a rhinoplasty.
Yeah.
Okay, ma'am. So this is also causing some amount of deflection. As soon as I release this, it is going to be better.
So in rhinoplasty, usually we do this with the perpendicular plate of ethmoid. That gives a very good strength. Splint it with the perpendicular plate of ethmoid.
Yeah. So here, since we are not allowed to go much at the bone,
that's true.
We would prefer doing more of the cartilage work inferiorly. Now you can see, ma'am, as soon as I took out that, it is sitting.
Yes.
And this deviation, I need to batten it in such a way that it straightens up.
Okay.
So first.
So you will put it on the convex surface?
Either surface, but the suture has to be one front, one back. It has to be stiff enough. Okay. So pass me the fifth size speculum. Keeping the dip it in saline. Keeping the septum in the center and the batten there, I'm just trying to see if my fifth size speculum goes freely to go posteriorly. So that's what I'm able to get. So let me first fix the septum to the center and get the batten in place. Now, if I fix it to the convex side, your question was very pertinent, ma'am. There can be a additional bulge over there. So you can fix it to the concave side, but the convex side of this cartilage has to be here, like this. Okay, PDS, please, slip retractor. I mean, all septums are not as simple wherein you can just get away with doing the inferior crest. Many times there'll be a K area deviation. Many times there will be a badly bent bony cartilage deviation. Get me the needles, please, if you can. That means at the level of the perpendicular plate of ethmoid itself, there will be a deviation. So those things you won't be able to handle just with what we did today. Maybe this case was easy on us, but then many times there'll be even more worse deviations. So the sutures that we use on children are something that dissolves away over time. Do not use permanent sutures. Hold the cartilage, please. Cartilage. PDS has a strength, don't tilt, which stays for about 3 months and then dissolves away, leaving a scar tissue behind. The scar tissue holds. And meanwhile, the growth patterns with a batten graft is going to make sure that that piece of cartilage doesn't turn. Cut, please.
Yeah.
Scissors to me. What's the time now? Yeah. I'm just keeping in mind the time required for the panel. Don't bend it. Just leave it. Just hold it. Leave it. So the way to suture across a fracture line is one suture behind, one suture in front, and one suture at the fracture line. So that's what I'm trying to do. If I feel that this cartilage is not sufficient enough, I will use another cartilage which we have already harvested. There's a lot of difference from the adult rhinoplasty, but then this is how pediatric septums are. Don't pull. Don't pull. And these are the points we need to take home. So just to reiterate whatever I said, never go and split at the upper lateral and septum. If there's a K area deviation along with the septal deviation, if the patient is more than 14 years, then you can go and split and do an extracorporeal septoplasty. A young patient like this, I would prefer not to do bony work on the top. Try and do most of your work inferiorly. Now, the thought about the maxillary spine itself, that the maxillary spine itself can be deflected. So this was something that is in adult. We tried, speculum please. Yeah, 2 or 1 is okay. So don't try to dislocate the maxillary spine. That is counterproductive for us. Because we don't have any utilization of dissecting the cartilage spine, the spine away and moving it. Try and fix your septum to the center. Okay. Just a second. Is the stitch seen?
Yes, yes.
Okay. No. So I'm engaging the periosteum here. This is the maximum we should be able to do in children, rather than trying to cartilage forceps. Move the whole skeleton to suit our needs. Careful.
So one should avoid making holes in the anterior spine to
Yes, ma'am. Totally.
fix the caudal septum.
Totally. Especially in children.
Yeah.
I think the CT scan I showed that time, there's a lot of tooth roots waiting to be damaged.
Oh, okay.
I would avoid that totally.
And if the anterior spine itself is deviated, then you fix the septum on one side of it?
Yes, ma'am. One side, and try and get your alignment to the center rather than trying to move the spine itself. The maxillary crest also, what happens is when we remove the maxillary crest, you have a marker, brother? Yeah. I'll just draw it here, ma'am. Can it be seen? Here? Here, ma'am?
No, we can't see. Yeah. Okay,
so
yes.
most of us, here? Okay. So most of us, when we remove the spur, we remove this part, we remove this part. And in the process, many a times, let's say this is what is coming to rest, we will think this is also deviated and we'll try to remove it. No, if the cartilage is innate and just standing like this, just allow it to fall on it. Because if you try to remove this part, you are leaving a gap and no connection between the two.
Yeah.
So in a spur like this, it's just best to remove this much and allow the springiness to fall on itself and align itself. Because the K area is not what you have touched. You have not touched the choanal pillar. You have not touched the skull base. You have not touched or rather corrected the anterior maxillary spine. I have some more work to do with straightening this cartilage, or rather the fracture line. I'll be at it. So if there are any questions, I'm happy to answer. Dr. Urvashi, any questions on the question forum?
No, sir. Right now we don't have.
Or double look.
So you said this patient had apnea.
Yes, ma'am.
Sleep apnea. So in case if the patient has deviated nasal septum as well as adenoids, then do you prefer to do both the surgeries at the same sitting?
Yes, ma'am. Yes, ma'am. Definitely. Because adenoids, obviously, after the medical treatment, if it is something that needs to be handled surgically, will give a predominant benefit to the patient along with the septal surgery. So we did look at the adenoids even before the septum, thinking that if it's only the adenoids, if we can correct it, we will help the patient. And the other side, if the scans were looked carefully, the other side was roomier than this side. maybe giving the patient a 20% space over the totally blocked space on the left side. Hold this, please. So what I'm doing is micro correction of all the deviations by putting the sutures in front and back, utilizing the straightness of that piece what we removed inferiorly. So there were questions earlier, which I remember. I can just go over them. That is, what do you do if there is a tip projection which is not sufficient, or you feel it is aesthetically not appealing? I would not do anything at that, because the rounded nares and the tip is what a child will have, and that is something which I will try to avoid correcting. Can you see the deflection, ma'am, on the front?
Yes.
So that is something which is excess for us. I'm going to trim it off.
Okay. So do you take a single suture at the antenatal spine, the periosteum and the caudal septum?
Yes,
Or
ma'am, that is
multiple
sufficient.
sutures? Single
That's
sutures.
angle scissors. That is sufficient, because for us, the main purpose was getting it back into the center.
Okay.
So this might look like it is floating. No, it has been fixed to the spine itself.
Yes. It is looking better now.
Yeah. With time, as the fracture posteriorly is also corrected, it look straighter, ma'am. So luckily there is no fracture line proceeding on to the dorsal septum. That's why we can afford to not touch the dorsum and not have to deal with the dorsum itself.
Yes. So if there is fracture line to the dorsum, then what is your take on it?
If it is causing obstruction, definitely, ma'am, I would have to deal with it. But then if it is not causing obstruction, I'll delay it for a later date. Unless
So do
the
you put a
patient
spreader graft or something if there is a dorsal
spreader batten, ma'am?
deflection? Yeah.
Spreader batten, yes, but then if I have to split the upper laterals to do that, I wouldn't do it. If I can do endonasally itself, or rather with the same incision itself, I will go ahead and do it, ma'am.
Mm-hmm.
So this is something that all of us need to practice, is putting batten grafts to correct the angulations. So what was deviated and here came here. There are two schools of thought with the caudal septum. Many feel that the caudal septum itself is excess. That's why it is going off to the side. Some people feel, or rather the other school of thought feels, no, its caudal septum is just dislocated out of the columnar pocket. All you have to do is replace it into the same pocket. So that's what I have done now. The caudal septal edge was never removed. All it was done was got from here and put it into the space in between. Meanwhile, as I am doing this, we can actually show some of the long-term follow-ups of the patients and the various concerns that we usually have. What about the scar? What happens? Will there be a saddle nose deformity? Will there be some... Don't pull. Yeah. Dinesh? Leave it. So now I am just going to go and close the incision as we had started. That's about the septal part which I'm going to do, because that part has now auto-corrected itself, the fracture line. It has come into alignment. Okay. Now, if you remember, we had made various marker points by cautery. We had marked these points. Can we see it here, ma'am? Hello?
Yeah.
Yeah. So we had marked these cautery points to be able to reflect it back. So before that, what I would like to do, in a patient with, or rather in an adult rhinoplasty, what we usually do is do a transdermal stitch.
Yes.
But in a pediatric rhinoplasty, we don't do a transdermal stitch because that is going to change the entire orientation of the whole medial crura and lateral crura. All we are going to do is get the cartilaginous portions together the way it was earlier.
So you are stitching back the soft tissue around the cartilages.
Yes, ma'am. Cartilage forceps, please.
And how did, sorry, I missed that part maybe. So how did you do the markings?
So when
Where did you do the markings? Yeah.
Ma'am, when we are actually cutting the soft tissue that is binding the, or rather the ligament of Pittangai, so we just burn that area and cut at the point of the cartilage itself, so that that serves as a marker for us in the future. That is when we are closing the incision. Or you can use a marker and mark it out.
Okay.
Dr. Manjula, ma'am. Manjula, ma'am. Relax. Relax. Hello.
Sorry, Krishna. Sir? Yes, sir. Yes, sir, Vishwas, sir. Dr. Krishna.
Yeah, the panel, I think we are about 10 minutes away from the panel. I don't want to hold
Yes,
them
sir.
back.
Right, sir. Okay,
So,
sir.
if there are any questions that anybody wants to ask, I'm happy to answer, and I'll just continue to close. And this is a regular closure. Just a few points to be remembered when we are closing. That's it. Hold this, please.
Right. Noted. I'll inform the panel also maybe the next 10 minutes.
Dr. Krishna sir, that Dr. Sachin's book announcement is
there. Sir, will do.
Yes, Sharona sir. Yeah, hi sir, Sharona sir, can you hear us?
Dr. Jaskaran? Hello?
Yes, sir. Yes, sir. We can hear you, sir.
Yeah, thank you. Thanks for coming in and being the chairperson moderating the show. And thank you, Jyotsna ma'am, for asking the pertinent questions so I could be able to answer all the various modalities of treatment in a pediatric rhinoplasty.
Yeah, thank you. Thank you, Dr. Vishwas. It was a wonderful presentation, a wonderful demonstration, and lot to learn in pediatric septoplasty. Actually, everyone, all ENT surgeons are a little bit scared to touch the septum, especially in children.
Yes,
so, so it is a very important topic for everyone, and especially for juniors, mainly how to select the patients, and then how to go ahead with it in the minimalistic approach. That's very important.
Hopefully, I have not.
And you showed it very nicely. Very
hopefully, I have not given too much fear of surgery.
No, it was a nice demonstration, wonderful demonstration.
Thank you, ma'am.
And you pointed out how to do it very well. So, what to preserve and what can we take out. So that is very important.
not going to have to.
Yeah. You can proceed to the panel. I won't hold you back. Yeah. Thank you. I think this is yeah. Mm-hmm. Another one or the short one is enough. Cut beyond the knot.
So just one question: do you need any columnar strut? In these cases?
No, madam. The septum is anyway in the midline now. I wouldn't need. It's actually coming anteriorly.
Yeah, in this case definitely, but in case if the septum, if it is fixed on the antenatal spine, it is not so much anterior, then do you put columnar strut or otherwise?
Sure. Ma'am, if you're doing a tongue in groove technique to increase the caudum or the dorsum, then we are likely to interfere with the natural septum. So if we are placing something end on the caudal septum, then also we are likely to interfere. So preferably we don't do any kind of columnar strut work here, ma'am.
Okay. Yeah, thank you.
Thank you, ma'am. So fragile. Leave it. Fifth size, please. Fine AdSense. Vehicle rapid. Hello. Hello.
Yes, Dr. Vishwas, we can hear you.
Yes, ma'am. Just closing off the incisions. So normally when we are putting a stitch in an adult, we tend to put it as close to the skin as possible.
Okay.
It's better to keep this bulk by taking the stitch posteriorly, because that is what gives the extra roundedness in the patient. And it also acts as a cushion for the cartilaginous envelope that we are having. So normally we would take the stitch here in an adult. It's better to take it posteriorly.
Okay.
Just a few points here and there, but then they go a long way and make a difference to the healing.
That's true. Small tips can make large difference in the surgery.
Now, as aesthetic surgeons, I'm sure all of us will be tempted to go ahead and make the nose look more beautiful. But then in this child of 8 years, this nose is beautiful. We should not try to meddle with it too much. Because the concern here is mainly the breathing, and the approach is only rhinoplasty. Just because the approach is rhinoplasty, we don't need to exercise our adult minds onto the children's faces.
Yeah. So you will be putting nasal pack or Doyne splint inside? How
no,
you will be
putting the knot? Ma'am, I just put Cuticell, fold it and keep it. The
it's something like the Surgicel?
No, Cuticell, that is Sofratul.
Okay.
Please.
Yeah.
The reason is children are obligate breathers and they don't like packs inside their nose. So I just put a soft roll with Cuticell, and then after that, I take it out on the morning after. That will also avoid any kind of bleeding by giving some amount of compression. At the same time, the child will be comfortable because it won't be too stuffy.
Okay. And any taping will be done? Do you do any taping?
Taping, ma'am?
Yeah.
Yeah, definitely. For the tip, I will be doing taping to avoid the collection of blood. The tip, definitely I'll be doing taping. And one side, since there is a tear on one side, if you remember the spur side, we had a tear.
Yeah, left side. Yeah.
So I will just keep a watch over today to see if there's any ooze in the post-nasal space. That's the only precaution I'll take. There is no ooze right now with the normal pressure.
Yeah.
I think Dr. Sharnu Malipatil is already ready. I don't want to delay their panel discussion, and I'm sure many people are waiting to hear them speak. And thanks for joining us, ma'am. I know you had a personal engagement to keep. Despite that, you came and moderated the session. And especially all the audience, thank you so much for being with us on a Saturday and learning with us. I hope it helps you. The winding of the last surgery of the day, I would like to thank our OT team here and the brothers and the sisters who are helping us. From Uma Rani, Rahul, Anantu, Niranjan, Stani, and everybody. Sorry if I missed any names. The excellent anesthesia given by the anesthesia team headed by Jaydev sir, Jyotsna ma'am, Kavana madam, and Bindu ma'am. And of course, our entire ENT Trustwell team, which has stood by us in whatever we do, and the management of Trustwell Hospital, which has always been encouraging of the ENT department to do more programs. In fact, they have given up the whole OT for our usage today, so that there is no interruption to the work. I would like to thank Dr. Madhusudan, CMD, Dr. N.S. Chandrasekhar sir and Deepak Haldipur sir for making it possible. And a special thanks to the Microlabs team, which year after year trusts us to do better at Trustwell. Dr. Krishna Manjula ma'am, Mr. Bhaskar, Dr. Urvashi, thank you. Thanks for making us do this program. There's many more things to come, and I hope we'll continue to innovate and make it better. This program this time is special because some of the international faculty have joined us and also there are some international centers where we are transmitting to. We'll have the proline, please. So the stitch on the skin should be proline because the reaction is always going to be more with a Vicryl rapid. Sharnu sir, we are done. Actually, you can start your session. We are not holding you back. We're just closing.
It was really nice. It was really nice seeing you operate on this, this case. This is really good. Shortly, probably we're going to start, I suppose, right?
Sir?
Hi, Vishwas. Can you hear me?
Yes, sir. Very well, sir.
It was really nice seeing you operating. It's a really nice surgery. Well done.
Thank you, sir. Thank you.
Yeah.
I just wanted to pass on a few tips and tricks of handling a pediatric septum without fear. I'll just run through a few slides. Where's my laptop? Can you ask them to run a few slides to show what happens in the long term? Can you call Dinesh? Can you connect to the laptop, please? Connect there. 8245. Yeah. That, QT cell, please. There strips. Scissors, please. Manjula ma'am, I'll just show the PPT just to show that long-term follow-ups of some of the patients done.
Yes, sir.
Just to show that, not to show off my results, just to show that you don't have to be fearful of doing a pediatric septum. Next slide, please. Yeah. I don't need this surgical feed. If you can just play only the slides, please. Yeah, so that's 6 to 10 years. Next. You can see that the scar is hardly visible. This is what most of them do ask me, what happens to the scar and what happens to the healing. Next slide, please. And you will be able to get a straight septum also if you are having a K area deviation. Of course, as mentioned, you can place a baton endonasally rather than opening up the upper lateral. This is a 5-year follow-up. Next slide. 5-year follow-up of the patient. You can see that's hardly any saddling and the ethnic and the original nasal architecture has been maintained, just that it has been straightened. Next slide. And this is what the scar is with a rhinoplasty approach. Next slide. This is a hump removal that you can do if that is part of the septum which is moving up. Now there is a concept called as preservation rhinoplasty, wherein the top part of the septum which is causing the hump is not handled. You would rather go subdorsally, that is inferior to it, and remove a strip so as to allow the hump to fall into position. Next slide. This is a patient again in the same age range, and you can do a combined rhinoplasty as well as a septoplasty. Next slide. This is again a 5-year follow-up of the patient having a osteotomy work done along with a septal work. Next slide. So 15 to 19 years, nowadays I counsel them and tell them that I can give a straighter nose, but I would definitely tell them that a small possibility of a revision surgery at 25 years, if at all there is some amount of deviation on the septum. Next slide. This is at again 19 to 25 years. Next slide. So the follow-up concerns were the scar and the growth itself that I've addressed sufficiently in the surgery. Next slide. Next, please. Yeah, so this is a patient which I wanted to tell you about, why you need to counsel and consent correctly. This was done at the age of 17 years. You can see that the deviation coming back after 2 years. Obviously, I put strong cartilages using the rib. It was not a warping. It was just that the growth was continuing. So on some people, they continue to grow. So do consent and let them know. Next. So this is also one of my very own cases. I had done this patient when he was 14 years old. So he came when he was 23, and then I did my own revision. So I'm happy to show that we all can have failures in rhinoplasty. There's nothing wrong in admitting that, but definitely we need to learn from our own faults and lessons. With this, I'm hopefully winding off and clearing the way for Dr. Sharnu Mali Patil and his panelists to continue the session in ENTrain. Thank you.
Thank you very much, sir. It was wonderful. I want to tell you, nearly 1,600 plus 500 live people were watching your surgery as we speak. And it was wonderful. And thank you very much for guiding us through this entire ENTrain. And it was more of a hand holding for us. You really helped us to conduct this. Thank you very much, sir.
Thank you, ma'am. Thanks for the opportunity. And thanks to everybody for helping me. My associate consultant here, Dr. Safina, and my fellow, Dr. Vitun, who have been part of this arrangement. Thank you for all the help. And all the sisters and the nurses here. Thank you.
And my classmate anesthetist, Dr. Jaydev.
Oh, yes. And of course, the last thank has to be to Dinesh Pal.
Yes, sir.
And his team, who has always been, like, as sir said, the Satish Jain of audiovisual transmission.
Yes.
He's so good that any problem, he solves it in seconds and he gets the transmission back online. Thank you.
Thank you so much, sir. Thank you very much. So, good evening once again, everyone. So, we had a spectacular surgeries from the legends from morning. Dr. Deepak Haldipur sir started off. Then we had Dr. Satish Jain sir. Then Dr. Ghosh. Then we had septoplasty by Dr.
When you want it to stay, it doesn't.
Sir, you want to speak something, sir?
Mic off?
Vishwas sir, you want to
No,
speak?
sorry, the mic is not off. Sorry.
Right. It was wonderful. I'm sure you have learned a lot of things from our legend. So now we are moving on to the panel discussion. So I'll just start. Dr. Krishna, you're sharing? Should I share this?
Urvashi is sharing.
Okay. Yeah.
Yes, ma'am. Just give me a second. I'm sharing the screen. Yeah.
Yeah. So the topic is CSF rhinorrhea. It is being moderated by Dr. Sharnu Mali Patil from Bijapur, and he has 5 panelists whom I'm quickly going to introduce. All of you know all of them very well, but as a formality, and it's my privilege to do so, Dr. Sushinder, Dr. Raghunath Hanbok, Dr. Gagandeep Singh, Dr. Pradeep Osamani, and Dr. Nishit Kesha. So, yeah, right. Can you move to the next slide? I'm sorry, we are little behind time. I think few 15 minutes behind the schedule. I'm sorry. So to start off with, the moderator for this session is, I can see. Thank you. Dr. Sharnu Mali Patil. Sir is Associate Professor at Department of ENT, Sri B.M. Patil Medical College Hospital, Bijapur, Mali Patil Sri Sangameshwara Hospital. Sir has been guest speaker for various national and international, to name a few, anterior skull-based dissection demonstration at SMFC Bagalkot. He's been the anterior skull-based dissection demonstrator for neurosurgeons, NISSL 1 and 2. And Karnataka State Conference Advanced Fest Dissection Demonstration at Madkeri. He has entered several skull-based dissection courses on anterior and lateral skull base at Kuala Lumpur, Malaysia. Dr. Malik Patil sir, thank you very much and accepting and
Thank you.
accepting to
Thank you so much.
Thank you. Welcome.
Thank you. Thank you.
Then other panelists will be part of this. Other esteemed doctors are Dr. H.K. Sushin Dutt. Sir is a senior consultant ENT neck skull-base surgeon at Fortis Hospital, Bangalore, which is at Nagapavi and Banagata Road. Apart from the regular spectrum of ENT, this Dr. Dutt, he specializes in middle ear hearing restoration procedure, cochlear implants, endoscopic sinus procedure, CSF rhinorrhea surgery, and minimal access endonasal brain tumor surgery, and surgery of temporal bone tumors, and surgery of CP angle pathologies, phonosurgery for voice disorder, and surgery for snoring and obstructive sleep apnea. A special interest include endoscopic ventral skull-base surgery and lateral skull-base surgery. He works in very close coordination with neurosurgical team for the treatment of complex skull-base and brain tumors. He did his fellowship and training in cochlear implant surgery and lateral skull-base surgery in Italy. He has more than 14 years of ENT experience. Welcome, Dr. Sushil Dutt, and welcome to the program.
Thank you, ma'am. Thank you.
And we have Dr. Raghunath Chanbak, sir. Sir is trained at the Department of Ventral Skull-Base Surgery, UPMC, and University Pittsburgh Medical Center, Pennsylvania, USA. Sir is an ardent speaker in various scientific forums. He has publication in peer-reviewed national and international journal. Sir has the privilege of working under legends such as Dr. Rajesh Shah, sir, Dr. Milind Kirtane, sir, and A.B.R. Desai, sir. So, Dr. Chanbak, sir, welcome to you to the program, sir. So we have Dr. Gagandeep Singh Mansar. Sir is presently working at University of Malaya. He has been trained in the University of Ireland and Edinburgh, and also at the University of Malaya. He's a ENT specialist, Hospital Pakar Fatima Mount. Please pardon me if I'm pronouncing it wrong. ENT specialist, Hospital Queen Elizabeth Kota, Kinabalu, and ENT specialist hospital at Tawavu Sabah. He has several medals. One is Professor Henry's RCSI third intercollegiate surgical case presentation. He has won this, and he has written a book. So it's in Malaya. So I translated it as questions on sinusitis. Sir, correct if I'm saying correctly.
Yes, you're right. You're right. Correct.
Yeah. So it's in the Malaysia. So thank you very much, sir. Welcome to you, sir, to the program.
Thank you.
Next is Dr. Pradeep Hosamani, sir. Sir is a senior consultant, ENT head and neck skull-base surgeon at Apollo Hospital, Bangalore. Several international publications to his credit in peer-reviewed medical journals. He has been part of faculty and demonstrated in Karnataka state conferences. His area of specialization includes anterior skull-base surgery, CSF leak, anterior skull-base tumor surgeries, angiofibroma, and advanced endoscopic sinus. So, Dr. Pradeep Hosamani, sir, welcome to you to the program, sir.
Thank you.
So, we have Dr. Nitish Jesha, who is a consultant ENT surgeon at Bombay Hospital, Breach Candy Hospital, and Reliance Hospital, Mumbai. He is the past president of All India Rhinology Society and chairperson of Division of Skull-Base Surgery, Indian Academy of Otorhinology and Head and Neck Surgery. He has written 3 books, and he has written multiple chapters in several books. And he's been faculty on more than 300 workshops and conferences, both India and overseas. So it's our privilege to have you, sir. Welcome to the board, sir. So with this, I would like to hand over this session to Dr. Patil, sir, to take over and conduct the proceeding. Over to you, sir. Thank you.
Very good evening. Thank you one and all for being here on this day. Hope all have joined.
Yes, sir. All have joined.
I'm not getting the screen.
Is it, sir? They've all joined, and only few are on mute. They can unmute, but they're all there.
I'm getting your picture, like the panelist picture and all. Like, okay.
Is it now, sir, visible to you? No. But
This side, Bhaskar, I'm ready with your presentation, sir. When you say start,
please.
I will start, sir.
Yeah, please. You start. You can start. Like, okay. So it's really nice to have you all here. Like, it's really a great opportunity for me to have been associated with all the eminent surgeons in the field of anterior skull base. They're all my friends, and let us start the panel discussion. My panelists for the day are like Dr. Jajit Nishit, Shanbog sir, and like Sushinder, Pradeep, and Gagandev. Hope all are there in the panel discussion.
Yes, we are there.
Yes.
Okay. Okay. Let us start. I request all the panelists to keep the answers very short and crisp so that we have got a lot more slides to run in. And as far as possible, I've kept the slides very simple, and the questions are also more of practical ones rather than the theoretical. Let us start. To start with, when do we suspect a case of rhinorrhea clinically? We'll be sitting in the OPD, and the patient comes in, then what is that which makes us to say that this patient could be possible a case of CSF rhinorrhea? Can we start with Dr. Sushil Dutt?
Yes, sir. Good evening to everyone. It's a privilege to be on this panel. So clinically, when a patient in the absence of cold comes with a unilateral clear watery nasal discharge, it typically happens when the patient sometimes bend forwards and in certain dependent positions of the head, and the patient might say that they were not able to sniff back the fluid discharge. That's when you start suspecting a CSF rhinorrhea.
That's good. Can you go to the next slide? Yeah. As it is rightly pointed out, that is a clear watery nasal discharge unilateral, and that will be worse on leaning forward or on Valsalva. And usually these patients will have one or the other symptoms of raised intracranial pressure, that is headache, tinnitus, vision problems, and dizziness. Or sometimes if the cribriform leak will be there, they will have hyposmia kind of thing. And sometimes if they have, in 25 to 50% of the cases, we have meningitis features like neck stiffness, headache, photophobia, all these things. Probably that is not true with all the cases. And if we take the history, probably they will give history of trauma or sinonasal surgeries or any other surgeries. Then next slide. Let us go to the causes. What are the possible causes of spontaneous CSF leak? You have seen a case of spontaneous CSF leak, and in your experience, what are all the possible causes that you have come across? Can we go to the Dr. Shanbag, sir?
Most of the time, good evening. Am I audible?
Yeah.
Yeah.
Yes, sir, you are audible.
Yeah. Most of the time, as they describe classical picture of.
Please change the next to the next slide once sir starts answering. Okay.
Yeah. Most of the time, it is the same thing. Fat female of 40, as we remember it, FFF, usually obese, BMR around 25 to 30, female, perimenopausal age. They are the ones who come with spontaneous CSF leaks. At the same time, I just wanted to point out that it can be seen as a swelling in the nose if it's a meningoencephalocele with intermittent leaks. So sometimes we get these patients with actually a nasal obstruction, if it's a meningoencephalocele, rather than spontaneous leak, which is happening all the time. And I've had patients who have come to me after an episode of meningitis. That is also a presentation. Patients have had meningitis. They're seen by the clinicians, the neurologists, treated, and then they realize it is possibly because of a CSF leak. These are the common presentations that we come across with spontaneous CSF rhinorrhea.
True. Exactly. In these kind of cases, one of the causes being discussed is about vitamin D deficiency. Have you come across with any patient who has got vitamin D deficiency?
I'm yet to come across a person without vitamin D deficiency.
Exactly.
I think most of us are vitamin D deficient. These vitamin D deficiencies talked about in almost every forum, whether it's ENT or neuro, gynec, wherever. I don't know. Time has to tell exactly how much of this is vitamin D deficiency related. But yes, you can keep that in mind.
Very honestly, there are no clear-cut studies to say. Human trials are not there. In animal trials, they say that it helps in resolving the hematoma and bone remodeling. Okay, next slide. So let us go to the diagnostic protocol. What is the most common diagnostic protocol we follow? Gagandeep, Dr. Gagandeep?
Hi, good evening. Thanks for having me.
Hi.
So, like from the start, when a patient comes in with a suspected CSF leak, I think we are very particular with the history. So we, if there's a history of trauma, then we of course be very certain. Also with history of any sort of iatrogenic nasal surgery, they come in a few weeks later with this persistent nasal drip. So generally what we do in our center in University Malaya is once it is demonstrable, we will arrange for a high resolution CT scan. So 1 millimeter cuts, and we get them in all the views, axial, sagittal, coronal. And most of the time, you will be able to find a defect. And even sometimes with proper nasal decongestion in the clinic, with the nasal endoscope, you can find. So we do a CT scan. Most of the time that works. Of course, if there's a meningocele or meningoencephalocele, then we proceed with an MRI. Traditionally, in the past, there was a role for CT cysternography, but because of the risk of allergies and anaphylaxis and the whole intrathecal injection, we generally rarely do cysternography. So standard is HRCT and then MRI.
Okay. As sir is rightly said, most of the times what we do when the patient comes with a clear watery nasal discharge, we ask them to collect and send for CSF analysis, and rest all the imaging modalities like HRCT and CT cysterno, MR cysternography, and the combination of HRCT and MR cysternography, all these things are done. And the percentage which I have given are all taken from the recent articles. That is the accuracy rate with which we can diagnose the leak. In that, the combination of HRCT and MR cysternography scores more. That is 96%. Anybody would like to add on to this, because this is a topic which is debated a lot, and ultimately some say CT cysternography is very good, some say MRI. So I want some inputs from all the eminent panelists. So sir, Nishit Shah sir.
Hi to everyone. No, I
Yes,
think
sir.
I
Hello.
agree that the plain CT scan with an MR cysterno is probably our first choice. There are occasions when there may be a lot of disease in terms of polyposis, sinusitis in the patient, or there are multiple leaks. So in those few cases, I might choose a CT cysterno.
Okay, sir. Okay, sir. So one thing regarding the beta-2 transferrin, anybody who regularly order the investigation for beta-2 transferrin? Sir, anybody would like to
Dr.
give their
Sushin, I
comments
think,
on that?
wants to speak.
So
Yeah.
in the recent times, there have been occasions when patients are not convinced to go in for a invasive CT cystonogram upfront. So
Yes,
beta trace protein, as against beta-2 transferrin, beta trace protein is now made available by the laboratories, and you could take a fluid sample from the nasal discharge, and you could measure the beta trace protein, and then when there is a confusion, sometimes we can do the indexing of the nasal secretion versus the serum, the fraction beta trace protein in the nasal fluid versus the beta trace protein in the serum. And by itself, if the beta trace protein is above 1.3, then it somewhat indicates that the patient is having a CSF fluid as against anything else. And when there is some confusion, we can do the ratio of the beta trace protein in the nasal fluid versus the serum. And then if this is above 4, as the literature says, then maybe we could also counsel the patient for a more invasive study, wherein we can pinpoint the size and location of the lesion.
Yeah, that's fine. Regarding the beta-2 transferrin, any comments from anyone?
I don't see any disadvantage in doing a beta-2 transferrin. It probably makes it easier if you have a positive result to go ahead with the scanning.
Okay, sir. One point I want to add on regarding the beta-2 transferrin, that is in presence of meningitis, it gives false negative report. That is, this is the extract from the article that says whenever the patient has got meningitis, especially streptococcus pneumoniae, then it's usually negative. That we have to keep it in our mind. When there is a lot of suspicion, then probably the negative report doesn't rule out the CSF leak. Next slide.
Can I ask a question?
Yes, sir.
I am from Dharwad. It's a periphery.
Yes.
I don't have access to beta 2 transparent. I just learned from you all, like Bombay, Bangalore, everywhere. I guess beta 2
Yes, sir.
transparent
Very
is
true.
easily available.
Yeah.
Yes, sir.
Achha, okay. Yeah, okay. That's
In Malaysia, it's not available as easily. So even in Malaysia, not everybody gets a beta 2 transferrin. It's only when there's diagnostic doubt or uncertainty, then we send them for beta transferrin.
okay.
Very true.
I just wanted to ask, there are situations where the leak is obvious. Okay, most of us
Yes.
come across the leak is obvious, and we do a plain CT. We can see the site. That's a very simple situation, but I am sure each one of us have gone through a situation where the leak is obvious on clinical examination, but when you do a CT, we don't see anything. I think we should discuss this situation. Which modality? My question would be, I am not the moderator, but my question
Yeah,
would be,
no problem, sir.
which it would be nice to know experience of every other person.
Yeah,
What
yeah.
happens when you just can't find the leak at the imaging stage? And sometimes we have seen it on imaging, but on table we don't see anything.
True.
That is due to intermittent leak, I think.
Yeah, that's
intermittent leaks.
Correct.
You won't see on the. It should be actively leaking. Only then it will become on the image.
Exactly. Yeah.
So intermittent leaks are difficult to find on imaging. And one point I want to add, instead of going for MR cystoscopy straight away, there's something called as T2 weighted, highly T2 weighted MRI, where without doing a lumbar puncture and giving a contrast dye, to some extent you can detect the leak.
Dr. Pradeep, that's what we do in MR cystoscopy, heavily weighted T2. We don't use lumbar puncture for our MR system.
We don't.
Yeah.
And one more thing
Very
that CT, it is a defect if you don't find, and sometimes MRI can pick up like a small cribriform leaks. Most of the times by CT we will not be able to make out, but MRI cystoscopy will detect it.
Dr. Nishit can.
So, Raghunath, this is a difficult situation that you described. We have a history of intermittent CSF leak or a history of meningitis, and now the patient's presented you with no leak.
Correct.
So, one is you can go ahead with investigations, but your cysterno may not pick up a leak because there is no active leak.
Correct.
As mentioned, an MR cysterno does give you a little better chance to get a suspicious area as compared to a CT cysterno in these situations. Second, you can ask the patient to wait until he gets a leak and do the CT or the MR at that time. Of course, this is with the risk of meningitis because of waiting. The third option is to do a sodium fluorescein and do the surgery or the diagnostic with sodium fluorescein and raise pressure, do a Valsalva while the patient's under anesthesia. And very often, this will prove to be a good option. If even that fails and you're reasonably sure that you've had a CSF leak, there's been unilateral watery discharge with meningitis, then I would do what is called a carpet graft, which means I would graft from frontal recess to sphenoid, from septum to orbit. Just put a whole graft on because that's your most likely area of leak is your cribriform fovea.
Okay.
That's how I would do it.
That's a nice point to be taken. Next
because,
slide.
I've heard about people using gadolinium contrast into the CSF space through a lumbar puncture and doing an MRI. I don't know.
Because it stays longer in the CSF, so you can repeat it. But if it stopped, it stopped.
Yes, right, sir. Thank you.
Okay. Next slide.
Yeah, we are seeing the table with advantages and disadvantages.
Like, next slide. Hello.
Yeah.
So regarding the graft materials, like back, you go back, previous slide. this is the exactly the next slide. Okay, so intrathecal, the sir was talking about the intrathecal fluorescein dye test, like your comments on that, like regarding when to use, how to use, and reactions and side effects. Dr. Pradeep, have you come across, have you used intrathecal fluorescein any time, or like what is your experience in relation to this?
We use it very rarely. Once or twice we have used, but it's very advantageous, especially when you don't find the site of leak on imaging anywhere, but clinically there's a strong suspicion. Yes, it's very useful. Only thing, the correct dose has to be given. Okay. And one disadvantage, practical disadvantage is, so many times if it is active leak, the CFF space will not be there. So getting a lumbar puncture and injecting the dye in that, so many times practically it's difficult. Either it goes to the epidural space or somewhere else. So in that case, if it is not in the correct space, you don't find the dye in the operative field. So that practical experience we had. After that, we have stopped using the dye.
Okay. Next slide. Like
that is intrathecal fluorescein.
Any inputs from others? You please change the slide. Go to next slide.
Fluorescein can be used locally also on table with a blue filter of the endoscope. Sometimes when we don't locate.
Exactly. It's like it's going to be helpful in difficult situations. Like, and blue filter, definitely it's going to enhance our visualization. And this is a point, 1 ml of 10% solution is mixed with 9.9 ml of CSF, and it has to be injected very slowly, more than 10 minutes. And like the only fear of using this thing is like it's related to its allergic reactions and seizures and its toxicity. But definitely, believe me, they're all concentration dependent. Rarely happens. Most of the neurosurgeons, like we ENT surgeons, like don't use it, but neurosurgeons in and day out, they use it. Another thing is it is not FDA approved. The next slide.
I was talking about local installation and then trying to see if CSF takes it. Yeah, it's okay. Yeah.
Okay. Next slide, please. So, like we talk about the management in that, like what is the scope of medical management of CSF rhinorrhea? Where and when you want to go for this medical management? Dr. Sushin?
So medical management of CSF rhinorrhea is mostly in acute trauma.
Change the slide. Change the slide immediately. Like once I finish off, please change it. Yeah.
So when a patient has had CSF leak due to a head injury or any kind of road traffic accident, that's when you might want to wait for up to 2 weeks and wait conservatively before you decide on plan to manage otherwise. Otherwise, I think when you know that there is no history of injury, when there is no history of trauma otherwise, if it's a spontaneous leak, then your thought process already goes along the lines of needing surgical management. So a lot of post-traumatic CSF leaks stop usually by the end of 2 weeks. We can manage them conservatively, and a lot of them are intubated when there are multiple fractures and coexistent injury to the brain. They're usually on the ventilator. Most of them are unconscious. So you would wait for at least 2 weeks before you can decide on managing them otherwise.
Okay. As it is rightly pointed out, most of the times traumatic leaks, like we have to wait and then go for wait with conservative line of management. And then even if it doesn't stop, then you go for the surgery. Spontaneous leaks, I don't think there is any scope for medical management. Like any panelist would like to add?
I would just second what Dr. Sushin said. It's the same. We only consider medical management for trauma. For iatrogenic causes or spontaneous leaks, we know that medical management rarely works. So we don't even embark or don't even start on it normally.
True. Very true. Any inputs?
Can I speak? Yeah.
Yeah, sure.
In traumatic CSF leaks, I've had an occasion where if the fracture line is such that the bone chip sits in such a way that it's not going to close. There's an wide open leak. So yes, we need to wait, but there are times when we feel that this is not going to close. So there is an option to go in and close. The second is iatrogenic leaks. Suppose a FES surgery is done and we know there is a leak. Suppose I'm doing and I see a leak. I would definitely close it then and there. And suppose it's a delayed leak and we do an imaging, and if we see again that it is not just a scratch or a fracture, but an actual break, then I guess there is a scope for going in and closing the leak. I would like to know from other panelists.
Yeah, probably all agree with your comment. Then the next slide. So regarding the graft material, one of the famous statement is we have got many graft, and what suits for which leak, nobody knows. There are no concrete evidences to say that one graft material is better over the other. And I'd like to know your experiences and your choice of graft material that you use in your practice. Can we go with Dr. Shah, sir?
Dr. Nishitsa, sir.
Hello?
Sorry, I'd lost you in between. So
yes, sir.
Generally, with CSF repairs, we tend to go with fat fascia as a free repair, unless the break is very large. I assume we are not talking of reconstruction and surgery. We're just talking of CSF leaks.
Yes, sir. Yes, sir. Exactly.
Okay. So then generally free repairs. Very rarely that you have a very large traumatic defect, then I would go with the flap. But I would say 95% of the time it's a free repair with fat fascia.
Okay. Most of us agree with you, and most commonly used are fascia and fat, as sir rightly said. Then we can use the cartilage in cases of high pressure leak, or like the defect is little more bigger, so that we can reinforce. Anybody for the bone, would like to use the bone. If no, why?
There's a chance of necrosis, free bone sitting there. And unless it's a big, very big leak where even cartilage can be used, bone is usually not preferred. It's difficult to manipulate.
Yes, sir, please.
We could use bone in some areas of some cases of lateral sphenoid recess leaks, wherein you might want to wedge it along with the fascia. We could use it as a gasket seal. If you're able to clearly define an area of defect, say it's about more than 5 to 6 millimeter, then maybe you can put a fascia and then you can kind of gasket seal and countersink it into that area. But like sir said, putting the bone alone will perhaps it could lead to problems. So you could use it as a gasket seal, and this usually is not possible in the case of anterior cribriform leaks, because the defects are usually so small. You may not be able to get a piece of bone or cartilage also into that place, and there, like discussed before, fat and fascia will be more suitable.
Yeah, so ideally, I think Sushin is correct, but between bone and cartilage is probably a better option.
True, very true, sir.
Yes.
Because bone, it's most one or two studies they say regarding the bone as a graft material, it gets resolved over a period of time, so that the chances of failure and re-leak will be more where the bone is used as a graft material. So, any experience of using dural substitutes? Anyone?
Can you repeat that?
No. We used both Duragen and bone for reconstruction in skull-based surgery without any problems. But there you have much larger bone defects and dural defects. So in the context of CSF leaks, I don't think there is much scope for
Yes, sir.
Duragen or dural substitutes.
Any inputs? Like
Yes, the same.
Shanbag, sir?
Yeah, as sir was talking about, I will just continue with what Dr. Nishicha told about, closure with fat fascia, because the primary problem is the benign intracranial hypertension in most of the CSF, spontaneous CSF leaks. So what we are doing is inducing a fibrosis, closing the leak, but medical management of the raised intracranial CSF pressure probably prevents further problems. If that is not done, any kind of closure might induce new problems or new leaks.
Yeah.
So,
Okay.
Dr. Shanbag, on that, for spontaneous CSF leaks, as a routine protocol, we would always do a lumbar puncture and check pressure.
Correct.
So that tells us or gives us two vital informations. One is to tell the patient if the pressure is say 40, 40, very high, that there is a potential for failure of the surgery.
Yes.
And also the need for a shunt in future, should it happen.
Correct.
Whereas if it's a relatively normal 20 to 30 also, I would be a little more relaxed, have him out of the hospital quicker, that sort of thing.
Sir, if I can ask a doubt, do you do manometry, CSF manometry?
Yes, we would check the pressure on table. It's not always reliable because the patients with an active leak may not be normal.
Yes.
But we could repeat it maybe a few weeks later once you have good closure. If you have a doubt on table,
And sir, how much do you rely on the imaging, the optic ring, the empty cella, the Meckel's cave showing CSF? Does it give you an idea about how to handle the high pressure?
Not really. I mean, almost all spontaneous patients will have a empty or a partially empty cella. They will have enhancement of the dura around the optics, all those signs. You could do an MR venography, but even that is a little controversial. Whether the closure of the venous sinus is leading to ICP or has the raised ICP closed the sinus.
Yes.
So, I mean, we do MR angios now when the pressures, MR venographies when the pressure is high, but I think it's just more to complete the study.
Yes, sir.
Okay. So one more comment regarding the cartilage. Like I use cartilage regularly. Like in that, like sliced cartilage is a really wonderful material. Like taken from the septum and just you slice it, slit it, so that becomes more malleable and we can use it. This is what I found. Like any comments on this, like Dr. Pradeep?
Cartilage I have not used. Bone, yes, in the skull-based reconstruction, but not CSF leak per se. Cartilage I have not used much. And which part of the leak you use the cartilage? And
that's what, like
lateral ischius leaks or?
Like that all depends on the site and the size, but like as a graft material, cartilage can be used. Like the whole cartilage is very difficult to use it. Like it will not be malleable, but if you slice it, probably it becomes more malleable. Let us go to the next slide. This is a standard statement. Graft material, like they do not change the outcome. This is what is the standard statement. And like, what is your experience, like Dr. Gagandip?
Yeah, so in our center in University Malaya, fat is our go-to repair graft. Most of our patients, even for pituitaries, we use fat. The only time we consider using anything else is if there's a failure of the fat. At that time, or if the graft is large, we use fascia lata. In terms of cartilage and bone, we don't use it in our center. Yeah, sometimes, of course, if the defect is very big, then you use Duragen and things like that. But mainly fat works for us, and we've rarely had any problems with it.
Any inputs from anyone?
Fat and fascia in equal numbers are used, where I use only fascia in some cases and only in fats in some cases. No difference in the failure or anything. So success rate is same. Use only fascia or use only fat or use both, it's all the same.
Yeah.
I guess most of us, sorry.
Yes, no, after you.
I think most of us do overpacking in the initial phase of our career, and then we realize we don't really need to put so much of packs. Then I think that's what I wanted to say. Most of us put a lot of things.
So one very important thing I would like to say is the first layer of the closure should achieve the seal. It's not the second layer or not the third layer. When you use fat, it should seal. When you use fascia, it should seal. If you use something else, we shouldn't depend on the subsequent layers to do the seal, because if the first layer is not so good, then the fistula will eventually, the leak will find its way out.
So the process of healing in nasal cavity in relation to CSF leak is very strange. Like there won't be any fibrosis. Like only this mucosa grows over and then closes it. That is the reason why the first layer of seal should be very, very perfect. That's what is going to help. Later, like the little subsequent layers are just supportive. They are not going to be helpful very much. I agree with Sushan. Any comments on that? Like anybody?
Yeah, basically, we should go to the bony defect. There are times when the mucosal defect looks big, but it is the bony defect which has to be seen. Yeah.
The pathophysiology of healing process of CSF leaks is totally different in the nasal cavity. It is just mucosa which covers. So that is the reason why we trust on these layers. Like the first layer has to be perfect. This is what is there in the literature. Like any experiences, like anybody would like to add on to this?
No, absolutely, I agree. The first layer, the moment you put the fat in, that should stop the bleeding, stop the leak. If that doesn't stop the leak, then we always, make sure we get a bigger piece of fat and make sure that because that's the most critical thing. If you don't plug the leak with the fat properly, all that extra layers of Surgicel or tissel is not going to help so much. The first leak plug is the most important.
Okay.
Yeah, I think you have to diagnose the site of leak precisely, have your bony margins well identified, make sure the mucosa around it is well debrided. Otherwise, nothing that you put will really stick there in the bone. And that's one area where you want to promote Syneque. You want Syneque because the Syneque give more strength to your repair.
Next slide. Like what would be, let us discuss about surgical technique of choice. Like I would like to share all your experiences regarding the surgical technique. Dr. Sushin, change to next slide. Dr. Sushin?
Yes, sir. Sir, if you're looking at a small leak less than 5 millimeter, I would, like has been discussed, I would like to use a small blob of fat, and gently see if it can be, pushed inside the defect area. It's very difficult to understand whether it sits as an inlay there or as any other layer. But in the area of the cribriform, we gently try to insinuate a small a piece of fat, and then also make sure that we denude at least about 4 to 5 millimeter of area around the area of the defect. So once the fat is in, I usually tend to use fascia. But what has also happened in the recent times is, despite the thinking that less than 5 mm you can use free mucosal graft, my neurosurgeons, when they call us for cases, they love the Haddad flap so much, they want us to rotate a local nasoseptal flap there. So it has happened on occasions that, in spite of our insistence, they want us to use a third layer. They want us to elevate a small nasoseptal flap and put it on top for the third as a third layer. But left to me, yes, I would use a fat going in snugly, fitting there, a little bit of the fat jutting out, and then a layer of fascia.
Okay. Anyone like regarding the techniques, like the way it is done?
Yes, I do use mini Haddad or whatever as and when possible. Like your neurosurgeons, they like it. Possibly because sometimes we don't have access to things like manometry and other things. And if there is a leak in the lateral lamella, I would resect the middle turbinate flush, because in the lateral lamella area, it's very difficult for me. I feel it difficult to negotiate. I make it flush, and then, of course, after denuding the mucosa, putting the fat plug in the bony defect, I do like to put a vascular flap there. and I'm quite okay with that.
Dr. Shanbag, would you like to completely resect the middle turbinate, or you
the vertical,
you are going to take out
sagittal
completely?
No, the sagittal part of the middle turbinate, because it's in the lateral lamella, I find it difficult to go there and try to look for it, and that's what I find comfortable doing. Yeah.
What I mean is, you are going to resect the turbinate completely, or you just the anterior end of the turbinate is being cut and posterior aspect is retained, so that it can be used as a turbinate flap. You know.
Whether used or not, what I meant is around the leak, the middle turbinate, the sagittal part, when there is the lateral lamella leak.
Okay.
The sagittal part, the vertical, whatever anterior part you said.
Yeah. Okay. Fine. Like any inputs regarding the technique?
I'm not sure that I agree with that.
Yeah.
For cribriform defects, they're usually very small defects, very small leaks. And I think to use a flap for that is way overkill.
Yeah.
For a medial cribriform, all you need to do is put a fat plug or a fascia, and you're fine. The moment you start thinking of putting a flap over there, one, it's a narrow recess, and a flap is very thick. There's going to be dead space. If you take out the middle turbinate, then you have to do a full fess, because you don't want your frontal sinus to be blocked.
Yes.
So you're just adding to the complexity of what would otherwise be a simple surgery.
I understand.
And for Sushin's point of putting the flap as a third layer, a vascularized flap works well if it's in contact direct with bone. It should not be sitting on something. So I think you can talk to your neurosurgeons a bit.
Very true, sir. Because like
in our ENT cases, I can get away, but with the neurosurgeons, we have to accommodate.
Yeah.
I guess. I think I also learned something. Let me try not to take a vascularized flap and make a surgery bigger one. Yeah.
Because in cribriform, what happens, like just like if for the ease of maneuvering this graft material, once we seal, whether it is fat or something like that, what I feel is we can get the anterior end of the turbinate and repose it back. Like that's what I meant. Not necessarily it should be the mucosal flap from the turbinate. You cut the anterior part, do the work there, seal it perfectly and comfortably, then repose the turbinate back. Like once we go in the post-operative period and we see it, it looks normal, like that, like absolutely perfect. Any inputs and any comments, like Dr. Gagandev? Probably.
Yes, we've done that before. Just to carry on from what Dr. Shanbag was saying, sometimes lateral lamella, you may have to cut the anterior portion of the middle turbinate just to localize the leak. And sometimes the leak may be very small, but we don't use a flap for small leaks. We only use it for large leaks. And what we do after that is just exactly what you said. We reposition the turbinate, and you see the patient 6 weeks later, it heals so well. You can't even tell. So that's what we feel. So we always reposition the turbinate back, the anterior part.
That's what. Okay. Any inputs, Dr. Pradeep?
Same thing. Middle turbinate we can cut and either keep it back, reposition back over there, or sometimes what I do, especially in the cribriform leaks, I wedge the cut middle turbinate towards the leak area.
Yeah.
So that can get fibrosed and sealed.
Okay.
This is other than the fascia, fascia or the fat I have put. So after that, the middle turbinate goes to that space and retained with the Surgicel and gel foam.
So as Nishad said, like it's locating, exposing, and the preparation of the bed, which is more important, along with the graft material. I would like to stress on, like because like the mucosa underneath the graft material, definitely it is not going to allow the graft to take up. So preparation of the bed is also very important, and like it is also like one of the most important thing. It is site dependent. Like sir, like when there is no chance for preparation of the bed, there is no scope, like there is no space for the bed. Like how you move about?
In which situation?
Cribriform, sir. Exactly.
No, but why will there not be space for the bed to prepare the bed?
So like if it is like horizontal lamella where there is a septum, just septum, like you, would you like to prepare the mucosa over the septum or something like that?
You're talking of a medial cribriform leak?
Yeah, exactly, sir.
So medial cribriform leak, very gently you need to lateralize both middle and superior turbinates. And if you do that gently, you always create space. If you have a deviated septum, you may need to correct that to get access or get easy visibility. You then need to take some mucosa off both sides, of the septum side and the turbinate side. The additional thing I do is also to enlarge the sphenoid ostium a bit, because I don't want a glue or my fascia slipping and blocking the sphenoid sinus. But I have not found a problem. If you need to be a little patient and gentle with your patties, and you always get the space.
So one more thing, what we find usually is like when we'll be cauterizing the mucosa or preparing the bed, like we find that the leak site gets enlarged, it becomes a little more bigger. So what is your experience in that? Like that's what I find most of the times. Your comments, sir, your comments on that.
Usually with the medial cribriform, these leaks are very small, and once you cauterize, the leak should stop. And if the leak stops, I'm very happy to just put, as Pradeep mentioned, just a fascia. Then I don't want to fat plug it, because to put a fat plug in, you have to open the dura again and put it intradural. So I know Gagandeep prefers to do that. I know PJ Wormhole prefers to do that. But if I have a closed dura, which should normally happen with a medial cribriform, I just put a fascia. If it enlarges or if it becomes bigger or if it's still an active leak, I will fat plug it.
Any comments from anyone?
Like sir was saying, the moment you do a bipolar there, the leak, the pseudomeningocele shrinks and then it stops leaking most of the time. And all you need, like sir said, is one layer, one good layer, and fat or fascia, and then only if there is a high septal deviation on the same side, you might need a septal correction to be able to reach that area. Other than that, with packing with well-soaked adrenaline patties, we always manage to make a nice tent, nice U kind of an area there, wherein you can work and reduce the area of the leak.
Yeah, I think the keyword is, like Dr. Nishit Shah said, patience. If there's a septal issue, you correct the septum, and you just pack it and wait. Eventually, you'll get that space.
Fantastic. Good. So next slide. So what is the method you usually do in your cases? Like that all depends on the size, site, and any comments on the different methods like you have come across? Like I want your input regarding this bath plug technique, overlay, underlay, gasket technique. Lot of debate is on that. Like what is your way of closing? Preference, like what is your way of closing the seal? Your preference, Dr. Gagandeep?
So from my center, most of the repairs are bath plug. We just plug it with fat and we put a layer of Surgicel on top, with or without Duraseal. We use Duraseal or Teseal. If it's a large, especially we're doing large transplanum work, and then we use Haddad flap as an additional support. And generally, it works very well for us.
Okay. Dr. Shanbag, sir?
The same thing. I hope when we say bath plug, we don't mean what Dr. PJ Wormhole does, the earlobe fat and all. I don't do that. I find it a bit cumbersome, probably. The same thing. Half the fat should be inside the bony defect, half should be outside so that there's adequate pressure. The second is the first, whatever material we have used should close the leak. And then additionally, depending on the pressure and the site and the size of the leak, we use different materials. Larger leaks, of course, gasket seal. I try to keep it only a few options rather than trying to do multiple things. These are the only things I do.
Like the type of leak, whether it is high flow or low flow leak, does it alter the way of your sealing?
Yeah, that's what I meant. If it's a larger leak or a high pressure leak, the amount of reinforcement we need will be a little more. Of course, in those high pressure leaks, we have to also look at the reason for the high pressure. And there have been two instances where I asked the neurosurgeons to do a thecoperitoneal shunt, because it's not only the closure of the leak at the site of leak that matters. It's the reason behind the leak. If it's a very high pressure leak, then again we'll be creating more problems. So I also believe in diverting the CSF. So I want to know from others.
One more thing, in high pressure leaks, the leak side, the repaired leak side may not leak, but in the future, the other sides may leak. The bone gets
True.
weakened,
Very true.
so
Very
other
true.
sides may leak. The other side of the cribriform plate, that may leak. So doing a TP shunt or no TP shunt, you should decide at the time when you see the patient itself. That's what I feel.
Exactly. So when the patient, there have been instances when the patient has come in for a second surgery. They have been operated once for CSF leak, had a re-leak. That is when we normally counsel the patient for a shunt procedure also simultaneously. When the patient leaks for the second time, that's when the neurosurgeon and the team, we would counsel them for a repair as well as a thecoperitoneal shunt.
That's right.
Dr. Nishit, your experience with shunt?
So what I would say is small active leak, bath plug with or without fascia. Small leak which is closed with bipolar, only fascia. Large defect like a ethmoid fovea defect, I would use a cartilage with fascia or flap. Lateral sphenoid, fat plug with fascia usually, because a contralateral flap is too much effort to reach there. And for skull base, large defects, a bone with dura, fat plug with flap.
Which bone do you use, sir?
Bone in reconstruction.
Yeah.
For skull base surgery, we have three options. You have the bony septum, which you take out as a large piece. You have the anterior wall of sphenoid, the rostrum piece also, which we try and take out as a large piece. You have the intersphenoid septum, which you can take as a large piece. If you've done a full Haddad, you can also have access to cartilage in front. Usually, we don't cut the middle turbinate, so we don't touch that bone, but one of these bones. We are going less and less with bone and cartilage for skull base. We are going more with duragen and flap nowadays.
What about TP shunt? How many times you felt the need for a shunt procedure for spontaneous CSF leaks?
Not common. We have had patients whose pressures have been like 40 and over. And those patients we have considered if either they have failed or have persistent headaches, or for whatever reason are very concerned about future leaks. But it's not common at all.
Okay.
All right.
Okay. Next slide. I would like to know, it's being given in the literature and proved, endoscopic CSF leak repair is the best one, and the outcomes are really good. What is your experience? Was there any incidents where you did an open approach, like along with neurosurgeons? I would like to know from you. Dr. Shah, sir?
I think they're all on the panel because we like endoscopic CSF repair. So we're not going to say anything bad about it. The one time where I think I might go in favor of transcranial repairs are with frontal sinus defects in a well-pneumatized frontal sinus. I think it's just a much easier surgery, and the follow-up is very quick and the patient's out without having to do a lot of follow-up if you've done a big draft procedure or done additional holes. So that's the one time. If you've had multiple large defects following trauma, I would probably say go with transcranial surgery.
Carpeting kind of thing. Okay, sir. Like any inputs from anyone?
Yeah, I agree. I think from our side, it's mainly multiple sites, multiple defects, post-trauma. We just had a case about 2 months ago. So, posterior table of the frontal sinus, sphenoid, the roof of the ethmoid. So many sites. So the neurosurgeons just went in transcranial and they did a pericranial flap, and that resolved the problem. So I think from our side, multiple sites and multiple defects, it's better to come with the neurosurgeons.
Yeah.
Okay. That's what is there in the literature. Like most of the times we'll get away with endoscopic procedures, whereas in multiple leaks where we are not able to find the site, and like we're in revision cases or failed cases, probably as Dr. Shaz has said, like probably the open approach and carpeting can be considered. The next slide. The complications in the post-op period, like what is your experience? Dr. Shanbag, sir?
I have not had very serious complications in my experience. So I think others can talk more about it.
Yeah. Anybody would like to give their inputs regarding the complications?
Thrusting and other things are common. I don't know if they can be considered as a complication.
No.
I suppose one of the things that we should do in practice is just to talk to the patients, especially if you're dealing with the cribriform area, is the issues with hyposmia or olfaction issues. I think some patients they don't expect. So when you counsel them for surgery regarding anything like that, anosmia is something, or hyposmia is something that we need to talk about. Pneumocephalus invariably may happen. If it's very large, then of course we need to deal with that. We rarely have cases with meningitis because we are quite aggressive with our prophylactic antibiotics. So meningitis is not very common as compared to what the literature would suggest. Yeah, but anosmia is something that we should just be aware of.
Any inputs from anyone?
Yeah, I think you must counsel the patient about anosmia. And that's probably one of the reasons why when you see a potential site on the opposite side, not the active side of a cribriform, then you have to really think about it whether you want to repair that side or not. Because to give a complete anosmia to the patient for a potential leak in future is something you need to discuss with the patient. And I would tend not to do it, to see if the patient leaked in future, maybe then to do it instead of rushing in and doing a bilateral cribriform leak. One of the issues with pneumocaph, and this we have seen, is when people try and do conservative management for a spontaneous leak, like using a lumbar drain. That's really a contraindication. You should never use a lumbar drain for a spontaneous thing, right? We do have sometimes these issues with large skull-based tumors of meningitis and pneumocaph, but that is not unexpected when you're dealing with large tumors, large intradural things. But regular CSF, I think, Raghunath, you mentioned crusting. It's not a minor complication.
Okay.
Because these patients, you are not doing proper nasal douching. You are being a little careful about cleaning the nose in that area of repair.
Yeah.
So, and then you have infection in that area of your graft.
Yes.
So it is something that I would not treat as a minor complication. I would treat it as a significant complication.
Yeah. I mean, it's more of a sequelae which happens quite often after our CSF lead repairs, or it's not.
Fortunately, it's not often, but I would
I guess in your case, true.
With antibiotics,
Yes, sir. That's right. Yeah. Pneumocephalus reminds me of one patient who came 1 year after trauma. There was a posterior table, frontal sinus posterior table fracture, which had leaked and stopped 1 year ago when the patient was admitted in our hospital. After 1 year, he came with severe headaches and an active leak. There was a leak, and there was a pneumocephalus. And I thought of telling this that eyebrow incision to enter into the posterior table is what we have used. I just wanted to know from others, do you justify that? Just an eyebrow incision, make a small hole, open into the frontal, use an endoscope, close it.
Yeah, that's something that we do as well, because it's you can directly access the posterior table or the frontal sinus that way. And because it's open, sometimes to repair, it's easier, especially if the fracture is comminuted. If it's just a single line fracture, if you can access it endoscopically, yes, but that brow incision is something that's very, very handy to have in your armory of.
It was a simple one fracture chip which we could manage.
Any comments on orbital transposition to reach the lateral aspect of the posterior table of the frontal sinus? Can we manage the defect? Any inputs regarding that?
I think Dr. Mali Patil himself can talk about it. He has done a case recently.
Any experience from Dr. Gagandev?
No, we have not seen it, at least, or not done it myself. So we don't do orbital transposition. Normally we just come from the front, open.
Okay. So Shah sir,
it's possible to do it, but it's a lot of work and effort when you have a simple bicoronal pericutaneal flap.
Yes, sir. Yes, sir. Exactly. Okay.
So if the patient is a young person, is very bothered about cosmesis, insists absolutely on endoscopic repair, then I would do it. But given that it's still in a very pneumatized frontal, it's still a very big challenge.
Very true. I agree with that. Any inputs? Any inputs from any other panelists? Okay. And next slide. So we have some case scenarios this slide is followed by the surgery, the way I managed. And the first case is this is a pituitary macroadenoma with suprasellar extension. While suctioning the tumor, the CSF leak starts at 12 o'clock. My question to all the panelists is, what is your graft material of choice to close? Whether you close it immediately or after the disease clearance. The next thing is precautions to prevent CSF leak in these kind of cases. So, Dr. Shah, sir?
So I don't think it matters whether doing pituitary or FES or whatever. I mean, you have to clear disease first. That is your primary objective of surgery, and the CSF does not stop you from doing that. So you finish your surgery, clear all the disease. Then you look at the size and the extent of the defect. If it's a small defect, you just fat plug it and maybe put a bit of fascia. If it's a large defect, I would put in a flap. Precautions to prevent it. Generally, for pituitary, we do what is called a U incision, and we elevate the flap upward. Because that 12 o'clock area at the cistern is the commonest area for CSF leaks, just with little bit of stretching or little rough use of curetting. So we find that doing this U incision and elevating the dural flap works well. And of course, in that area, you have to be a little gentle with your instrumentation. But no question that you finish the tumor removal first.
Yes, sir. For the next slide, video, please.
Okay.
It's actually dangerous to try and do the closure without doing the tumor removal.
That's true, sir. Yeah. I agree with that.
Sir, if there is a leak during surgery itself, I would use a long tailed packet there with one hand, put pressure with a pack, and with the other hand, continue the instrumentation, try and remove as much disease as possible. The leak can technically happen anywhere. Once you have seen the arachnoid, which starts bulging into the cavity, you would definitely take little more care to kind of use the soft tip instruments. You can use the soft tip suctions, and you might not want to use curettes. But nevertheless, when the leak happens, we can still continue the surgery by using a Surgicel gel form, and then you can have a tailed patty on top of it, and still continue dissection and clear the disease.
Okay. Anyone uses a lumbar drain as a preemptive measure before doing a pituitary or any surgery to prevent the arachnoid from falling?
Some neurosurgeons use it, some don't. So one of the neurosurgeons uses a lumbar drain for two purposes. One is when the arachnoid bulges out, so you drain some CSF so that the arachnoid goes back, and then that injury can be prevented while suctioning. One thing. So that is one advantage you have when there is a lumbar pre-operative lumbar drain. That is just before the surgery they insert it, and after 2 days they're good.
Yes, sir. So even one of my neuro colleagues likes to use a lumbar drain preoperatively, pre-surgically, because when there's a large cellular supracellular lesion and you're anticipating a leak, they may we do the lumbar drain, but we don't activate it. At the end of surgery, when there is a large, if there is no opening or rent in the arachnoid, then the arachnoid starts bulging into the sphenoid sinus. Then you might want to activate the drain and remove a little bit of CSF. Then the arachnoid recedes. Then the packing will be easier. So there are certain neurosurgeons who like to have a lumbar drain in place before we start surgery, but we may choose to activate it only if necessary.
But what would be the right thing to do? I mean, Dr. Nashid Shah, Dr. Gagandi.
In my center, we don't use a lumbar drain routinely. It's only in certain situations where we feel that we may need to have some control of the CSF, we do it, but it's very rare. Maybe 1 in 100 cases, we probably use a lumbar drain. So not common from our side.
Yeah, I agree. We don't use lumbar drains often, but if we feel that we have a pathology with potentially a very large dural defect, like a meningioma, we may choose to go in with a lumbar drain pre-op. One of my neurosurgeons actually had this belief that put in a lumbar drain and start draining the CSF a little bit so that the diaphragm rises and your chance of getting a CSF leak is less. But practically, at least with him, I don't think it worked very well. Why, I don't know. But out of the
Also, the drain gets blocked.
CSF leaks.
Yeah, and also the CSF, the lumbar drain gets blocked. It's messy and a lot of problems arise. So that's what I'm facing.
That's post-op you're talking.
No, on table itself with the drain positioning, and they open and close, and sometimes it doesn't flow when they're trying to open.
Practically, it's more tedious and difficult, right?
Yes,
Should not
I
happen
do feel.
normally.
Yeah, it also depends on
Normally
what
that should
stage
not
of.
happen.
Yeah, it depends on what stage of learning curve the team is.
You know, when we started doing pituitaries in the early 2000s, we were using lumbar drain a lot. And that time we were actually pushing air through the lumbar drain to push the supracellular part of the pituitary down. So the tumor would just come poop into the cellar and out. And it sometimes it worked really well. But when it didn't, then parts of the dura came down which we didn't want and trapped the tumor. So we stopped using it. But in those early days, we did use it often. Almost all our patients got lumbar drains in those days. But I think in the last 10 years, it's become less and less and almost not very common now.
So
Is there
I
a
want to
disturbance
add.
in the audio only for me, or everybody is getting it?
There is a buzz in the background.
Yeah, there is a noise.
Yeah.
One more point I would like to add, like regarding the precautions to prevent the proper exposure. If in case of supracellular, like the exposure has to be really good. So like that will allow us to be careful and prevent a lot more complications in relation to CSF leaks. Can we go to the next slides?
Yeah.
This is a video. Hope it works. It is a this is a case of microadenoma with supracellular extension, and this is a dural incision which is being put. The exposure has to be really good, big and wide. This is the almost the entire tumor has popped out, and during the clearance of the tumor, hope the video is clear.
Yeah, it's clear.
Yeah. So there was a washout sign, and while checking for the leak site, it started. Probably that is the area where most commonly we see the leak. And the rent was small, and it was plugged with the pad. And one more thing I want to ask, like in all these cases, would you like to raise the Haddad flap, or like in cases of where the tumor is going in for supracellular area, like there you want to raise? Like, what is your take on this raising the Haddad flap in pituitary macroadenomas? Like Sushin, Dr. Sushin?
So in all supracellular lesions, we always keep the Hadad flap raised and ready. When it's a cellular lesion, then we keep it as a standby. We may not raise the flap, so we'll just elevate, keep it as a rescue, and then only use the full flap only if necessary.
Yeah. So like any inputs from?
I think we all agree with that.
I agree with what he said. That's what we do as well.
I think we tend to use rescue flaps. We tend to use rescue flaps most of the time. If it's an invasive pituitary which is gone intradural, or we are doing an extended in the sense of a transplanar approach, only then in those cases we'll take an Hadad at the beginning of surgery. Otherwise, you would just do a rescue.
This is a Hadad flap which we raised in view of the supracellular extension, and probably it comes for help in case of CSF leaks in this kind of situations. Can we go to the next slide?
Yeah.
The case 2, it is a lateral lamellar leak with pseudomeningocele. Steps of management and regarding the use of fibrin glue, is it a must? Or like precautions regarding the artery and graft sealing, Dr. Pradeep?
Pseudomeningocele, fibrin glue, I don't think it's a must. Routine materials what we use, it works well. Put a patterned fascia and maybe a flap if the defect is big. And precautions, obviously, yes. Anterior artery or to visualize, and the frontal sinus drainage also. So glue, in this one, it depends. Like I don't use much of glue. Only the neurosurgeon insists to put glue, you put glue. Otherwise, I don't think it's of much help.
Dr. Gagandeep, your inputs?
Yeah, I think with glue, I think when we first start repairing, we're always so worried, so we tend to use a lot of glue. I think when you start getting a bit more experience, then you are more confident to not use glue. So we don't use glue all the time, but there are some situations where you feel the flow is high or you just want a bit of extra reinforcement, we would use glue. I think anterior ethmoidal artery is very important to look at the scan before, so you know where it is, whether it's in the mesentery, whether it's up in the skull base. That helps us definitely. And so yeah, most of the time we don't, but of course, if the anterior ethmoidal artery is there in the way, then you need to address that as well.
Go for the video. Any inputs, Dr. Shanbag sir?
Yeah, I'm fine. I think when we started repairing, we didn't have tissue glue. Now we have it. So sometimes that also.
Sir, our patients are very poor.
No, I understand.
Yeah.
In every given situation.
A video is not running?
Yeah. It's not running. And the audio disturbance, I don't know, is everybody else feeling it or I'm the only one?
Yeah. There is some audio disturbance.
And you guys don't seem to be disturbed at all. I'm the one who is struggling here.
Your hearing is better than ours.
I can't tolerate this noise.
Third video, sir.
Sorry?
Second or third video, shall I play?
Yeah. Okay, you can go for the next video, no problem. No problem. What I did in that is the pseudomeningocele was reduced and the bed was properly prepared, and we used the crushed muscle with the fascia. I tend to use a lot of materials, try many things. This is a thing which I learned from Dr. Madhusudan from Trustwell Hospital, where he uses this crushed muscle with the fascia. That can be a very good sealing material, because when we crush the muscle, according to them, it releases some fibrin content, so that acts as a very good sealant. That's what I wanted to show you. That's what it was slightly different.
Neurosurgeons are very much used to using crushed muscle.
Okay, fine, no problem. It's another case of malignant melanoma of the nasal cavity abutting cribriform plate, intraop CSF leak while a disease clearance. It has to be, because it was abutting. There was no compromise on disease clearance. And like how you plan to reconstruct in these kind of things, because it's a malignant case, and what alternative for local flaps, because as all the tissues are involved in the disease. And the last is like post-op RT, like and CSF link, any relation regarding that, your inputs, Dr. Sushil?
Sir, in the case of malignancies, and when we're looking to do post-surgical radiation, definitely it makes sense to use multi-layer closure with also pedicle flap. Your vascularity is always better. Having said that, I have not encountered any kind of leak post-radiation therapy.
Okay. Any inputs? Nishit sir?
Yeah, I think in this case, probably you have also removed the turbinates and you have a bigger defect. You're thinking of post-op radiation, I would go with the flap.
Okay. Okay. So the video, can we run the video? So they are very huge files, I suppose. Like
1 minute.
Yeah, yeah. So
next time, Sharanu, keep the control with you. It's easier because you can fast forward, play, pause. Yeah.
Exactly, sir. True. That's a area like where the CSF leak started. It is a cribriform area. Yeah.
This is after tumor removal.
Yeah, sir. Like during the procedure. Yeah. So like I thought the leak is very small and tried to cauterize, and in fact the leak has become big, and like there was a huge bony defect. And when I palpated, when I did suctioning, there was a huge bony defect. Probably that was involved in the disease, and I had to take out all that. And then posterior ethmoidal artery was there. It was bleeding just by the side. Like that is the area where that posterior ethmoidal artery I had to cauterize, and bleeding was there. And then later I went in for reconstruction.
Aman.
And one more point I want to put, like in these kind of situations, would you like to tuck the graft material into the space between the lateral lamella and the horizontal lamella, like where the defect is there? Any inputs on that, sir? Like, so once the fat is being put, I use the fascia lata. So that is the fascia lata which is being taken. And once the fat plug is put, this is the fascia lata which is being put there. And as sir rightly pointed out, all the sinuses both the frontal sinuses are wide open there. You can see it is not in the way. It is putting a carpet-like thing. And then because there was no choice for me to use the local flap, just I used that fascia lata and hope for the best. Like post-op radiotherapy, we have to wait and see whether they will leak or not. Any input on this, sir? Like any comment? Like anybody would like to do this case in a different way? Any inputs?
If there is no flap, then we use fascia lata if it's a large defect. So if we know that there's a defect and we know that we probably get a less chance, then even before we start surgery, we counsel the patient that we may harvest the fascia lata and we prep the patient. And the moment we clear everything, we repair with fascia lata and fat as well.
Okay. Any flaps, sir? Like what are the other flaps that we can use in these kind of situations, sir? Like Nishit, sir?
So your reserve flaps are optional with middle turbinate. If it is not involved with melanoma, it's a bit dicey because you get skip lesions and a lot of the parts of the nose may be affected. A lateral nasal wall flap is a little difficult to raise, but if you're good at that, and you should be, it provides a good option. when you're using a lateral nasal wall flap for a cribriform defect, it has to be anterior based, not posterior based. So it'll be based on the anterior ethmoid and swung and disconnected posteriorly, as against using it for a sphenoid lesion, for example. So it's versatile. It can be bigger or as big as your Haddad flap, and it can swing up and close this defect easily. Lateral nasal wall.
Charanu sir, you are on mute. Charanu sir.
Yeah.
Fine. I got it back. This is the case 4. This is a spontaneous cribriform leak with a large defect at the horizontal lamella. Middle terminate, that's what it's already being discussed. Would you like to save or resect or middle terminate flap here? Like multi-layer closure or reinforcing? Graft material, whether you use it as a free middle terminate mucosa or pedicled nasoseptal flaps. Like any comment on this? Huge defects in the cribriform area. That is spontaneous leak.
What is the size of the leak?
Probably it is more than 1 centimeter. 1 centimeter. 1 centimeter defect was there. Bony defect was there. Dr. Pradeep?
So 1 centimeter bony defect, usually use fascia, patent fascia, and then maybe a flap. Middle turbinate flap, yes, I've used middle turbinate flap after resecting the middle turbinate and elevating the mucosa.
Hello? Hello? Go for the video. Yeah. So the middle turbinate is being resected. So you can see that is a leak. And what I feel here is like once you locate preparation of the bed and like undermining, as Nishit sir was telling, finding the margins was more important. I used temporalis fascia here. As the first layer, I used temporalis fascia and it is used as underlay, cut everywhere around the bony margins. And then followed by that, I used cartilage. This is the first layer. First layer has to be very perfect, as everyone said. And then once that is done, then this is the cartilage, the sliced cartilage I was trying to push into. Slowly it is manured. So once that is done, then again third layer I used fascia. I don't know, like it was my earlier days. Like I wanted to be very careful. I wanted to do the multi-layer very perfectly. This is the third layer again. The fascia was being put and like tucked in. And this is the free mucosal flap. Like at the time I resected the middle terminate, I used the mucosa of the middle terminate to close that, to put over that, and then Surgicel followed by gel foam. Sir, any comments on this?
So I liked your first two steps of the fascia and the cartilage, or you could have put fat and cartilage. But then I think that the next fascia should have been just a plain simple overlay.
Yeah.
Because then you're moving the cartilage from sitting nicely. But
yeah,
I would have gone with what Pradeep said. You know, I would not have cut the turbinate. I would have taken a turbinate flap, just taken the bony part out, and then try to rotate the flap, the turbinate flap, as the overlay layer after you put the cartilage.
True, sir. True, sir. This was me before going to.
But I'm sure that, you know, even the same patient, if I do it on 3 different days, I'll do it 3 different ways.
True,
so
sir, right.
It's not maths. It's sometimes it's just what your mood is for that day, or what you think will work better for that day. And I'm sure if you ask everybody, they will all say a different way to do it.
Yeah.
Exactly.
Yeah.
Any thoughts from anyone?
Yeah, I think that's the same. I think I agree with Dr. Nishit Shah, because sometimes you may have the same defect in a different day, you may repair it differently.
Yeah.
So I echo that completely.
Yeah. So the next slide. Next slide. Next slide. Okay. This is a horizontal plate. Entire length was defective. I don't know. The patient had a trauma, past history of trauma. But when we saw the entire cribriform horizontal plate defect, and like discussed, directly I want you to go for the video. Yeah. So you can see in the video, this is a horizontal part. Like you can see the entire length is gone, entire cribriform. So there, like again, I used the fascia, cartilage, and then the pedicle graft. Like I handled it from the septum. Any comment on that? Anyone?
Medical graph. Medical graph from where?
Small upper part of the septum. You can use it, right? Like yeah. Any comment? Not necessarily a conventional hada kind of flap. Like because we are the septum is near and the horizontal plate is near, and like we can take a small incision in the upper part and rotate posterior based flap and rotate it. Any comment on that? That's what I did.
Yes, sir. This is the flap which our neurosurgeons like. They want some blood supply somewhere coming from. I mean, even if it's a random thing, so this is what they like, and definitely it's a good idea to reinforce.
Okay.
Yeah. In this situation, it doesn't matter because you're going to lose olfaction anyway.
Okay. Very true. The posterior ethmoid. It was at the anterior wall of the ethmoid roof. It was a high fluid thing, and the graft material again. It is being discussed, and the method. Like I did the gasket method. Just I believe in trying all these things, different things. Video, please. Yeah. So it was done at other center. That was a junction of the anterior wall of the sphenoid and the ethmoid. Small communicosing. It was a high pressure leak. What I thought is like I had to reinforce. I used gasket method by I used the cartilage as well. Recording facility was not there. This is shot with a mobile camera. Okay. Just let us go to the next slide. Once it's being closed. Next slide. Yeah, that is the gasket sealing. I used the facial lata, the first layer, and it was spreading over the margins of the that's the cartilage in the middle, and fascia looks spread nicely margins of the lake. Any thoughts from anyone? Hello?
You know, for me in this situation, I would have probably gone with a bath, probably an easier thing. Having said that, there is a difference between a fat plug and a bath plug. And a bath plug is far more secure than just a fat plug. And I think I would let Gagandeep explain to you why and how the bath plug works better than just a fat plug.
Yeah, the bath plug definitely has a better seal, and because it just, if you can imagine literally what it takes its name from, a bath plug, so no water escapes, and because it's sort of when it sits with the pressure, so it's tight. Well, sometimes with a fat plug, it's not going to be tight. So you can imagine, especially fat is very malleable. Any change in pressure a fat is more susceptible to leak. Whereas with a bath plug, because it's sitting with pressure, it's unlikely to cause more problems. So generally with high flow leaks, we always prefer to use a bath plug closure method compared to a fat plug.
Dr. Gagan, do you mean to say the bath plug, when you say bath plug, what is propagated by PJ Wormhard? The
Yes,
earlobe
correct.
fat with the thread going through it?
Yes, correct.
So it doesn't have to be earlobe. It can be any fat.
Yeah, I understand that. But the thread going through it?
Thread has to go through that.
Yeah.
That's the whole trick of the bath plug.
Yes. Absolutely. We use, in our center, we use abdominal fat. Malaysia is a very prosperous country in terms of abdominal fat. So we've got a lot of abdominal fat in our patients. So you normally take abdominal fat.
So I want to see you this video. This is taken from Dr. Shanbag, sir. Thank you very much, sir, for sharing this video. Just
Basically, we are talking about high pressure leaks.
Just you only have to tell, sir, how you manage this thing.
Yeah. The other panelists can tell me in this kind of a situation on table. Dr. Nishit, sir?
Well, I would put a manometer in first and check the pressure actually, what it is.
Do all of you have access to manometer? The others also?
Yeah, it's a very simple instrument. I mean, it's like 100, 200 rupees. It's just a simple glass tube.
Yeah,
no big
the
deal.
vertical tube.
You now get digital manometers, which are a little fancier, but even easier to use than the big glass globes.
Yeah, I would go for that.
But if it is like 35 or above, what one would expect with this, I would put in a lumbar drain, but I would keep it closed till I have done my CSF repair.
Yeah.
Because I want to see that CSF leak and I want to be sure that my repair is strong enough to close even a strong leak like this. After I've closed it, I have the option of then using a lumbar drain for a day or two, but not more. If that lumbar drain does not work properly, it comes out. Because a non-functioning lumbar drain is a source for meningitis. So it must not be kept.
Right. In my case, this is the neurosurgeon doing it, and he went ahead with a TP shunt. And the leak was in the lateral wall of the sphenoid. I did place, I could not locate a single leak there. It was very difficult for me. And we went ahead, I did my closure with the onlay big flap, and the neurosurgeon went ahead with a TP shunt. It's been 3 years. Patient is in follow-up and doing fine.
What
with
was
the
the
lateral, with the lateral sphenoid, actually, I would not do a shunt for sure, because I can put in cartilage and do a really strong repair there.
Yes, yes.
I'm sorry, guys, but I think we were supposed to end at 6:30, and I have a different engagement at 7. So I'm going to run in 3-4 minutes if you all will give me permission.
Yeah, we will
I'll do
not
one
leave
slide
till
and-
we get all the information from you.
Sir, Sharanvalli Patil sir, you are on mute. Sharanvalli Patil sir, you are on mute.
Okay. The last slide, how to avoid iatrogenic CSF leaks. Next slide. Your views, Dr. Pradeep?
Hydrogenic CSF leaks, maybe in the initial days you will get, but later, yes, in tumors, yes, obviously it can happen. Routine FES, maybe in the initial days.
Sir, you please mute.
Hello?
Can you hear me?
Lot of disturbance in the...
Tremendous disturbance.
It's because of this issue of Sharanvalli Patil sir.
No, but last half an hour, it's...
I think now it's gone.
Yeah, because Sharan was on mute, I think.
Yeah.
Yeah.
Are you getting any audio disturbance now?
Yeah,
Now, no, sir.
The it's continuous.
Okay.
Sir, Vishwas here. That audio
Can I-
disturbance is from the fan or some wind running against the earphones.
No, it's so bad. It's
here.
all right. I think, is it the last slide? What is the plan, Dr. Sharnu?
Going to wind up.
Okay.
It's for new, like who are starting new and doing it. Any comment on the position? Like, was it position of the head while doing the surgery? Is misleading, isn't it?
Okay. Guys, just to say thank you to everyone, but I must run. Thank you,
Yeah.
Sharno. Very nice
Thank you.
panel. Enjoyed it. Thank you to all the panelists.
Thank you, Dr.
sir.
Nishit.
Thank you very much, sir.
And I'm sorry that the delegates have to run few minutes earlier, but please excuse me and thank you very much, everyone.
Thank you.
Thank you. Yeah.
You're on mute, sir.
Sharanu sir, you're on mute.
Yes. Any final word? Last word?
No, I'm waiting for an answer for this. I think, depending on the case, if it's not very much, most of the time, I think we would like to go in immediately and close it, but we need to talk to the patient relatives if we are going to do it in the same sitting. That's what I would think. And preoperative counseling matters a lot.
Like, my suggestion is like, as a surgeon, I want to be very comfortable, and the patient position has to be proper. Otherwise, end up doing a lot more harm than benefit to the patient. And we will end here. And we really enjoyed having you on the panel. It was really nice discussion. Mr. Basu, shall we conclude here? There are many more slides to, but most of the questions are covered. Most of the questions are answered. More slides are there. That's okay. It's already being covered. Shall we stop?
Yeah, I think these are all the theoretical aspects which we can always discuss.
Yeah, sir. What? That's why I kept all those things in the late part of the discussion.
Sir, there is a question here, if you can take that. It says, doctor from Visakhapatnam, he says, what is your experience of meningitis secondary to CT cystinogram?
Oh, yeah.
In Malaysia, we've not seen it, but we don't routinely do CT cysternograms. So we have had some bad adverse effects with allergies and adverse reactions to the contrast. But in terms of meningitis, no, we have not seen. But we don't do it as much as we used to compared to maybe 10 years ago or 8 years ago.
Yeah. Can I speak? I had one case after the CT cysternography. I think within hours, the patient developed severe headache and neck stiffness. We thought it's meningitis, but then the neurologist said it cannot happen within hours so fast. And it did turn out that there was no meningitis, bacterial meningitis was not there. It was probably a reaction to the iodine content in the contrast material. And funny thing is, of course, the patient was very upset. And the best part is the leak closed. She stopped leaking because of the inflammation. Yeah. I mean, later on also, I was in touch with the patient, and I don't know if on phone she told me a truth or the lie. She said, I'm fine now. But this is the reality, and this is what happens sometimes, that cysternography, CT cysternography, when you do a lumbar puncture and all that, it can be very painful for the patient because they lift the leg of the patient because the iodine material, contrast material, doesn't go into the basal cisterns very easily. CT cysternography is quite difficult for the patient.
Any other questions? Audience?
No more questions, sir. That was the only question.
Okay.
I should congratulate Dr. Mali Patil. Wonderful forum, wonderful, good questions, good discussion. All the panelists. I learned a lot.
Well done. Yeah, very well done.
Very well done.
Thank you so much.
Yeah. Thank you, Dr. Deepak Halipur, Trustwell, and everybody. The whole team.
Thanks for having me.
Microlabs.
Thank you, Gagandeep. Thank you, Micro, for giving us an opportunity to share our experience and share our knowledge. Thank you very much.
Thank you.
Thank you.
Our IT team is telling to, can we all mute, only person speaking unmute. That's what they're requesting us for the sound.
Yeah, I think that's why
Dr.
the
Vishwas sir
disturbance.
is there. Sir, over to you, sir. Vishwas sir. Vishwas sir, can you speak, sir? Give the closing comments before we close the session.
Yeah, thank you, Sharnu sir, Pradeep Usmani sir, and thanks sir, Raghunath Shanbhag sir, Nishiksha sir, Pradeep Usmani sir for making sure that the panel was so enlightening and exciting at the same time. And Dr. Gagandeep Singh from Malaysia for joining us at Indian time. A special thanks to all the audience who's been watching them. Close to 1,200 people were live and 600 people were sitting in the various physical audience across the medical colleges and corporate hospitals and hotels. It was really nice to know the case-based scenarios that Sharnu sir inculcated in the questionnaire, and amazing spread of knowledge in the last 1.5 hours that people still wanted to listen. There is still an audience clicking on. Probably 900 to 1,000 people are still there listening in to this. Congratulations to the entire team. Hope to see you all again. And signing off from Trustwell Hospital for today. Hope to see you all tomorrow at 9 o'clock in the morning. Manjula ma'am,
I have one announcement to make, sir, if you permit me. I would like to tell all the audience that there is a book available to you for download, which is a pocket-friendly atlas on temporal bone dissection. This book is available on the digital style. That is, when you log on to the platform, click on the instructional section, you will go into the stall where you can do the certificate course of instructional session. Plus, there are books available. One is the ENT book, other one is pocket-friendly atlas on temporal bone dissection. So if you go to the stall, you can see the initial part forward. If you want the book, kindly share your email and it will be delivered to you. So that's what I would like to tell everyone. Over to you, sir. Sorry, Vishwas sir.
Thank you to everybody. I think the final comment should be by Sharnu sir and Raghunath Shanbhag sir.
Yes.
Who are so gracefully sat down on a Saturday evening educating all of us.
So it was really nice being associated with you, Vishwas. Like I am there, like always for you, and Trustwell Dr. Deepak Halipur more so. And special thanks to Micro and the entire team. So good. And like literally, Bhaskar and his team really helped me in organizing like panel discussion event and uploading all this. It was really huge file. It really difficult. They helped me. And Dr. Shushin, Dr. Pradeep, Dr. Gagandeep, Dr. Shanbhag sir, Dr. Shah sir, all of you people. It was really nice being with you. And I believe in continuous learning. Learning never stops. Right? So with this note, I want to sign off. Thank you one and all.
Thank you. Thank you, sir.
Thank you very much for having us.
Thank you.
We should have more
everyone.
programs
Thank you,
like
sir.
this.
Thank you so much.
Ma'am, tomorrow's program we can update once so that everybody knows.
Yes, sir. Yeah. Dr. Krishna, can you share tomorrow's agenda, please? So tomorrow we have 2 panel discussion and 1 live surgery, but by Dr. Janki Raman sir. Dr.
Urvashi,
Krishna,
next slide, please. Agenda. Yeah.
Urvashi, are you sharing?
Oh, yes, ma'am. Just give me a second. Yes.
Yeah. So we have live surgery by our legend, none other than Dr. Janki Raman sir tomorrow, which is on rhinology and skull-based surgery. We are going to put the slide now. And there are 2 panel discussion. One is topic is papillary and follicular thyroid tumor by moderated by Dr. Bharti ma'am. And we have another topic, sudden SNHL and auditory spectrum disorder by Dr. Manoj. Manoj sir will be moderating the session. I'll just, I'm waiting for the slide.
What time do you start?
We are starting in the morning. As far as I know, there's slight difference, right? Morning, we will be having first panel discussion by 9 o'clock. Bharti madam will do, then followed by live surgery, then followed by another panel discussion.
Followed by
Right?
Manoj Manikot, sir. Sorry,
Okay.
ma'am. Sorry to interrupt.
Yes, sir. Please go ahead, sir. Yeah. You have
First,
the latest
Bharti
update.
madam will be Bharti ma'am will be doing the panel discussion from 9 to 10:30.
Yes.
And 10:30 we will be having Manoj Manikot sir and his team doing the panel discussion. At 12 o'clock, Jankiram sir will go live from Trichy and operate on 2 surgeries. Revision endoscopic Sternberg CSF leak and revision juvenile angiofibroma surgery. So we have all legends lined up for you tomorrow as well. So, and we are hoping that Sunday will be a bigger attendance. Today we have clocked an attendance of 2,200 plus people who attended the program. It has been a record of sorts for Micro Labs and all of us at the team here, the ENTrain team here. And congratulations to all of you also, ma'am. And thanks to the wonderful faculty and wonderful audience who have made it possible. It only goes to show what philosophy Deepak sir has put in place. That is the common ENT surgeries and common ENT topics to be discussed by experts. And in a format which is most convenient for everybody in a short duration. In fact, the highlights of today was a fest being done to start off in the most effective manner in 1 hour to understand all the basics, including the CT scan, revision, juvenile angiofibroma going intracranially with an explanation of CT scan getting over within 2.5 hours, 3 hours. Then excellent coablation work, adenoid and tonsillectomy in the most bloodless manner possible by Tushar Karthik Ghosh sir. And of course, a little bit of my teaching.
No, it was wonderful. Actually, I was keenly watching your surgery. I must say, I learned a lot. Fantastic demonstration by you.
Thank you, Raghunath sir. Thank you so much. So, and we have had this good panel which touched upon topics as wide as a neurosurgical or a neurological intervention to the pathological purview. So it was a good panel to be and to learn from. And I'm happy to say that you have had the maximum attendance here today with the graph climbing up towards the panel discussion. So we have just made a resolve that Saturday evening should be the next ENTrain program so that everybody gets their due of attendance.
Correct, that's true.
Yeah.
True.
Correct, sir.
True.
Thank you everybody. Hopefully we'll have a relaxed evening and see you all tomorrow morning.
Thank you so much, sir. Thank you, everyone. Thank you.